Check. Check, check. Check, check, 1, 2. Check, check.
So Prabhat, a very good morning and greetings from Pune. On behalf of the organizing committee, I welcome you all for this 13th AORA annual meeting. Learning is a continuous process and we always strive hard to sharpen our knowledge and perfect our skills. But in order to achieve it, we need teachers, mentors, and masters. This Congress is a blend of everything: didactic lectures, workshops, panel discussions, then various kinds of master classes. We have eminent faculty from India and from abroad, and they are going to cover a plethora of topics over 3 days. I'm sure this is going to be an intellectual feast and an enriching experience. Without wasting much of your time, I would welcome you all again, and I would request Dr. Neeta to take over the proceedings.
Thank you, Himanshu. So let's begin. I invite the chairpersons, Dr. Varshali Kenya and Dr. Sachin George, for moderating this session. Brachial plexus above the clavicle. Over to you, ma'am and sir.
Very good morning. I welcome all from AORA Pune. So the first session is brachial plexus above the clavicle. We'll start the session by a talk with eminent speaker, Dr. George Fiegel. I invite George Fiegel on the, I invite Dr. George Fiegel on the stage to deliver the lecture. Thank you.
Thank you, moderators. Good morning, everybody, and a warm welcome. I would specifically introduce George Fiegel because I had been with him in Graz for 7 days from 8 to 8 in the evening, and we used to do a lot of dissections and cross-sections and a lot of studies. Good news, George, I got a message in the morning that one of our article is published. So thank you very much, George.
Okay, thank you very much for the honor to speak over here. Just make also a little introduction tomorrow. because concerning 10 minutes of brachial plexus, it's like flying through it. It's not running through it. It's more rushing and flying. So I just want to give you a short introduction about that, not only concerning systematic anatomy, what you already know, but also topographic anatomy and cross-sectional anatomy. So concerning the brachial plexus, you know the segments where it's coming from C5 to TH1. You get the different stages, first of all, the ventral rami of the spinal nerves, then forming the trunks, the cords, and the nerves. This is very important because concerning these structures, you already know that you perform different block techniques in different anatomical regions. As you have for the segments, the ventral rami, the interscalene block, then you're going to the trunks, where you perform mainly on the superior and middle trunk, the so-called supraclavicular blocks, then going to, again, the cords, which is below the clavicle area, so the infraclavicular blocks, whatever is included over there. And then finally, you go in the axillary fossa, where you find the final nerve running. You do not need to know who or where the nerve fibers are going through or to and form, because this is something which is so of high variability that you mainly focus or have to focus on the nerve structure you see and you can identify with the ultrasound device. So it's a little bit like that. If you're going on a road and then it's going separately, you have different nerve fibers rising and going anywhere. So if you just take the anatomy and the variability of the brachial plexus, you have Abraham Kerr's investigation about 220 plexus being dissected, and he found 155 different variations. So that's what you saw, is just a systematic overview. Anyway, which is important to see a little bit more, the different areas. As you can see, these are now the ventral rami exiting over here and already being formed. The dorsal branch already has arisen and ran dorsally. And this is now an overview about the brachial plexus itself with the different areas, where you get the interscalene area, then the supraclavicular region, then you have over here the infraclavicular area. The first white line would be the clavicle area. The second white line would be the lesser pectoral muscle, which is a borderline in between the infraclavicular and the axillary fossa. And you can see quite easily that in the axillary fossa, the main nerves are really arising, are formed, and then running distally to innervate their areas of interest. So as you can see, just summarizing the interscalene gap with the interscalene block, the supraclavicular blocks, in the sulcus deltoidea pectoralis or deltoid pectoral groove, you find the infraclavicular blocks or the costoclavicular, for example, and the axillary block in the axillary fossa. So again, this would be now the area. And quite interestingly, you really have a small gap in between for your interscalene area and interscalene block. This you have to keep in mind, considering also the volume you use over there. The second one is, of course, supraclavicular, infraclavicular, and axillary fossa, a huge area where you have to take also into account the different fascial system. With the clavicle and the lesser pectoralis still in its topography, you see it's closing down. It's really getting more narrow and narrow, as you can see. And then if you just enlarge over here the area of the interscalene, you see the superior trunk being formed more laterally than the interscalene gap is. So the interscalene gap also enlarged. See, it's a small gap filled up with nerve fibers, as you will see in the next one, and then covered by a fascia, which is an important fascia called the prevertebral fascia, elevated in the second dissection over here, where you see the phrenic nerve just running ventrally off the anterior scalene, and then the brachial plexus just a little bit lateral and dorsally to it, located. the distance in between can be less than 2 millimeters, because in the cranial part, he's crossing just superficial to the superior trunk area or C5 segment. This is one of the very important cross-sections. As you can see, the anterior scalene, the middle scalene muscle, and over here, this is the superior trunk being formed with the prevertebral fascia covering the entire region, and also, let's say it like that, forming a wall for your local anesthetic being injected underneath. And this is a very strict wall, which will also get an unpreviewable spread if you use high volumes. An enlargement again, you see anterior scalene and middle scalene muscle. Watch out over here, these muscular bridges, which are frequently visible, frequently developed. Over here, really separating the superior trunk to the C7 ventral ramus, and over here the phrenic nerve, just close to it. Imagine now if your needle is being located over here and you inject 5 ml. Well, you get the phrenic for sure. That's it. So what you get over here in the posterior lateral cervical triangle, you get the superior and middle trunk. You will have some troubles with the inferior trunk. I will get to that tomorrow in my talk concerning the problems with the brachial plexus in this area. What you get over here are axillary and musculocutaneous median nerve, parts of the radial nerve, and also supraclavicular directed direct branches like the subclavius nerve and the thoracic longus maybe is posteriorly. Again, this is the supraclavicular region. Watch out also for different vascular structures. You see the suprascapular nerve arising as the first one, running a little bit more distally, very parallel to the clavicle and going laterally. So if we just enlarge this again, you see the omohyoid muscle, which is a very important structure and landmark in the ultrasound. You have the prevertebral fascia covering the entire space and also being this wall, which is important. So let's go infraclavicularly. We have the infraclavicular and the costoclavicular block, which is mainly going directly, also a very important block technique to reach the inferior trunk, which is a main trouble. You have this deltoid pectoral groove with a fascia, which is also a very important border in between the superficial and deep part. And in the deep part, you find then the nerve structures of the brachial plexus being positioned around the artery. The axillary artery or subclavian artery depends a little bit what you define. And in the deep, you see this fascia again, also vascular structures in the area. But what is important, if you just go to the next slide, which is a sagittal section with the clavicle, the subclavian vein, subclavian artery, the brachial plexus is really positioned a little bit cranial and dorsal to it. And this is one of the major points that the inferior trunk or the medial cord is really covering behind the artery, is located behind the artery. So if you advance your needle, regularly you get the lateral cord and the posterior cord, and the medial cord is strictly behind the artery at that moment, at that time. If you enlarge it, you also find a very important anatomy, which is over here, a fascial structure, which is really in between the lateral cord, the posterior cord, which are more cranially, and then the inferior cord, the medial cord, which is dorsal to the artery. First rib in this area is quite well visible. Yes, I know. Then, axillary fossa, that's the last one, so you already got it. You see the different nerve fibers rising, and then the important topography over there with a fascia which is covering entirely the neurovascular structures in this space. This is called the so-called deep axillary space, and you find the nerve structures and the artery in there. But it's not like that you just inject in this space and then it's going around everywhere you like to, like in the dissections being provided in the different textbooks. But more or less, when you get these, you have also fascial tunnels which are just surrounding the different nerves. And this is one of the major important informations I can give you, that if you inject, for example, to the median nerve, it does not run around. Okay, that was it. If you want to have more information about the brachial plexus, the special topography, the special fascial compartments, and so on, you have to come back tomorrow, because then I will talk a little bit more extensively about it, because 10 minutes is a little bit too less for that. Thank you very much for your attention.
Thank you. Thank you so much, Dr. George. We'll take the questions all together in the end. Now may I call upon Dr. Balavenkat Subramaniam to talk on how to make the endoscalene work with nerve stimulator. Over to Bala, sir.
Good morning to everyone, and it's indeed a delight and a pleasure to be back with the AORA family, an organization which stands for promoting literacy in regional anesthesia and safe practice of regional anesthesia across this country. Thank you, Sandeep, Divan, Mutta, and the entire team for the enormous efforts that you have taken to make this a possibility. When regional anesthesia grew, I think an anesthetist was directly branded if he is a good regional anesthetist or not based on one single block, and that was block above the clavicle. If you know to do it right, and if the surgeon is convinced that you are able to do it without offering any kind of sedation to your patient, he declares you as a good regional anesthetist. And does it mean that you need to have ultrasound all the time? The answer is yes, but the answer is no. If you have the ultrasound, it's good. But if you don't have an ultrasound, then you need to do it with a nerve stimulator. 80% of the population in the world, the anesthesia population in the world, even today do not have an access to ultrasound. Does it mean that you don't pass on the benefit of the beautiful anatomy that was described by Dr. George Fiegel to your patient? So here is a video on how to do this right. So that was beautifully described, and I would need the audio, Anand.
Approach to brachial plexus. I could say that the interscalene, finding out the interscalene groove almost is equal to defining a successful upper extremity block. All those who are able to define the interscalene groove correctly and place the local anesthetic solution in the groove will surely get a very successful block. How to identify the interscalene groove? Let me demonstrate this on a 50-year-old patient who has come with a fracture in the forearm. Now, if I could show you the anatomy, here you see the sternal notch. You see the sternal head of sternocleidomastoid. You're seeing the clavicular head of the sternocleidomastoid. Then this is the clavicle, and this is the head of the humerus. Now, what is more important is to identify the groove, and the way I do it is in relationship to the lateral head, the lateral border of the lateral head of the sternocleidomastoid. Now, to begin with, you have identified the sternal notch. If you just go up, you palpate the cricoid. And cricoid is at the level of C6. From the cricoid, you just bring your fingers back at the level of C6. And when you cross the lateral border of the lateral head or the clavicular head of the sternocleidomastoid, tell yourself that you have to go another 1 to 1.5 centimeter laterally. And then if you see that now I'm at a place which is roughly about 1 to 1.5 centimeter lateral to the lateral border of the sternocleidomastoid, and here I am palpating the apex of the scalene triangle, scalenus anticus medially, and the scalenus medius laterally. So I am at the apex. If I take out my finger, you can see the external jugular vein is crossing the apex of the scalene triangle. In 95% of the times, you always see the external jugular vein crossing the apex of the interscalene groove. So once again, I'm going to palpate. So now I'm palpating it more than once, I want to make 100% sure. I roll my finger so that I'm palpating the belly of the anticus and the belly of the medius. Having done that, the next thing I'm going to do is I'm going to stretch the skin slightly. Because it's a very labile skin over the interscalene groove, many people make a mistake if they don't make the skin taut there. When they introduce the needle also being blunt, there is a possibility that the needle doesn't enter the groove correctly. So now I have identified the groove, rolled my finger, made sure that I'm feeling both the anticus and medius. I have stretched the skin here. And the nerve stimulator that I'm going to use now is the Stimuplex DIG machine, which you can see there. This is the basic version. I've kept a milliamps of 1.5 milliamps in the peripheral nerve stimulator. Here you see the positive electrode, which is connected to an ECG electrode. The negative electrode is connected to the Stimuplex needle. So now, since the circuit is complete, I am palpating the apex of the scalene groove, and I'm just going to tell the patient, so I'm trying to introduce the needle into the... So now, as you see the contraction of pectoralis major, deltoid, biceps. I'm slowly decreasing from 1.5 milliamps to 1 milliamps, and 0.8, 0.74, 0.6, 0.5, 0.48. Now we'll aspirate, make sure there is no blood that is coming out, and inject the drug. Yeah. So now there is a free flow of the drug. The moment 1 cc of the drug went inside, the stimulation stopped, and this is called as the Raj test. The Raj test indicates that the tip of your needle is very close to the nerve that you want to block.
So this is one of the simplest way of doing the interscalene block. And when we do the workshops, a lot of people tell that in spite of doing the block appropriately, they didn't get adequate surgical anesthesia. So now, what is the reason? Number one, it is very crucial and important that you need to get more than one nerve supplying a motor unit. See, what happens is, because it's a blunt needle, and when you push it in the interscalene groove, though you got the groove right, when you push it, and it's a very, very superficial block, sometimes what happens, the way you applied pressure, it just bypasses the plexus, and you go more towards the nerve root. So sometimes you go and stimulate the C5 nerve root or C6 nerve root. Only the individual nerve root gets stimulated. And then you do get a motor response to that particular nerve root, but not the entire plexus. So you administer the entire drug there. If you're fortunate enough, the drug spreads to produce a complete plexus block, but if not, it just becomes a root block. And you will see it has taken partially. So I just want to make sure that you get the deltoid, you get the biceps. So you get more than one group of muscles contracting so that you know that it's in the plexus and it's not in the nerve root. That's point number one. Point number two is the mistake that is done is when you push the needle inside, you identified the groove rightly. But when you push the needle inside, the needle entered the space, the other triangle between the lateral border of the sternocleidomastoid and the scalenus anticus muscle. Many times here, you get a vigorous stimulation of the phrenic. And when you do the block, many times they keep the hand over the chest. So the diaphragm contracts, and there is a violent movement happening to the upper limb. And many people construe this as a motor response. And you see that the block completely fails. And the third mistake that is done is, when you insert the needle, you just went into the posterior side, which is lateral to the middle scalene muscle. And you have a vigorous contraction of muscles of latissimus dorsi. So you see a violent movement in the upper limb, but it is not deltoid, it is not biceps. So I just wanted all those who are still working with nerve stimulator to make sure that the end response, they carefully watch, and then they administer the drug. They will get an excellent block. The only other thing which I wanted to tell is, you may have to do adjunct blocks based on the surgical procedure, because the intercostobrachial nerve and supraclavicular nerves need to be blocked. The dermatomal level have to be blocked based on the surgical requirement. If you focus on these aspects, you can become very close to your surgeon in spite of not having an ultrasound, and he would continuously ask you to do a block because your block never fails. Ultrasound is not needed to give a successful block in few cases, and one such as interscalene. Thank you so much for your patient hearing.
Thank you, sir, for such a wonderful demonstration. I now invite upon Dr. Subramaniam for his next talk on ultrasound interscalene nerve fails. Never fails.
No, it's difficult to follow a master. He's my mentor, teacher, and friend. So I'll try to pitch in, add a bit more details. Over the last, let's say, 15, nearly 17 years, the ultrasound has become part of us. A lot of development has happened, and one such area where we can reliably see what is happening, and not only by our visual appreciation, but also the evidence what it says. Let's see. Sorry, I just went back to slide. Now, briefly, what I want to show is, see, a lot of things have happened. One is there is a comparison of ultrasound-guided blocks with nerve stimulator. Briefly see that there has been a slowly decrease in the volume of local anesthetic required for doing a block. That also there is evidence there. Whether should we be intraplexus or outside the plexus, does it make a difference? There is evidence for that. Decrease in the complications. We not only see the nerves now, we also starting to see structures around the nerve, identifying the neural elements, and there is also an incorporation of artificial intelligence nowadays now. And there's definitive guidelines has been given what to see and what not to see, what not to do. Now, Dr. Bala sir showed us how he positions. It's almost very similar when you do the ultrasound guided as well, wherein which a slightly head-up position is beneficial, pushes the diaphragm down. And while approaching, you always, Dr. Bala sir showed, you can call it as a straight approach or an out-of-plane approach or an in-plane approach. Now, when we do the scanning, again, Dr. Bala sir showed the level of the cricoid cartilage. You can do the same level, come from the midline, go laterally, or you can scan up or trace back method. So you can put the probe and go laterally from the center to lateral, or come from down and slowly scroll up to see where you want to do, where you're seeing the nerve plexus, where you're seeing the trunk. Now, when you put a probe, what we generally see is something like this, a lot of grays and whites. But not only, most of us can pinpoint, this is the nerve there, but it's very important to see all the structures around, identify them so that we don't injure them. Like, for example, in this case, you start from the center, identify the trachea, thyroid gland, all the muscles around it, the vessels around it, identify the muscles on either side of the plexus, and there you will see. So in that way, you can forget that part and focus more on the part which we want to see. Now, if we go zoom into that particular part, what we will see is something like this, where you can see the anterior scalene muscles, middle scalene muscles, and sandwiched between the two is the plexus. We used to call it a traffic light sun. It's no longer just the 3 lights there. You can see the plexus, the configuration of the plexus changes in each individual. Now, most of you are able to pinpoint your finger there and say, this is the plexus there. Now, how we go about is, see, what we want to do is we identify the plexus. Once you have identified, you want to put the local anesthetic not in the muscle, just next to the nerves, not inside the nerves. Now, you can either do it in plane or out of plane. We used to do it out of plane, but now we have found that it is in plane is much more reliable, and you don't need to give the local anesthetic on either side. The initial thought was you had to give the block, put the local anesthetic on either side, but now the evidence is there as long as you are not in the muscle, it's just next to the nerves, even putting it one side is good enough to give a persistently good block. Initially, when we started doing the blocks, this is how I used to do. So you go from in plane, from lateral to median, and go close to the nerve and slowly inject the local anesthetic beyond the muscle, just next to the nerve. So there was a temptation to give, achieve what is known as a donut block. Do we need the donut block? Let's see what the evidence is. But I used to put the local anesthetic first initially at the C5 and C6 and make sure that the local spreads very well to the C7 nerve root if possible as well, and go on to the other side and put it as well. But this is how we thought it would give a fantastic block. It used to give a fantastic block, but there is so much of poking around this the nerve sheath which are still not so much myelinized. So it poses certain risk to the patient. As a result, there is evidence now that you don't need to give so much of poking around the nerve. You can just give on one side of the plexus, and that will usually work as long as you give a little bit of time. And also they have found out that the muscles has a new perimysium, and the sheath around it is fairly very thin. As a result, it spreads in fairly easily. Now, what does the evidence say? If you look at the evidence, so this is way back in 2012, so where they compared around 160 patients with surgical anesthesia with ultrasound-guided block versus nerve stimulator. There is no competition at all. Nerve stimulator had around 91% success rate, whereas ultrasound-guided blocks had nearly 100%, 99% rate. So the sensory, the motor, and extent of blockade was significantly better in the ultrasound group. Now, next thing was to see whether we can reduce the volume of local anesthetic. In this up-down study, they showed that the volume of local anesthetic required to achieve a significant block is much less in the ultrasound-guided group. Now, it significantly reduces the number of needle passes, the required LA volume, and because you're putting just next to the nerve, the post-operative pain control was reasonably good. Now, the next thing was to see whether should we go between the nerve roots, or you can stay outside the nerve roots. This study showed that you don't need to be poking between the two nerve trunks. So you can be just outside it and give it, and there is absolutely no difference in the quality of block. So you don't need to be poking between the two nerve roots or the trunk. So if you're just next to the nerve, the spread is good, you will get a good block. That is what this study showed. So similar onset times, and in both motor and sensory distribution, the quality of block was essentially the same, except if you are intraplexar, between the sheath, in the sheath, so you may get a slightly faster onset. Otherwise, the quality of block was exactly the same. Now, of course, if you try to enter between the nerve trunks or between the nerve roots, there is an incidence of transient paresthesia, which may pose the patient to the post-operative nerve deficits. Now, our own Pune girl, they showed that if you are using ultrasound, the incidence of hemidiaphragmatic paralysis is much less. So almost none in the ultrasound group, whereas with the nerve stimulator group, where we're used to giving high volumes, we used to have a significant number of hemidiaphragmatic paralysis. Not only that, Horner syndrome and vascular puncture can easily happen because you're not visualizing what is happening. You're going by only the stimulation of the nerve. Now, the other study by our friends from Pondicherry showed that it is possible to identify the upper trunk consistently, and you can use that as a target rather than as a nerve root. And the local anesthetic volume, they showed that you can easily achieve a good block somewhere between 5 and 10 ml of local anesthetic volume. So in that way, so you not only are specific, you can reduce the volume and reduce the toxicity as well. Now, what we also started was, they also noticed that you not only see the nerve, you can see inside the nerve. The nerve elements can be seen. All the structures around it can be identified. For example, in this case, we all can see the nerve, but it's important to identify what are the other structures there. This is at the level of the T7 transverse process. You can clearly see they have a specific pattern in which you can appreciate, so that where you want to put, depending on the kind of surgery, where the incision is, you can focus on that particular area. So most people, what they say is, you can easily put the local anesthetic somewhere between C5 and C6 roots. If you put the needle here and give the local anesthetic, that is good enough. You don't need to be poking in all the way down here to get a good block. As long as the needle is not in the muscle, it's just periplexus, it is good enough to give a consistent block. Now, the C6 also has a characteristic appearance. Again, you can not only see the nerve, so you can see the plexus, muscles, plexus, and the appearance of the transverse process, which to help us get the needle at the correct place. Now, using all this, they have developed the AI model. I have not access to this particular machine, but it is possible to identify, not only with our brains, using artificial intelligence as well, what are the nerve roots there. Now, in a sense, what we need to do is we need to focus on identifying the vessels, the nerves, nerve roots, the muscles around it, and see where exactly we want to put. Most of the time, we can put the local anesthetic between the C5 and C6 roots and put the local anesthetic that is good enough to get a good significant block. So, brief video in which to see how to scan up and down, where we are seeing the transverse process, as well as the nerve roots and the muscles around it. Now, when we do the block, what we need to do is we don't need to get the needle all across. We need to get the needle as close to the plexus, beyond the muscle, and don't need to be poking with the middle scalene to injure the nerves passing through that. So you just get in there, and one single shot injection next to it. If you are achieving a spread like this, that is good enough to get a significant block. You don't need to go to the other side, and that is what the evidence says, and that is what my experience as well. Now, slowly, we have developed a consensus. What are the things which we need to show when somebody is showing what they have to show? And that means when you're scanning phase, you need to make sure that you show these muscles which are on the left side. That is, you need to show the anterior scalene, middle scalene, C5 and C6 roots. You can show the other structures, but they need not be seen all the time. So when you're doing the block, you should be able to consistently see these muscles. So in a sense, there is a significant advance which has happened over the last 10 to 12 years, and it has made us nerve blocks safer. So in summary, what we need to do is we think that if you're using these safe maneuvers, safe techniques, ultrasound interscalene should never fail. Thank you very much.
Thank you, Dr. Subramaniam, for that in-depth talk on ultrasound-guided interscalene block. Now I invite Dr. Sandeep Punta to speak on the traditional method of supraclavicular block.
Ram. We have seen ultrasound, how it works, but we all have been using PNS or a landmark technique for giving the blocks. Yeah. So I'll be dealing with why supraclavicular is my choice in these patients with upper limb surgery. As you go down the memory lane, in 1928, Kulinkev and Perky, they said that the best way to reach the trunks was in the neighborhood of the subclavian artery over the first rib. That is the supraclavicular block. We know that there are three plexuses in the neck, that is the cervical plexus, the brachial plexus, and the accessory nerves. We have seen about the brachial plexus, how it is formed. George Figel told us, elaborate this one, how it is formed. Now, if you see, between the middle scalene and the anterior scalene, the roots come out. They are separated from each other. If you want to block these, we have to be very specific which nerves you want to block. And these nerves are also very thick. This is the brachial plexus, and which gives anesthesia to the whole arm. When you're giving any blocks to the upper limb, it can be aboveclavicle or below clavicle. Aboveclavicle are the deep cervical, superficial cervical, interscalene, supraomoid, intersternocleidomastoid, supraclavicular or subclavian perivascular, and below clavicle are the infraclavicular, axillary, elbow block, etc. Can be given by different methods. Now, if you see this picture, the roots, they are separated from each other, and if you want to block any root, you have to be near to that root or around that root. And you can give a small quantity of drug also to block those. But here, the roots are very thick, and the drug doesn't penetrate completely inside. As you come down to the supraclavicular area, it is into the trunks and the division level, where it is in a very compact region. So at one place, if you get one stimulation, you just rotate the needle a little bit or advance or withdraw the needle, you will get the stimulation of the other nerve. And if you go down below the clavicle, these now again separate out and go around the vessel. So again, there we have to be specific which nerves we have to block. As you see this, there are different blocks and what anesthesia is given. Only supraclavicular gives anesthesia to the complete arm. Most of the time, surgeons say that if I give an interscalene block, the fingers are moving or the hand is moving because those nerves are not blocked. If you give a supraclavicular block, all the nerves are blocked and the entire arm is anesthetized. One more thing, we call supraclavicular block as spinal of the arm. Because as you see here, it can block from fingers to wrist, arm, forearm, and up to the shoulder region if you are given adequate quantity of the drug. These are the contraindications. Different approaches are the classical supraclavicular approach, subclavian perivascular, and the other ones which most of us don't use most of the time. Different muscles which can move, which are stimulated with the brachial plexus, and the movement of the muscles is seen here. But here, if you are giving a supraclavicular block, we don't want the shoulder abduction to be there. So that is the suprascapular and the axillary nerve. We want either elbow flexion extension, wrist flexion extension, the movements of the finger, movements of the wrist, and thumb adduction and abduction. That is the lateral cord, median cord, and the posterior cord stimulation. So when you are giving a position to the patient, the head is turned on the opposite side. You mark the posterior border of the sternocleidomastoid. Then, as Sir had told about the brachial line, you palpate the groove at the level of the cricoid and palpate it lower down, that is in between the anterior scalene and the medial scalene up to the midpoint of the clavicle. From there, if you extend the line, it goes to the axilla, that is called a brachial line. Just above the clavicle, medial to the brachial line is the subclavian artery. Then you palpate the subclavian artery 1.5 centimeter above the midpoint of the clavicle with a simiplex needle, nerve stimulating needle, you can give this block. So you can go by two approaches. The classical approach is either a medial caudal and posterior direction of the nerve, that is perpendicular to the brachial plexus, or you can go lateral caudal and the posterior, which is along the brachial plexus. This is the position where you have to stabilize your arm or the fingers on the chest, and with the thumb, you palpate the subclavian artery, retract it medially. Keep the arm in a neutral position. Okay. Here you can see that once the needle is in a proper place, you get the flexion extension of the fingers and the wrist. Then you decrease the current.
60. 50.
Till 0.3, where the stimulation goes off, and then you can inject the whole drug. I use normally around 20 to 25 cc of lignocaine and bupivacaine mixture for these patients. Anand, can you stop the sound? Other method is the subclavian perivascular. Subclavian perivascular, head is turned on the opposite side. You palpate the interscalene groove and go down till you palpate the subclavian artery, and the whole subclavian artery should be palpated with your thumb. And once you have palpated that, just above your finger, you pass the needle perpendicular to the skin, and immediately within around 1 to 1.5 centimeter, you will get the block. Can you stop the sound for this? Yeah. So here we are palpating the groove, and then going down and palpating the subclavian artery, pushing the subclavian artery medially and caudally, and pressing it a little bit firm so that the distance between the brachial plexus and the needle entry is less. Then you take the semiplex needle and just above the finger, and make sure that your needle is going lateral to the subclavian artery. As soon as you enter, around 1 to 1.5 centimeter, you will get the contraction or the stimulation of the nerve and the contraction of the fingers, or the flexion extension or the wrist movements which are there. You can decrease the current and give the drug. Your action of complete anesthesia to the arm will be there. So AORA gave some tips for that the needle should be parallel to the midline. The palpating finger needs to exert different amount of pressure for the deeper tissues, and never insert deeper than 1 inch for the supraclavicular block, and not more than 1.5 centimeters for the subclavian perivascular. So why I prefer supraclavicular is it is easy to give, it is approachable nerves, it is as a bundle of grapes in a smaller space, so all the nerves can be blocked there. These are not the thicker nerves like in the interscalene groove. The drug takes a longer time to seep inside. So they are the thinner nerves because they're the branches and the trunks and the branches. So the surface area for the drug to act is more. There are less complication, but you should be aware of pneumothorax, which can occur. It is called spinal of the upper limb. And we get a predictable, complete anesthesia to the arm. If you're using ultrasound for supraclavicular block, it decreases the chances of failure and increases your accuracy. Thank you.
Thank you, sir, for such a wonderful talk. I now invite upon Dr. Shri Prakash K. for the talk on corner pocket is my goal in US supraclavicular. Over to you.
Good morning all and welcome. Before I start, I thank organizers sincerely for this opportunity. The popularity of supraclavicular block remained unrivaled till date. Only during last decade or so, there have been some modifications in the technique, mainly to prevent complications like pleural or vascular puncture. Some important key landmarks in the background. The supraclavicular block was introduced into the clinical practice by Clue and Claff. The first ultrasound supraclavicular block was performed by Capral. In 2007, Source made a breakthrough by identifying the corner pocket and recognition of its importance in preventing ulnar nerve sparing. Anatomy of interest mainly for this block is the relationship between the subclavian artery, first rib, pleura, and the plexus itself. The brachial trunks along with the proximal divisions cross over the first rib along with subclavian artery between the insertions of anterior and middle scalene. Here, importantly, the brachial plexus lies posteriorly and superiorly. This block has got definitive distinct advantages. The block is performed at the distal trunks and the proximal divisions. Here, the brachial plexus is confined to a very small surface area, and the trunks are placed very closely, resulting in a dense block. We all know all the three trunks carry entire sensory, motor, and sympathetic innervation of the entire upper limb except for a small area. So injection into this space would result in a widespread loss of sensation. Literature at present does not support, as previously thought, the concept of rapid onset of supraclavicular block just by simply injecting between subclavian artery and first rib. Studies have shown, in fact, that costoclavicular and infraclavicular are equally effective. The positioning of the needle in the supraclavicular brachial plexus with the use of ultrasound has progressed from center cluster, that is single injection into the center of so-called bunch of grapes. Corner pocket, single injection between subclavian artery and first rib. The combination of two is the double injection technique, which came into vogue, became very widespread popular, and even practiced today with little modification. Targeted intracluster was proposed, providing 100% success rate, rapid onset, but you require a high resolution ultrasound, and it is prudent not to miss any cluster. Intertruncal approach is a relatively new promising technique. Having seen so many techniques, let's see why our goal is corner pocket. Defining corner pocket, it is the area inferior-medial to the brachial plexus, superior to the first rib, lateral to the subclavian artery, and probable location of the inferior trunk and its division mainly unknown. These are also known as pocket nerves. The 8-ball corner pocket technique was introduced by Source. The name comes from game of pool, in which no match is won unless the 8th ball is pocketed into the corner pocket. Likewise, according to Source, no supraclavicular block is successful or complete unless you inject into the corner pocket with or without additional injections. This is an illustration of modified double injection technique, where your first injection goes between first rib and subclavian artery, that is corner pocket, and second injection preferably between upper and middle trunks. This is a classical sonoanatomy of the supraclavicular region, where you identify pulsating anechoic subclavian artery, hyperechoic first rib, hyperechoic pleura with sliding sign. The trunks of the brachial plexus here are represented as hypoechoic nodules with hyperechoic connective tissue, and the arrow corresponds to the corner pocket. A small clip demonstrating the corner pocket injection. You can appreciate the pulsatile subclavian artery, first rib. The needle is introduced from lateral to medial in plane technique, and the goal is to observe the lifting or elevation or peeling off of the inferior part of the brachial plexus of the first rib. Why should my goal should include but not confined to corner pocket? Number one, corner pocket injection beyond doubt prevents ulnar sparing in 80 to 85% of the cases. Number two, it is not always possible to image inferior trunk or its divisions, because they may be hidden between subclavian artery and the first rib. Number three, by taking the advantage of this small surface area, will definitely prevent patchy or incomplete blocks. Number four, though we all know it depends on the total volume to be injected, but there is evidence that corner pocket injections, there is decreased incidence of hemidiaphragmatic paresis. Some critical aspects regarding corner pocket injection: the transducer need to be moved in several angles to get the key sonographic landmarks, that is subclavian artery, first rib, and pleura. Two anterior, two posterior might obscure the image. It is mandatory to apply color dropper before needling, as most commonly supraclavicular and transverse cervical and several unnamed hypoechoic vessels may course your needle pathway or may actually traverse the plexus itself. Regarding needle insertion, the most common is lateral to medial insertion, is widely practiced. The advantage is unobstructed pathway to corner pocket, but the disadvantage is the needle point outs towards pleura. On the other hand, some practitioners pass needle from medial to lateral. The advantage is the needle point outs towards first rib rather than pleura, but the disadvantage is the knee subclavian artery itself obscures the pathway, requiring several manipulations. Hydrodissection and hydrolocation to reach the corner pocket is highly suggestive. Some advantages of the corner pocket injection: hemidiaphragmatic paresis is less. This is a single center randomized controlled study comparing it with intracluster technique. The speed of onset definitely not inferior to the infraclavicular or costoclavicular. Immediately after the publication of 8-ball corner pocket technique by Source, Samet has actually filed his comments to the editor, expressing his strong reservations against positioning the needle between subclavian artery and first rib. He wrote, unless one is a professional 8-ball player and has got highly advanced equipment, what he meant was high-resolution ultrasound, there is a potential for hazardous scratch of subclavian artery or pleura. But subsequent papers titled Avoiding the Scratch and Trick Shot to Corner Pocket have actually made to dispel the myths of corner pocket injection. They ensured and concluded that corner pocket injection is safe and highly effective. Comparing with the targeted intracluster technique, definitely it is faster than corner pocket injection, but there is a question in the conclusion. Is 8 minutes of onset of time worth potential for axonal disruption? Obviously, the answer is no. Coming to the novel needling style or technique, the intertruncal approach, where you identify the upper trunk and its divisions, anterior division, posterior division, and suprascapular nerve, the middle trunk and the lower trunk. The first injection goes between the divisions of upper trunk and middle trunk into the adipose connective tissue. Second injection between middle trunk and the inferior trunk. Said to be safer because you are injecting into the adiposal connective tissue, not entering near the nerve. Many individuals are now switching over to this practice. I don't know whether at present or will be the standard of practice in the future. Thank you all. I take this opportunity on the behalf of AORA to invite all of you to the 14th annual conference of AORA to be held at Hyderabad in the month of August 2024, dates 22 to 25th. Please kindly save these dates to make your presence. Thank you.
Thank you, Dr. Shri Prakash. The session is open for question and answer. We'll take 2 or 3 questions.
If there are no questions, can I ask a doubt to Bala sir? Sir, can you advise, you said about feeling the interscalene groove. In your experience, if you are encountering an obese patient, what would be your tactic?
The first advice is to tell the patient to lose weight, because the next time when he comes, the block becomes simpler and he will live longer. And second thing is, in spite of the patients being very obese, the only thing two things that you would need to do, ask the patient to turn the head to the opposite side with the chin to the mid-clavicular line. This is a perfect position, number one. Number two, ask him to lift the head against little resistance. The muscles get very taut, and now you overcome and your fingers are able to feel the muscles which have become very taut, both the sternocleidomastoid and the scalene muscle. So invariably, though this part looks a lot of fat deposition, it becomes easy when the muscles become stronger. So I would say that these 2 points, and invariably 100%, I'm very confident that you will be able to feel the scalene groove with this maneuver.
Thank you, sir.
Can I ask a question?
Sure.
This is to both Dr. George and Dr. Bala. Dr. George, here, you mentioned about the existence of some muscular slips between the scalene roots, the cervical roots. Could be this a possibility for sparing of the, and how often do you find it in your cadaveric dissections?
Well, concerning the frequency of these muscular bridges I just mentioned, it's about 40% that they are existing. So it's not a variability, it's a regularity. So they are regularly, and these are the problems that might give you a little bit a different spread. That's the first thing. Second thing, for the positioning, I just want to mention that if you lower the shoulder, your entire plexus is coming up more superficially, so you already get the groove also quite easily.
Okay.
And one third remark is concerning the roots. I'm sorry, there are no roots. I know it's terminology, but at that time it's only ventral rami. The roots are much more medially. They are in the spinal canal and not laterally. This is a very different terminology, and if you get the roots, you are epidurally. I'm sorry to say. So the textbooks are wrong. I know that's a clinical term, but it's a wrong term. The correct term is a ventral ramus, because the dorsal ramus of the spinal trunk or spinal nerve already arose and passed dorsally. So the left one is the ventral ramus, nothing else. Okay? You can say segments, but please do not use roots. Thank you.
Dr. Fiegel, you have shaken our roots. Regarding the question of these facial planes being present, after the advent of interfacial plane blocks, like we have started knowing more about the drug spread across fascia. I think regional anesthesia is poised to a greater heights in the coming years because of our understanding about the spread of the drug across the fascia. So now the question is, even if they are present, it will work, but maybe it take a longer time for the drug to penetrate this fascia and then go towards the nerve. It will work, but maybe it takes a longer time. Thank you.
So one last question. Last question. Anybody who wants to ask? So regarding the anatomical landmark, I think Sri Prakash mentioned about the intertruncals between the two trunks. So if it would have been in the past, like you obtain a paralysis of the middle trunk and give local anesthetic agent. So in this case, if we obtain just a needle position at the middle trunk and inject a local anesthetic, would be sufficient?
Identifying clearly the trunks is the crucial. The answer is yes, if you can identify the delineation between middle and inferior trunks.
Concerning the anatomy over there in the, with the inferior trunk, you will see some dissections tomorrow. And what is the cause that you might miss it if you just go to the middle trunk or in between the super and the middle trunk. Okay, there is an anatomical cause which forces source to implement this corner pocket injection. You will see tomorrow. Okay, a little bit some patience. It's a little bit the thrilling part of the anatomy.
Yeah, we'll conclude the session. I request.
All mention. I don't know whether Bala Venkat just forgot or didn't mention. The sniff is the perfect word to identify the interscalene groove. No? And you tell the patient to vigorously try smelling, and even in obese patient, there is something you get.
Thank you for that tip. Yeah, I declare that the session is closed and we can take question and answers in the break. I thank all the speakers for their excellent discourse. Thank you.
Good morning. I invite Dr. Lakshmi Manvikar and Dr. Vandana Mangal for the next session. Brachial plexus below the clavicle. Over to you, ma'am.
As the chairpersons are taking position, a small announcement. At 9:30, 9:30, we are having another session called AORA Global. It will be in Hall D. We have got 8 international faculty from across the globe speaking to us, and this session will start at 9:30 in Hall D, and it's termed as AORA Global. It's in the first floor. Thank you.
Very good morning to all. I welcome you all for the second session, that is brachial plexus below clavicle. I take pleasure in inviting first speaker of this session, Dr. Ritesh Roy, on ultrasonic infraclavicular just beneath the axillary artery is all that is required.
Thank you to the organizers for giving me an opportunity to share my deliberations. So I will be speaking on US infraclavicular. Is a single injection below axillary artery is all that is required? Greetings from my hospital. We are a 300-bedded hospital which runs a fellowship, AORA Fellowship Center, and these are my disclosures. So a 72-year-old patient with a fracture both bone forearm, known case of COPD, CAD, diabetic and hypertension, was posted for open reduction and internal fixation. So based on the surgical factors and dermatomes, myotomes, and osteotomes, these are the approach options which have. But based on the patient factor, my choice is lateral infraclavicular block. And this is the way I did my lateral infraclavicular block. This is the pec major, the pec minor. You can see the axillary artery. You can see the axillary vein, the lateral cord, medial cord, and posterior cord. In this patient, I got it, but maximum time you see only the lateral cord. And I do an in-plane needling from cephalad to caudard. I will just appreciate a facial click and put my needle tip just at the 6 o'clock position. And as I start injecting, you can see a good U-shaped spread of drug and displacement of the axillary artery anteriorly. And I deposit around 25 to 30 ml of local anesthetic. How many of you agree with this technique? Vote. Fingers up. So I have many to prove it. Fingers down, many. So let's review the literature, what the literature says. So coming to the cadaveric study, all the 3 authors are here in the conference. You can clear your doubts. So they did an ultrasound-guided single needle tip placement below axillary artery in a cadaveric study. And what they found, there were 2 cadavers. One, in both they injected below the axillary artery. One was frozen, and one they immediately dissected. And what they found, in cadaver 1, there was spread of latex dye to the lateral cord and the posterior cord. In cadaver 2, which was frozen, the blue latex engulfed all the 3 cords. The authors concluded that a single injection of 20 ml below the axillary artery is what is required, but you have to confirm it by your clinical studies. There was another clinical cadaveric study, why your infraclavicular block fails. So they performed bilateral infraclavicular in 20 cadavers. Lidocaine 0.5% with methylene blue was injected. The primary endpoint was the failure of the ultrasound infraclavicular. In 33, they were successful. In 7, the blocks were unsuccessful. The authors concluded it was not the placement of the needle tip, it was the spread of drug to a thoracocapsular space between the subscapularis muscle and the serratus anterior muscle. Can the facial layer influence the spread of dye, which Dr. Sandeep Diwan, they have shown that there is no facial septa in their cadaveric study. But in this cadaveric study, they found, they have shown that there are well-defined septals in 7 cadavers which they dissected. In 6, the facial layer impeded the spread of drug, but in 5, there was no facial layer. So the facial layer adjacent to the neurovascular bundle are common, but it is not invariably present. The most common location of the facial layer is below the axillary artery. That's why the appreciation of a facial click when you are going just below the artery is one of the sensations which can give you a successful block. And the optimal spread of injectate is by a single injection below the axillary artery using 30 ml of drug or by a multiple injection which you want. Now coming to the MRI studies. According to the MRI study, they found 3 cords and it was almost within the 2 centimeter of the axillary artery. And what they concluded that the injection site that is closer to the cord, that is cranio-posterior and adjacent to the axillary artery is what is required. Now coming to the clinical trials, the double bubble sign which we always tell to get it, the inferior bubble is the local anesthetic and the superior bubble is the axillary artery. And if you get a double bubble sign, the success rate is almost 100%. Now this is a study which was conducted in 2010 which they compared single versus triple injection, and what they concluded that a single point injection posterior to the axillary artery is what is required. There is another study comparing single or triple injection. The conclusion was the success rate and onset of the complete sensory block is not enhanced by a triple injection, and a single injection is what is enough. What is the end point of a successful ultrasound block? The combination of a facial click, which I showed, a U-shaped distribution of local anesthetic, and anterior displacement of the axillary artery when you are injecting the drug is the end point of a successful ultrasound infraclavicular block. Now, this is a study again by Dr. Sandeep Diwan, ultrasound-guided infraclavicular without neurostimulation in a patient with crush injuries, and there were 14 cases of crush injury of upper limb for amputation below elbow, and the LA was deposited below the axillary artery in a 6 o'clock position. The author's recommendation, needle tip placement below the axillary artery and injection of LA posterior to axillary artery is what is required to get a successful infraclavicular block. Now, this is a study in 2013, the complication of single injection ultrasound-guided infraclavicular block. It was done in 627 ultrasound infraclavicular. There were 4 transient neurological symptoms, 2 possible last, but the success rate, 94% in experienced and in non-experienced hand, 93%. And what was the conclusion? A single injection posterior to the axillary artery is safe technique associated with the high success rate regardless of the expertise of the anesthesiologist performing the block. This is a study comparing single and double injection technique where they gave around 25 ml of local anesthetic. There was no difference between the single injection group and a double injection group. The conclusion was a double injection block doesn't provide any significant advantage compared to the single injection counterpart. This is a recent study which came in May. They compared a single injection with a triple injection, 30 patients in each group, and the sensory onset was slightly less in a single injection group, but the motor onset time, the composite sensory motor onset time, and mean time to perform the block was less in a single injection group, but rest of the parameters were almost same. The conclusion was a single point injection method has a shorter performance time with a similar onset time with less procedural complication compared with the triple injection technique. So I gave that block and I assessed it by the by push, pull, pinch. So my block was successful, and that 72-year-old patient had a very good block. He underwent the surgery without any complication. So I was ready for action. So the take is a single injection below the axillary artery. Appreciate the facial click when you are targeting your needle at the 6 o'clock position. As you start injecting, you see a good U spread of drug, and as you are injecting, you will see the anterior displacement of axillary artery. If these 3 triads are successful, a single injection below the axillary artery is what is required in an infraclavicular block. Thank you very much.
Thank you, Dr. Ritesh, for such a wonderful presentation.
So after that PowerPoint presentation by Ritesh, may I request Dr. Somita Christopher to please deliver her talk on is US ultrasound costoclavicular and overrated block.
Good morning, everyone. Respected chairpersons, colleagues, and my dear friends. It's very difficult to undermine infraclavicular brachial plexus block after that talk with Dr. Ritesh. So the topic which was given to me is costoclavicular block overrated? So the term overrated means rated or valued more than what it deserves. So ever since costoclavicular brachial plexus block was introduced in 2015, it has emerged as an effective technique in providing anesthesia and analgesia to the upper limb beyond the clavicle, beyond the elbow. So I will be discussing costoclavicular brachial plexus block under the headings of anatomy and sonoanatomy, block techniques and performance, complications and risks, and in the end we can come to the conclusion whether this block really deserves the position it has gained. So coming to the anatomy and the sonoanatomy, for the people who are new to this block, the costoclavicular brachial plexus is performed just posterior to the midpoint of the clavicle, which is known as the costoclavicular space. And it is in this location that the three cords of the brachial plexus, namely the lateral cord, the posterior, and the medial cord, are superficial and are consistently clustered lateral to the axillary artery, which is the main selling point of the costoclavicular brachial plexus block. Coming to the sonoanatomy, once the probe is placed just below the clavicle, you can see the pec major, pec minor, you can see the pec major, the subclavis, and the axillary vessels, and the costoclavicular space, which is the hyperechoic area just lateral to the axillary vessels. The initial sonography of the costoclavicular space may be technically challenging, but once the injection is given for the lateral cord, the rest of the cords are easy to see. So if you compare it with the infraclavicular brachial plexus block, which is given just medial to the coracoid process, the cords are deep to the pectoralis group of muscles, and they are separated from each other. So what does that mean? That means that it is possible to do a costoclavicular block with a relatively smaller volume of drug as it is required for the infraclavicular brachial plexus. This was a study which was done in 2016 to study the anatomy and the axial topography of the costoclavicular space, and the authors concluded that the cords were consistently lateral to the axillary artery and parallel. They also spoke of a connective tissue septum which separated this costoclavicular space into a superficial and a deep compartment. The superficial compartment consisting of the lateral cord and the deep compartments consisting of the medial and the posterior cord. So if you look at the infraclavicular brachial plexus, we note that the position of the cords is variable with respect to the axillary artery, and it is very difficult to find all the three cords in the same ultrasound plane. Coming to the block technique and performance, similar to the infraclavicular, this block is also performed with the patient in supine position and the arm abducted to 90 degrees. A linear probe is placed just inferior to the midpoint of the clavicle and slightly tilted chordate to get a cephalic to get a better picture of the plexus. The needle trajectory can be from the medial to the lateral side or lateral to the medial side. However, if you look for the people who are doing this block regularly, it is not very easy to pick up the needle or to put the needle between the coracoid process and the clavicle, and the optimization of the needle as well as the view of the shaft of the needle is also very suboptimal. The disadvantage of placing the needle from the medial to lateral side is the axillary vessels which are right on the way. So placing the needle out of plane perpendicular to the probe can be a good idea, but again, you cannot see the shaft of the needle. The injection can also be performed as a single technique as was initially described, but double and triple injection techniques can also be done. So these are the two movies showing the in-plane and out-of-plane approach to the costoclavicular brachial plexus block. The movie on the left side, you can see the needle being placed in the middle of the cluster and the local anesthetic spreading. And you can see the lateral and the medial and the posterior cord. And this is the out-of-plane approach to the costoclavicular brachial plexus. You can see the spread of the drug just next to the costoclavicular space. The only disadvantage of giving a single injection is that there may be inadequate spread of the local anesthetic because of the spread of the septum and thus delayed onset for the medial cord or the inferior plexus. So this was a study which was done by Munzo and Hadzik to determine the efficacy of the double injection technique. It was a retrospective study in which 40 patients were given costoclavicular brachial plexus block with ultrasound as well as nerve stimulation guidance. They gave a double injection in which the first injection was given in the inferior compartment after getting a trigger for the posterior cord or the medial cord. The needle was little withdrawn and the drug was injected next to the lateral cord. And these authors boasted of a success rate of 97.5%. This was a study done by Lyra and colleagues in which they compared the single injection and a double injection technique for costoclavicular block, and they found that both the onset time as well as the total anesthesia related time was much less with the double technique as compared to the single injection for costoclavicular. So what about the block onset? For the people who are doing this block regularly, you would have noticed that the block onset is very rapid. In fact, in this study, which compared the infraclavicular with the costoclavicular brachial plexus block in 40 patients undergoing upper extremity surgery, they found that the sensory onset as well as readiness for surgery was as fast as 10 minutes as compared to the infraclavicular brachial plexus, where the readiness for surgery was at least for 15 to 30 minutes. What about the perineural catheter? Yeah, this place seems to be a good site for placing a perineural catheter because of the ease of catheter fixation, and also there is a reduced risk of accidental displacement of the catheter as we see more commonly with the supraclavicular technique. In fact, in the study done by Dr. Sandeep Diwan and colleagues, they placed a stimulating catheter retrograde from the costoclavicular space and placed the tip in the interscalene region for postoperative analgesia after shoulder surgery. What about the complications? Disadvantages of the costoclavicular brachial plexus block are inadvertent puncture of the vessels or the pleura simply because of the vicinity of the structures to this space. So this was a very interesting study which was published in Canadian Journal of Anaesthesia. They studied the critical structures in the needle path of the costoclavicular brachial plexus. So they took 4 cadavers and they gave bilateral costoclavicular brachial plexus block with the epidural needle and later dissected the costoclavicular space. And they concluded that although the needle path was very near to the critical structures such as cephalic vein, thoracoacromial artery, medial brachial and medial antebrachial cutaneous nerves, none of these structures were penetrated. But the point to note was that lateral cord was penetrated in all the cadavers, which means that there is a propensity of the nerve to the lateral cord when you're doing an in-plane needling for the costoclavicular brachial plexus block. Therefore, the double technique is preferred. So what about the big hemidiaphragmatic paresis? So in the study done by Dr. Shiva and colleagues and also by Dr. Hong in 2021, they compared the costoclavicular with the supraclavicular brachial plexus block and studied the incidence of hemidiaphragmatic paresis, which was very less. It was 5% in Dr. Shiva's study and 2.9% as compared to 22.5% in a study by Dr. Hong. In a recent meta-analysis, which was done by Dr. Liu in 2023, they looked at 6 RCTs, which consisted of 414 patients, and studied the incidence of hemidiaphragmatic paresis. And they found that the incidence was much, much lower with costoclavicular brachial plexus block as compared to 31.3% people who received interscalene plexus block for arthroscopic shoulder surgery. This was another interesting cadaveric study done by Dr. Kyal Moody and colleagues in which they injected 20 ml of methylene blue in the costoclavicular space and later dissected this area, and they found that most of the cords and the trunks as well as the suprascapular nerve was stained with methylene blue. But if you look, the phrenic nerve was spared in all the 3 cadavers in which they did this study. So as a conclusion, costoclavicular brachial plexus block is an effective technique for analgesia and anesthesia. but it is technically more challenging, but which technique is not. Needle visualization is an issue in almost all the techniques which we practice. Thank you. And I would again take this opportunity to welcome all of you to the 14th Annual Conference of Academy of Regional Anesthesia in Hyderabad, to be held from August 22 to 25. Thank you.
Thank you, Dr. Somita. Now I invite Dr. Chandrasekhar Cham to deliver his talk on landmark guided perivascular axillary soaks all cords. Dr. Cham, please.
Hello, good morning. I'm going to talk about the axillary block. Perivascular axillary block soaks all cord. This is basically an anatomical guided block which I have to speak about. As you know, the axillary approach, it's a basic peripheral nerve block, brachial plexus block, which is most common. And it is very famous during our residential period. In our residential period, when there is no nerve locator, ultrasound guide, ultrasound. And the basic, we get a very satisfactory block below the elbow for forearm and hand surgery. And another very advantage about the axillary block, it's the safest block. As compared to all other blocks, does not risk blockade of the phrenic nerve, nor does it have a potential to cause pneumothorax, and it's an ideal option for the daycare surgery. But even though there are advantage and safe, there are some limitation, disadvantage of the axillary nerve. It is only for the below elbow surgery, and because of sparing of the nerves, there is limited use of tourniquet and needs multiple blocks to complete the block, multiple injection. And also because of the sparing of the musculocutaneous, we need rescue blocks for the axillary approach. This is history. I will not go in detail, but it was only after Bowman's publication in 1959, the axillary block getting more popularity. These are the indication on the basis of the terminal nerves supplies, dermatomal, myotomal, and that the block, axillary block, is very much for the below elbow surgeries. These are contraindications, and some about the anatomy at the axillary block is basically for the terminal nerves like radial, ulnar, and median nerve. There are chances of many a times, even with this block, we can block the musculocutaneous, but many a times it gets spared. So you can see the cord divide at the level of lateral border of pectoral minor and gives the terminal nerves which are lying around the axillary artery. These are the roots of the terminal nerves. Knowledge about the arrangement of all the terminal nerves around the axillary is very important to block the axillary block. With the arm out in the anatomical position, median nerve usually lies superior, that is anterior lateral, whereas ulnar nerve lies inferior, and radial nerve posterior to the artery. The musculocutaneous nerve lies outside the sheath and usually superior lateral, just above the median nerve. This is the cross section that gives idea about the positioning of the nerve as compared with the axillary artery. So there are various techniques to block the axillary nerve. single injection technique, double injection technique, multiple injection technique, and transarterial technique. This is I am telling about the landmark guided, not about the ultrasound guided or nerve stimulator guided. It has been suggested that axillary brachial plexus sheath contains the septa, but several studies shows that these septa is not going to affect the spread of the drug all over the or around the axillary artery. So the anatomical landmark for the axillary block is the pulse of the axillary artery, coracobrachial muscle, pectoral major muscle, bicep muscle, triceps muscles. Now the position for the axillary block, patient should be lying supine with the arm abducted and elbow flexed to 90 degree. The head should be rotated away from the side of the block. Avoid excessive abduction that will prevent getting the pulsation of axillary artery. Stretching may increase the risk of nerve damage by preventing nerve from rolling away from the needle. So the requirement for the axillary block is simple 22 gauge 38 millimeter short bevel, then IV access, monitoring, full resuscitation. The technique is paresthesia. There are many things by which we can judge the entry of the needle into the sheath. One is the paresthesia technique, another is the pulsation technique, then is the transarterial technique, and these are the three methods by which we can judge the entering of the needle in the sheath. So the needle should be directed towards the axillary artery. If artery is entered, then redirect needle until the paresthesia is obtained. And once you get with a single injection technique, you can inject the whole amount of drug into that. And there are dye studies which gives that with a single injection technique also you can get the block very effectively. But many times there is chances of spares are there. So we have many times we have to give double injection technique. And the another method is transarterial. Palpate the axillary pulse, insert the needle through small intradermal skin wheel where pulse is felt, aspirate bright red blood and advance needle until blood is no longer obtained. Inject 40 or 35 cc of local at this point. There are alternative approach where we can inject 20 cc in front of the artery and 20 cc behind the artery. These are some complications of the axillary block: vascular puncture, intravascular local injection, hematoma, toxicity due to absorption of local anesthesia because large volume of drug is used around the artery. So clinical pearl is that we have to use short bevel needles, suitable length for each block, so slow injection with repeated aspiration. Avoid injection if high pressure is there. Don't inject if pain is there. And we have to use the concentration of drug according to the duration of surgery. There are many a times single injection technique is not sufficient to get to block all the nerves. There are chances of sparing of mostly musculocutaneous. So multiple stimulation result in a higher success rate as compared to single or double injection technique. Many times you have to block musculocutaneous nerve separately. So to conclude, axillary block is a safe and effective regional anesthesia technique suitable for wide variety of procedure for both inpatient and outpatient. Care should be continued exercise using standard safety precaution of slow, careful fractionation injection to minimize the risk associated with the technique. So with the single and double injection technique, if the drug is spread all around the artery, the effect is very good with the axillary block. Thank you.
Thank you, Dr. Cham. for such a wonderful lecture. I now welcome Dr. Nitin Gawai to talk on neurostimulation identification of each is required.
Good morning, everyone. My topic is axillary block, neurostimulation identification of each is required. Brachial plexus block at the level of axilla is one of the commonest approach because of its simplicity, easy landmark, effectiveness, and safety. Now, going back to history, the surgical technique of axillary block was first described by William Halsted in 1884, whereas the percutaneous method of axillary block was described by George Herschel in 1911. After the concept of neurovascular sheath was established by De Jong in 1961, single injection technique, being the simplest, became the standard. However, in 1983 and 84, Wester Anderson and co-workers demonstrated that despite of large volume of local anesthetic, analgesia was patchy in single injection technique. In 1990s, transarterial double injection technique was popularized by Urban and Stan and co-workers. With the development of peripheral nerve stimulator, multiple nerve stimulation became possible. Now, this is a diagram showing anatomy of brachial plexus, which has been described beautifully by Dr. George Figel. Axillary block targets the terminal branches of brachial plexus in the axilla, namely the musculocutaneous nerve, median nerve, radial nerve, and ulnar nerve. Axillary block result in anesthesia of upper extremity distal to the midarm, which includes forearm and hand. So the indications of axillary block are, it is used for surgeries below elbow, for forearm and hand surgeries, and for daycare surgeries. And the contraindications are skin infection at block site, allergic to local anesthetic, axillary lymphadenopathy, and coagulopathy. Now coming to relationship of axillary artery in the axilla, here you can see median nerve and musculocutaneous nerve lies superior to the axillary artery, whereas ulnar nerve and radial nerve lies inferior to the axillary artery. Median nerve is more superficial than the musculocutaneous nerve, whereas ulnar nerve is more superficial than the radial nerve. This is a common topographic arrangement of brachial plexus, which is seen in axilla, and it is seen in around 65% of individuals. Anatomic variation of brachial plexus is quite common in axilla, around 35%. You can see it around 35% of individuals. And this can influence the conduct and outcome of regional anesthesia. Therefore, multiple nerve stimulation using peripheral nerve stimulator increases the success rate than either single or double injection technique. A recent Cochrane review by Hendall and co-workers, which included 12 trials and 981 patients, showed that multiple injection technique using peripheral nerve stimulator for axillary block provide more effective anesthesia than either double or single injection technique. Now coming to the technique, under all aseptic precaution, a 50 mm atraumatic insulated stimulating needle is used along with peripheral nerve stimulator. The neurostimulator is said to deliver a current of around 0.5 to 1 milliampere with a frequency of 1 or 2 hertz and duration of 0.1 millisecond. Electrical connections with the needle and the electrode should be checked. Acceptable motor response is up to 0.4 to 0.5 milliampere and not below 0.4 milliampere. This is to prevent intraneural injection. Now, how to do it? With the patient in supine position, arm is abducted to 90 degrees and elbow is flexed. Palpate the bicep muscle, palpate the coracobrachialis muscle and palpate the axillary artery just below the coracobrachialis muscle in the axilla. Insert the needle just above the axillary artery for median nerve block and musculocutaneous nerve block, and insert the needle below the axillary artery for ulnar nerve block and radial nerve block. This is a median nerve block where the needle is inserted just above the axillary artery to obtain median nerve block, which is manifested by flexion of lateral 2 to 3 fingers, forearm pronation, and flexion of the wrist. Current is decreased to around 0.4 to 0.5 milliampere. And around 5 to 7 ml of local anesthetic is injected. For musculocutaneous nerve block, needle is withdrawn subcutaneously and directed cephalic into the coracobrachialis muscle to obtain elbow flexion response. Here around 5 ml of local anesthetic is injected. For ulnar nerve block, needle is inserted just below the axillary artery to obtain ulnar nerve response, that is flexion of medial 2 fingers, thumb adduction, and ulnar deviation of hand. Thereafter, current is decreased to around 0.5 to 0.4 milliampere, and around 5 to 7 ml of local anesthetic is injected. For radial nerve block, needle is redirected deeper below the axillary artery to obtain extension of wrist and hand. Here around 5 to 7 ml of local anesthetic is injected. So the local anesthetics commonly used are, for anesthesia purpose, bupivacaine is used as 0.5%, ropivacaine 0.5%, and lignocaine 2%. For analgesia purpose, bupivacaine 0.25% and ropivacaine 0.2% is used. A total volume of 20 to 25 ml is used. Clonidine can be used as an adjuvant in a dose up to 0.5 microgram per kg. Now coming to the clinical pulse, median nerve and ulnar nerve both result in wrist and finger flexion, making it difficult to differentiate between the two nerves. Following method can help to differentiate between the two nerves. If forearm pronation is also present, then the stimulated nerve is the median nerve. Median nerve produces movement of palmaris longa and flexor carpi radialis, whereas ulnar nerve produces movement of flexor carpi ulnaris. Decreasing the intensity of the current helps to differentiate between the two nerves. Now coming to tricep response. This is a tricep response which should not be accepted for axillary block because it is due to stimulation of muscular branch to the tricep. So what are the possible complications? Vascular puncture is quite common, so always aspirate before you inject to prevent intravascular local anesthetic injection. Hematoma, if occurs, should be treated with firm pressure for 3 to 5 minutes. As large volume of local anesthetics are used, always watch for last. Intraneural injections are characterized by pain, extremity withdrawal, and resistance to injection. So always be vigilant. So the advantages of axillary block are there is no risk of phrenic nerve palsy or pneumothorax. Therefore, it is preferred in severe respiratory disease and daycare surgeries. It is a better alternative in case of mild coagulopathy because vessels are easily compressible. Thank you.
Thank you, Dr. Nitin. It was really a very good presentation and cleared many of our doubts. For the next session, we have Dr. Rupinder Singh, who will be talking on just 1 ml per nerve for ultrasound axillary brachial plexus block. Is it sufficient? Dr. Rupinder, please.
Can we have her presentation, please?
Yeah. So, a very good morning to all. So, this is the last lecture in the series. So, I have been given this talk regarding is just 1 ml per nerve for ultrasound-guided axillary brachial plexus block is sufficient. So, earlier this year, we had a meeting at AIIMS New Delhi, and Dr. Devan was there with me, and this was the thing which came, Ek Chutki Sindoor. So I transformed it to, does Ek Chutki Bhar LA suffice for a USG-guided axillary brachial plexus block? So let's see. So traditionally, high-volume axillary brachial plexus block have relied on very high volumes up to 40 ml to achieve surgical, both motor and sensory. But however, saying this, much of this volume may diffuse into the surrounding soft tissues or undergo vascular uptake and thus not contribute to the anesthesia as such per se, and leading on to the most dreaded complication of LAST. In some patients, it might, because the axillary area as such is very vascular. So the key to a successful block is to surround the nerve bundle as much as possible with a local anesthetic solution. However, the minimum volume which is required is not known. USG for us has been a boon, and it has potentially reduced the amount of volume and hence decreasing the complications. But the question remains, how low can you go on your volumes? So my previous speakers, they have told about the anatomy, and usually this is the normal anatomy which you see. So we have the radial nerve, the median nerve, the ulnar nerve, and the musculocutaneous nerve. But even with the use of ultrasound, can we identify all these terminal branches? I think all of us sitting in the hall have used USG for giving axillary brachial plexus block, but not all the times you can see all the 4 terminal branches, right? So because there are certain facial structures, tissue planes, which can be mistaken as nerves as such per se. And this was an article in which they said that 4 separate nerves can be seen on static. The word static is important over here. On static ultrasound imaging, only in about 75% of patients. So now, what is the scientific evidence regarding how much volume, what concentration, where should be the needle tip when we give an axillary brachial plexus block? So this was an article in which they had around about 60 patients where they tried to have a minimum effective volume of local anesthetic application. And they found that anything less than 2.5 ml per nerve resulted in an unsuccessful block. Having said this, the authors even stated that it may be kept in mind that the motor and sensory onset block will be extended, and the regression time and the time for first analgesic requirement will be shorter with this amount of volume. In another study, I was very surprised by this study. The authors have done a successful ultrasound-guided axillary brachial plexus block with 2% lignocaine with epinephrine. And how much volume they have used? They have used just 1 ml. And what was the population data? Just 5 patients. So it's a thought. In another study, the minimum volume of local anesthetic was determined, and they found that the minimum volume for radial was around about 3.42 ml, for median 2.75, for ulnar 2.58, and for musculocutaneous 2.3. However, in this patient population group, 7 patients required additional local anesthetic infiltration with these low volumes. So do we want our patients, these patients, axillary brachial plexus is more of a daycare surgery. So do we want to supplement our patients by going down to such low volumes? Another study in which they used 0.75% ropivacaine, they used the step-up and the step-down method, and the initial volume which they used for all their patients were 15 ml. And they found that the minimum effective volume for 50% of patients was 8.62 ml, and for 90% it was 11.82 ml. So having quoted all these studies, they have used low volumes. The disadvantage is that the onset of anesthesia was relatively slow and the duration was short. But can we extrapolate this study into our clinical practice? It is to be seen. So at the flip side of it, how much is too much? If we say that the volume, we should not go to this lesser amount of volume. So ultrasound helps us in seeing the drug deposition around the nerves. So 5 ml per nerve is good enough for the axillary brachial plexus with a quick onset and good duration of action of the block and good block as such. I have put up this slide over here that whenever we speak about local anesthetics, it is not only the volume, it is the concentration also which is important. So when we use a higher dose and a higher concentrations, we get a long duration of sensory and motor block. And studies have shown that patient population groups who were given equal dosages but higher concentrations, they had a longer duration of sensory and motor block. So this was a study in which they found the minimum effective concentration of bupivacaine for axillary brachial plexus block. And they increased the concentration of bupivacaine from 0.15 to 0.35, and the success probability of the block increased dramatically. Also, the latency of the block, as you increase the concentration, the latency of the block also decreased. So in conclusion, I would like to say that the knowledge of the different topographic variation of the 4 nerves, 4 terminal branches at the level of the axillary brachial plexus, you should know that. You should know how to put your probe properly so that at the proper pressure which has to be applied. Use of low volumes could lead to intraneural injections, which is not required. Extraneural placement of local anesthetic should be administered with visualization of the nerve and dissemination of local anesthetic. Less the volume, the time of onset of sensory and motor block is prolonged, the time to block recovery is shortened, and the time to rescue analgesic is shortened. So, does ek chutki bhar LA suffice? I would say, ye dil mange more, a little more. Thank you very much.
Thank you so much, Dr. Upendra. And this was the last talk of the session. Now the session is open for a brief round of questions. All the speakers are available here to solve your queries. Yes, Dr. Gopal.
Yeah, thank all the speakers for their lucid presentations. How many of you practice ultrasound-guided infraclavicular brachial plexus blocks? Wonderful to see so many hands go up. How many of you agree that a costoclavicular brachial plexus block is overrated? One of the purported advantages of a costoclavicular brachial plexus block was that visibility of all 3 cords would be assured in a single window. But we don't often see that. With a lateral, sagittal approach, there is variability, but ultrasound helps you pick up these cords. So I would also tend to believe that a costoclavicular brachial plexus block at this point of time, given my experience, is overrated.
Sorry, might I give an anatomical comment about that?
Sure.
Well, I absolutely agree with that. but I want to give you some more impressions about. First, you follow simplifications. Simplifications found in your books, regional anesthetic textbooks, and anatomic textbooks. The problem is the variability. You have such a high variability that even cords must not to be formed. Sometimes you do not find 3 black dots. You find 5 black dots. What's now? It's a duplication of a cord, or what is it? It's nothing. It's a variability. But everybody is talking about 3 cords. It doesn't need to be. So just be simple. Who said, okay, you see 4, you're not drunk, there are 4. Then you get 4. Go with your needle. Place your needle perfectly close to the nerve structure you identify. Nothing else. There is no secret at all in this area. Okay?
Dr. Fiegel, yeah. Coming to your cadaveric study, right? Your cadaveric study, according to it, don't chase the cord. Don't chase the cords. Chase the artery, right? Because according to your cadaveric study, even you
Which
have
one?
the lateral infraclavicular,
Okay.
single injection below the axillary artery. And in that study, you all have also contraindicated that there are no facial layers, which are there in earlier cadaveric studies. So according to your cadaveric study, if there are no facial layers, just target the axillary artery and deposit below the axillary artery. You don't have to chase the cords, right?
Well, now you have to just take into account the time of the publications. The first ones of Ben Kadra was just about 2009, so a little bit longer ago. You can imagine also my anatomical knowledge enlarged a little bit, also with some new informations I received after dissecting 3,000 bodies. Currently, my understanding about the anatomy is over there that, yes, you're right, there are septa. There might be septa developed. They don't need to be, but they are regularly over there. And yes, if you get one single injection, you might fail because of a, let's say, inefficient spread about. This is one of the major problems concerning the rising method of a nerve when he's splitting, when he's dividing. It's also the epineurium, which is dividing, and then might form, does not need to form, but might form a septum, which separates the different nerve structures from each other. And this is especially in the axillary fossa much worse than in the infraclavicular region. So as a conclusion, the far you go peripherally, the more problematic is one single injection.
Okay.
Yeah? So I absolutely agree with your critics. And I wouldn't, for example, perform the first publication of Quadra using methylene blue. Because why? If you open the area, your methylene blue is everywhere. Yeah. And everything is reached. Oh, great. Perfect success. Never do this again. That's why we use latex. Latex is hardening, and then you really say, okay, that's a distribution which should be or was. Okay? So the identification and the validity of your results is much better. Yeah? Even more. We still have to learn the anatomy and to respect the anatomy much more than we used to do last years or last decades. Okay? So we are still in a learning process.
Okay. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Just one statement. I agree with Gopal's statement that I think the costoclavicular is just ultrasound version of Kilka's block. That is one thing. Second, as George said, we have recently uploaded an article which we have several questions we have answered regarding the number of hypoechoic elements in the costoclavicular area. We found a maximum of 8, and we have answered all this. One of the reviewers might be here in this, so he should be heard about this probable divisions which might exist even low down in the costoclavicular area, which might have some implications on the block. Thank you. I think you can close this.
Yeah, thank you so much. Thank you, everyone. We close the session, and it was a great session. Thank you all.
Moving on to the next session, another interesting session of sparing and complication. I invite Dr. Choba and Dr. Shalini Sardesai to please moderate the session for us. Dr. Shalini will join us shortly. She's chairing another session in the neighboring hall.
I'm myself, Dr. Savar from Imphal. Very good morning to all the delegates of the AORA 2023. So we have got 4 sessions in this session. We have got 4 speakers. The first speaker is Dr. Sunil Dixit. I call on Sir Sunil Dixit.
Thank you, sir. Very good morning to all, and my dear respected chairpersons and my colleagues. I will be presenting my talk on brachial plexus block. Probably I missed my nerve proximally. I do not have an ultrasonography. What do I do? So I will be featuring on the landmark guided or PNS guided blocks, rescue blocks. As we all know that incomplete proximal brachial plexus block is an indication for selective upper extremity nerve blocks. And innervation of upper extremity variable and overlapping, so technical difficulties are there. Because of this, there are missed segments and incomplete block. One can block the corresponding nerve depending upon the surgical area. How will you test the block has acted or not? There are a test of 4 P's. Ask the patient to push inside against resistance, the vasculocuttance will be tested. Ask the patient to push outside, extensors, that is radial will be tested. Pinch on medial surface of the little finger. The ulnar nerve will be tested, where if you pinch on the second finger on the medial side, the median nerve will be tested. If a particular nerve is not blocked, give rescue block in axillary region. It is always wait for 20 minutes for a block to set. Now, one of the rescue block is the supraclavicular nerve block, that is the superficial cervical plexus block. We all know that it is derived from the ventral rami of the C3-C4 and it is not derived from the brachial plexus. It becomes superficial as it penetrates mid-belly of the sternocleidomastoid, forming 3 branches. It provides the sensory innervation to the cape area. What is cape area? Cape area spans from midline to the deltoids and from second rib to the top of the scapula posteriorly. Only 5 to 10 ml of local anesthetic is required. Out of this, 3 ml in the mid-belly of the sternocleidomastoid, 3 ml subcutaneously cephalidy, and 3 ml caudally. Then now comes the suprascapular nerve block. It is useful for when interscalary block fails, and along with axillary block, it gives good results for the shoulder surgery. I generally do this block by Mears approach. The position of the patient in this block is the patient has to be seated, both arms in full adduction. The main landmark of this block is the spine of the scapula, which is identified. A line is drawn between the lateral end of the acromion and medial end of the spine of the scapula. The line is held, and the 2 centimeter above the line and 2 centimeter medially, that will be the line of the point of the insertion for the suprascapular nerve block. The direction of the needle should be infralateral and the 45-degree to the skin surface. The evoked motor response will be minor abduction and external rotation. Then comes the intercostobrachial nerve block. It is indicated for the surgery involving the medial or posterior upper arm, and it alleviates the pain caused by the general tourniquet. It is not the component of a brachial plexus. It arises from the T2 and occasionally T1 nerve root. Along with the medial cutaneous nerve of the arm, it provides sensation to the upper half, medial posterior arm, and also portion of the anterior axilla. It's a very simple technique. We have to only deposit 5 ml of the local anesthetic subcutaneously, superiorly and inferiorly along the axillary trees. Then comes the everyone has talked about the axillary brachial plexus block, but there is a great deal of anatomical variability. Median and musculocutaneous nerve superior to the artery, ulnar and radial nerve are inferior to the artery. I generally do this by two needle technique. We know that median is superficial to the musculocutaneous, whereas the ulnar is the more superficial to the radial. Occasionally, radial or musculocutaneous are found behind the artery. Medial, ulnar, and radial nerve are situated around the axillary artery. Expect to find these nerves superficially, often within 1 centimeter from the skin. Radial nerve, however, is the most difficult to locate. We all know that musculocutaneous nerve departs from the lateral cord in the proximal axilla and is commonly spared in the axillary approach. But to cover this, large volume of local anesthetic is required, and we have to, after giving local anesthetic, massage proximally up the sheath, and we can thus block the musculocutaneous nerve. Axillary brachial plexus block, shoulder is abducted, elbow is flexed, axillary artery palpated, 2 distinct puncture sites, above and below the axillary artery is marked. Needle inserted above the artery, if musculocutaneous nerve is stimulated, elbow flexion will be there. 5 to 7 ml of the local anesthetic is deposited. Needle is repositioned above the artery to locate the median nerve. There will be wrist or finger flexion will be there. Now for radial nerve below the artery, wrist or finger extension will be there. And for ulnar nerve below the artery, flexion of the distal phalanx of the little finger and medial flexion of the wrist. Now these are the superficial, lateral and medial antebrachial cutaneous nerve blocks. This is LAC and MAC. These are, LAC is the terminal superficial branch of the musculocutaneous nerve. It innervates the lateral or radial half of the forearm, whereas the medial antebrachial cutaneous nerve emerges from the medial cord and innervates the medial forearm plus skin overlying the olecranon. It is indicated for the superficial surgery of the forearm, generally for the AV fistula, and it can be supplemented to incomplete brachial plexus block. But it should be injected to 20-30 minutes after the primary block. Technique for LAC block, LAC is blocked with the 2 local anesthetic injections placed along the intercondylar line. First 5 ml deep to the lateral margin of the bicep tendon, then second 5 ml subcutaneously given lateral from the first along the crease of the elbow. Then MAC, this injection is given half ring of the 5 to 7 of local anesthetic about the quarter of the arm's length above the median elbow. Selected nerve blocks at the elbow, more difficult to perform. It's a time consuming, greater risk of complications, and they block the forearm flexors and extensors. Out of this radial nerve, which we all know that it is sensibly supplied to the dorsum of the forearm and head, and extensors are supplied by the radial nerve. It descends along the posterior surface of the arm, travels from the medial to lateral side. At the epicondyle, it lies relatively deep to between brachialis and brachioradialis muscle. Technique, patient is supine, arm supinated and abducted. Generally, nerve is formed 1.5 centimeter lateral to the bicep tendon at the level of the epicondyle. Needle inserted to the depth of 1 to 2 centimeter. Finger extension and the wrist extension will be there. Median nerve, it supplies sensory supply to thenar eminence, palmar surface of the part of the thumb, index finger, middle finger, and the lateral side of the ring finger. It also supplies motor supply to the flexors. It passes the elbow. It is always medial to the brachial artery and in front of the brachialis. Needle is placed at the epicondyle region, medial to the brachial artery. Motor response of the thumb apposition. Now ulnar nerve, it is located, it is very superficial, located at the elbow. Then it is superficial in the ulnar groove. Supine forearm flexed at the elbow. Ulnar groove is identified in between the medial epicondyle and olecranon process. Needle has to be placed 1 centimeter proximal to the epicondyle, then directed distally. Ulnar deviation of the wrist and flexion of the little finger. We have to inject only 2-3 ml of the local anesthetic to avoid the excessive pressure within the tight canal. Now there is a humeral canal block. It anesthetizes the brachial plexus at the level of the terminal branches. Here, musculocutaneous and median nerve are present above the artery, then ulnar and radial nerve below the artery. The radial nerve is difficult to find as it crosses the posterior to the humerus. technique, shoulder is abducted, elbow is flexed. It is fine, site of the entry is generally between upper 1/3 and lower 2/3 of the arm. 2 puncture sites above the artery and 2 puncture sites below the artery. This is a short video. Ulnar nerve is stimulated, then, sorry for, it is the incomplete video. Okay. The humeral can to reposition the artery 2 puncture site below the artery, radial for wrist or finger extension, for ulnar deviation of the wrist and flexion of the 4th or 5th finger. Now there comes the wrist block. Wrist block, radial nerve can be blocked at the wrist without the use of PNS because it's a very superficial and sensitive supply is there. We have to field block the 5 to 7 of local anesthetic subcutaneously in and around the anatomical snuff box. For median nerve, it is between the tendon of flexor parvis longus and flexor carpi radialis. Needle is introduced approximately 3 centimeters above the wrist crease. Thumb flexion will be there. Deposit the 3 to 5 ml of the local anesthetic. For ulnar nerve, we have to go medial to the ulnar artery below the tendon of flexor carpi ulnaris. The needle is inserted 3 centimeters proximal to the wrist crease. There will be flexion of the 5th finger. 1 minute only. 3 to 5 ml of local anesthetic is deposited. Then the last but not least, the digital nerve block, hand in prone position. Needle introduced the rep space of the finger corresponding to the proximal phalanx. We should never use the adrenaline for this block. Thank you.
Thank you, sir, for a wonderful lecture. So next I call on Sir Ujjwal Dedua to give his lecture.
Good morning, everybody. Thank you for the wonderful invitation and wonderful crowd. So continuing with the talk on the sparing of brachial plexus block, I would be talking about brachial plexus block. I probably missed the nerve proximally. I have ultrasound, and what do I do? So first we have to understand, when we are facing this scenario, do we call this as a failed block? So for that, we need to understand what is a failed block. So we need to categorize. What is a failed block? Failed block is a block that does not provide anticipated level of anesthesia or analgesia despite adequate lapse of time. We have given whole 20-30 minutes and it's not providing anticipated level. It fails to provide adequate patient comfort to allow planned procedure without adding any intervention. So that is what we call as the failed block. Now it can be complete or it can be partial, and we need to decide based on evaluation of sympathetic system, evaluation of sensory and motor. I won't be going into details of these evaluations, but we'll see how to progress when we face this scenario, because I'm sure everyone has faced this some or the other time. Important is know your brachial plexus, and it's good to have a green version of brachial plexus. But what is important is, I won't be going into details, but what is important is C5 roughly supplies this area, C6 roughly this area, C7 roughly this area, C8 T1 roughly this area. So we can have a brief understanding, okay, this area, which route we are missing. Importantly, there are 6 nerves which are mixed nerves which are supplying the upper limb: suprascapular nerve, axillary nerve, musculocutaneous, radial, median and ulnar. Rest all are cutaneous branches, and fairly they can be handled by infiltration at the area or subcutaneous infiltration. So we won't be going into detail, there's no rocket science in that. But in case we have sparing of these mixed nerves, we should be able to address them. So always have these flashcards around you to understand what is missing and where to do. Understand the supply of radial and axillary nerve. Understand the supply of musculocutaneous, median and ulnar nerves. Go for a quick motor assessment. Very simple. If you have external rotation and abduction from 0 to 15 degree, you know you have the suprascapular nerve which is paired. If abduction of shoulder is happening, you know the axillary is paired. If elbow flexion is still happening after your block, you know musculocutaneous is paired. And the rest 3 nerves, it's very easy to understand rest 3 nerves. every one of us knows this rock, paper, scissor game. So if it is a rock, you know median nerve is spared. If it is a paper, you know the radial nerve is spared. And if it's scissor, you know the ulnar nerve is spared. Very quick assessment. You don't need to go much in detail. Now, based on your assessment, you need to understand whether you need a top-up or you need a rescue. So you need to understand what are the reasons for sparing. So revisit your scan, you have an ultrasound, you revisit your scan, you see there is a poor drug, you need a top-up if you are in the safe dosage limit. If the spread is good, then you know you are dealing with anatomical variation and you need to go for a rescue block and move a little distally. Now this is something. Forgive me for this picture, it's not the ideal one. The block is not to be performed in that, but you can see the drug spread over here and you can see this is not. So this is a failed block, but you scan and you understand, okay, so you can top up over here. Now coming on to rescue block. Suprascapular nerve. You have assessed and it is blocked. Simple placement of probe. I'm dealing with anterior approach. I'm not dealing with posterior approach because of paucity of time. But this doesn't require any change of position of the patient after you have given the initial block. You get this anatomical picture, your ultrasound picture, but clippers. Probe position is in the sagittal plane. You have medial lateral in this view. Needle enters from this and you get a picture from it. You can see the suprascapular nerve passing behind the omohyoid muscle as it leaves the upper trunk. Use 3 to 5 ml, and if you increase, you are likely to face phrenic nerve blocks. We have seen this. Coming on to next, axillary. Again, just a little bit of patient turn lateral or if possible sitting position. This is the posterior view. You have an acromial axillary fold line, midpoint of that line. You place the probe, slide the probe proximal or distal or lateral medial to identify the posterior circumflex humeral artery just above the humerus. Once you identify that, you know that proximally you have teres major, distally you have triceps, on the lateral part you have the deltoid muscle. And your needle comes from top to bottom, gives this picture, stay lateral to the nerve, stay proximal to the nerve, avoid injury because beneath lies the bone. Use 5 to 7 ml and your axillary nerve will be blocked. Moving on to next, musculocutaneous. Same, identify the position of the arm, put it into the groove of the pectoral, deltoid and biceps, and you'll get this picture. Probe is transverse, artery, medial, ulnar, radial, axillary vein. Musculocutaneous is between biceps and coracobrachialis. Identify the conjoint tendon. Lower down you have the latissimus dorsi. And this goes your needle. You can block the musculocutaneous directly over there. Drug volume again 3 to 5 ml. Median nerve, importantly identify the hand position, place the probe, identify the brachial artery, and medial to the brachial artery you will find the median nerve. This is the humerus over here. Needle entry, again medial to lateral. Coming on to radial nerve, identify this, identify the position, identify lateral epicondyle, place the probe a little 1 to 3 centimeters above, and anterior to the humerus you will find the radial artery. Inject 3 to 5 ml of solution. Coming on to next, ulnar nerve, hand turned on the other side, identify the medial epicondyle, again 1 to 2 centimeters above, identify the bone and muscle traversing on top of triceps. It is important not to give it in the groove below down because then you get a compartment syndrome. So have volume, stay as low as you can. That is your needle entry path. So conclude, what should we choose? I'm not going into details of wrist block because I feel this is more than sufficient. You don't need to go more towards the wrist and cutaneous infiltration. What should be the approach? Block is given with a proper technique, equipment, and experienced hands. If it is no, please accept the failure, switch to plan B, and plan B means convert it to general anesthesia, no compromise with anything. Yes, you know it has been given technically sound thing. Adequate times has lapsed. If it is yes, go for the assessment. If it is sparing, poor spread, do a scan. You know it is poor spread, go for top-up. Anatomical variation, go for rescue block based on the examination of motor function. But adequate time has not lapsed. Give adequate time and follow the same path again. And it is there, the complete failure, again plan B. Don't hesitate to convert it to GA. And most importantly, don't exceed your dose limits. Thank you so much.
Thank you, sir, for your wonderful demonstration. And I think after this session, nobody will spare the nerve block. Everybody will give the rescue block whenever there is inadequate analgesia. Thank you very much. Next. Yeah. Now, next station is, oops, probably must have blocked the phrenic nerve. What must have gone wrong? I call upon Dr. Shiv Shangam.
Shiva, you can.
Sorry for the pronunciation.
Okay, thank you very much. I mean, this is what we are afraid of in terms of brachial plexus. This is one threat is there for all of us. Let us look at if the suspected phrenic nerve palsy, what would have gone wrong is I'm going to talk about. The answer is very simple. That is, your local has reached the phrenic nerve apart from your brachial plexus. There is nothing else. It's 100% fact. How it has reached is what I'm going to discuss in the next few minutes. So you look at this image, you can see very clearly, this is the anterior scalene muscle, middle scalene muscle. These are all the brachial plexus element. And then the phrenic nerve is running in the anterior surface of the anterior scalene muscle. Always it commonly accompanies the ascending cervical artery. You can see that. So this is a phrenic nerve. As you can very well appreciate, at the root level, this is very close to the brachial plexus element. As we go down, the brachial plexus element moves to the hand, whereas the phrenic nerve goes into the anterior mediastinum. So the gap between these two elements are progressively increasing as we go down. This is beautiful to look at into the atlas. But in the ultrasound, everything is in a cross section. In this image, you can see these are all the brachial plexus elements. C5, C6, this is C7. This is the anterior scalene muscle, phrenic nerve is sitting there, and this is the ascending cervical artery. So only the anterior scalene muscle separates the brachial plexus elements and then the phrenic nerve. So this is how we are going to see it in the ultrasound. So you can look at in the, I will play the video. This is a sternocleidomastoid muscle, carotid artery, and this is supposed to be the anterior scalene will arise here, and we can watch how the phrenic nerve appears on the ultrasound. So now you can see the brachial plexus elements, C5, C6 roots are popping up. I'm going back, coming down. So this is the anterior scalene muscle, and this is the phrenic nerve, and this is the ascending cervical artery. C5, C6, and then C7. And then as we move up and down, you can see that is the phrenic nerve, ascending cervical artery. As we scan up, it has come closer to the brachial plexus element. As we scan down, it moves away from the brachial plexus element. So that is the phrenic nerve sitting on top of the anterior scalene muscle. This is anterior scalene muscle, that is the middle scalene muscle. So that is the sternocleidomastoid. So how my LA has reached to the phrenic nerve. I'm going to explain you two terminologies and the phenomenon. The first one is through bulk flow, and then the second phenomenon is through diffusion. So what do we mean by bulk flow? It is nothing but it is a mass movement of the drug. While you're injecting, you're pushing the local. From the start of your injection, just after stopping, that is, while you're injecting, the drug moves out. So this is known as a bulk flow. The drug molecule moves passively by your injection force. The driving force is the performer. the speed, the pressure, whether you are going to inject continuously or intermittently, what is the size of your block needle, and what is your LA syringe size, all these things will contribute. It is basically you are pushing the local anesthetic. The local anesthetic passively moves and takes the least resistant path. The second phenomenon is diffusion. After the mass movement is initiated by the performer stops, the diffusion starts. Because at this point, the local anesthetics comes to the standstill. From that point, depending on the concentration gradient, the drug is going to move across all 360 degree. Now here the force is the concentration gradient. The bulk flow is directed towards one direction and the drug movement takes the least resistant path, whereas the diffusion moves the drug all 360 degree. The performer don't have any control once the drug is released. So we don't have control over the diffusion. We have major control over the bulk flow. So can we see all these phenomena in ultrasound so that we can try to attempt to reduce these maneuvers? So here you can see, this is again the same image what you've seen before. That's the sternocleidomastoid muscle, carotid artery, anterior scalene, middle scalene. These are all our chain of beads or brachial plexus elements. Our phrenic nerve is lying on the top of the anterior scalene muscle. This is ascending cervical artery. The phrenic nerve is going to lie somewhere here. My needle is coming in plane from across the middle scalene, try to inject the local anesthetic close to the interscalene groove. So now you see I'm going to inject only 3 ml of local anesthetic. You see my needle is coming, it is very precisely parked between the connective tissue matrix. You can see some amount of local comes over here. This is what is a bulk flow. After that I'm adjusting the needle so that the local try to stay here so that I'm happy and continue to inject 1, 2, 3. My needle is gone little away, I try to withdraw, keep it very close, but see the local where it goes. So we were delivering here, but the local goes here. So this is known as bulk flow. That is, the force is yours. So this is one example. The next example is, so I thought my local is not come on to this surface, predominantly it is on this side. So I redirect my needle to the other side and try to get some local close to the upper trunk. So that is my needle coming out of plane. I'm trying to inject the local there. Here is the phrenic nerve. See, moment a 0.5 ml of local anesthetic is being injected. See the local that seeps on top of the anterior scalene muscle. So here is your phrenic nerve is sitting over there. So even with, see the local has come all the way around the scalene muscles. This is our brachial plexus element. This is with just 3 ml on the other side of the plexus. After that, I'm scanning down, you can see the local is sitting on top. That is the phrenic nerve. This is the ascending cervical artery. Local is already reached the undersurface of the phrenic nerve. So this is how the bulk flow happens. So now, suppose if you think this is directly the local is spreading, let us make it a more precise injection. I thought I will inject the local anesthetic within the trunk in a small aliquots. Now also I'm using a 25 gauge needle and 10 ml syringe on the other side with a small aliquots are being injected. You see the local anesthetic come, the needle is coming within the trunk and then we are injecting as a 0.2 ml small aliquots. So the local is trying to contain within the trunk itself. There is no big movement. So this is how you can limit the bulk flow when you come closer to the neural elements and inject with small aliquots and take a bit of time. So if you see here after the injections, even though the drug has come out of a bit of the trunk, but there is no much spread over the anterior scalene muscle to the phrenic nerve is somewhere here. So the moment you see this, you should not think that if I go inside the trunk, can we avoid the phrenic nerve? No. Sometimes even if you go into the roots, the local anesthetic can spread directly over the plexus. So this is a fresh cadaver demonstration. If you look at here, this is a C6 ventral rami. The clinician is injecting about 0.5 ml of methylene blue. You can see the dye spreading into the, this is the transverse foramen. So through the nerve itself, it can diffuse into the epidural space and produce a phrenic nerve block. So now what I'm trying to say is there are two mechanisms. One is the bulk flow can happen over the scalene muscles. Another one is through the intraplexus. While you're injecting even inside the nerve, it can diffuse across and then reach the epidural space and produce your brachial phrenic nerve involvement. And what about the diffusion? It is a random passive movement of the drug from high concentration to low concentration. Drug moves across all 360 degrees. The movement stops when the concentration gradient ceases. So if you look at now, this is the upper trunk and this is where the phrenic nerve is sitting. It is about 1.24 centimeters from your brachial plexus element. You try to inject the drug within the upper trunk. but immediately after some time you are seeing the local spread to a little bit more. This is a bulk flow. After the bulk flow stops, the diffusion is going to start. It is going to spread over a period of time and reach the phrenic nerve. There is a time also is there, there is a distance also is there. So in every single situation, to sum up, the phrenic nerve involvement is due to inadvertent drug spread to its location. The spread is happening through varying combinations of bulk flow as well as a diffusion phenomenon. So bulk flow can be through intra or extra plexus. As a performer, we can limit the bulk flow, but not the diffusion. Diffusion can be limited by manipulating the dose. So these are all the ways it can reach our phrenic nerve. So how we are going to manipulate all these variables so that we can avoid these things, let us listen from Dr. Amjad. So thank you very much for your kind attention.
Thank you, sir. Thank you for your wonderful explanation for the cause of phrenic nerve block during the interscalene block. Now, second, this one, no? Yeah, how can it be avoided by Dr. Amjad Maniyar? Welcome, doctor.
Good morning, everyone. So I have 10 minutes to tell you how to avoid the phrenic nerve, and Shiva has made it very clear that it is extremely difficult to avoid it. So let's just look at what can be done about this. Now, the first thing that you need to know is that if you have created a phrenic nerve blockade, it is not the patient's fault, it is your fault. It's either a poor assessment whether this patient needed that particular sort of technique, or there must have been some technical issue in the way you have deposited the drug. A couple of things that I always tell my juniors when they call up and inform me about what PAC is, have they gone through this sort of a checklist to identify the risk factors with which a phrenic nerve blockade can actually cause problems to your patients? Most of the time, the phrenic nerve blockade does not clinically create an issue, but in patients who have compromise in the respiratory system or have some anatomical variations or like a short neck, or they're obese, or they have some cardiac orthopnea going, a phrenic nerve blockade can show up very viciously as a clinical problem for you. Again, as you saw, excessive volume and hydrodissection can also contribute to this. Now, I'll just run you through 3 concepts that you can take home today. The first one for avoiding or reducing, say, a phrenic nerve palsy to maybe a paresis would be to go low volume. As you saw, Shiva was injecting very low volume, still the drug was moving towards the phrenic nerve. So one of the first concepts that started off is that if you were still doing an interscalene block is to reduce the volume, go really low. How low? They've gone as low as 5 ml, and yet with 5 ml you see that they can be 33% blockade. Okay? If you go up higher in volume, you start seeing further blockade of the nerve. So 33% is definitely better than 60. Traditional volumes of the interscalene, which were 25, 30 ml, are now pretty much not in practice. What we usually do for an anesthetic block will give you you'll use about 15 ml to get a block going. So one concept to follow is to reduce the volume when you're using an interscalene block. Now, we saw how the superior trunk is formed by C5, C6. That's a superior trunk over there. As Shiva said, we can do something known as a superior trunk approach. This concept is starting to move away from C5, C6, the traditional interscalene area, and to give the injection at the superior trunk level. This was initially discussed by Vincent Chan's team, and they used 12 ml, and in those initial trials, there was apparently no phrenic nerve blockade. But as this has been extensively studied, we see that there still is the possibility of the phrenic nerve getting blocked. As Shiva said, is even though you inject into the sheath, there can be spread back towards the origins and towards the roots. And this can give you about 5% of phrenic nerve blockade when you use about 15 ml. Once again, keep an eye on the volumes. As the volume increases, the chances of phrenic nerve blockade also increases. So this is another concept. Go low and go distal. Now, how distal can you go? Many people still practice a supraclavicular plexus block for shoulder analgesia. Now, in this image, This is the subclavian artery, and you see that the supraclavicular area is just forming. It's not complete. This is not a typical ideal image of the supraclavicular area, but what you see is the main supply of the shoulder joint, the suprascapular nerve, has already left the plexus. So this, for you to get a block that works well for the shoulder, you'll have to be within the sheath and you'll have to raise the volume. Remember the nerves that are involved for shoulder innervation: the suprascapular, axillary, the lateral pectoral, and the subscapular. Missing the suprascapular and the axillary will not give you adequate analgesia. So if you go to the supraclavicular area, there still is some chance of blockade. And with the higher volumes, you start getting about 25 to 50% phrenic nerve blockade. Some people have started using the costoclavicular block, but once again, you see there is a slight deviation from traditional volumes. And even with the costoclavicular block, when you raise the volume, you get about a 2.5 to 11% phrenic nerve incident. My friend Shiva will tell you it's at about 5%, but it still exists. And these volumes are usually very high for a costoclavicular block if you're dealing with non-shoulder surgical areas. So again, it's something to think about. But as you can see, none of these approaches assure you of a 100% phrenic nerve sparing concept. So the third concept is go extremely distal. And you've seen with things like TKR, we have started to move closer and closer towards the joint. We're doing motor sparing TKR blocks. The same is happening with the shoulders. The concept is now to move closer to the shoulder and block only the relevant nerves. And this concept was brought about by the late Darcy Price in 2007, where he said that we could block the suprascapular and the axillary nerves separately and get some amount of analgesia going for the shoulder without involving the phrenic nerve. So this was just an uncontrolled and retrospective study that he did. And what he found was it was better than a surgeon-guided intra-articular injection, but slightly inferior to the interscalene block. But since we are very far away, physically very far away from the neck and the phrenic nerve, the incidence of a phrenic nerve blockade is practically zero when you provide the suprascapular nerve block in this area. You also saw the other approach where the suprascapular is present in the anterior neck. The other block that he proposed to do was the axillary nerve block, which again is, this is the suprascapular image. As you can see, the suprascapular nerve is along with the artery in the fossa over here. The other nerve block was the axillary nerve block. It's a little tedious to position the patient for this, but this can be blocked at the back of the shoulder. This is how the anatomy would look: the deltoid, the teres minor, and in an entity known as the quadrangular space, the axillary nerve can be blocked. So this is another set of options that you have for 100% phrenic nerve-free shoulder analgesia. Now, something new that has come out, again, not too much in literature, but something that you should know about and probably can go about and read, is the PENG block for the shoulder. You've heard about the PENG block for the hip. So this is for the shoulder, and this is one case report where they attempted it for a shoulder, open shoulder fracture. It was not very good, but the analgesia was really good for an arthroscopic rotator cuff repair. So the anatomy is a little different. This block was also previously described by Sundekapam and team as the subscapularis plane block. So I'll just go through the quick anatomy. The axillary nerve and the subscapular nerve, remember these are two components that supply the shoulder, lie on top of the subscapularis muscle. And if you were to put some local along this plane, it's a facial plane block, you will get blockade of these two nerves, and you can separately block the suprascapular nerve elsewhere, either anteriorly or back at the scapula. So this is how you scan. The probe is placed transversely, and what you look for is the greater tuberosity and the lesser tuberosity of the humerus. And this is the intertubercular groove where the biceps tendon would lie. This is the deltoid on top. And you look for this muscle here, the subscapularis. Now, if you externally rotate the hand, the subscapularis will come into view quite nicely. So this is the deltoid, and if the hand is externally rotated, you see the muscles swing in like this. And then you have a greater distinction of these two muscles. And the facial plane lies in between these two muscles. If you go very medial, you might see the pectoralis major, but essentially this would be the deltoid area. And this is the plane where you would put in the local anesthetic. So this is just a quick, this is a very difficult, it's more of a tendon, it's very difficult to pierce, so you can get into the plane quite nicely. This is the local anesthetic fill. So this will block both the axillary nerve and the subscapular nerves. So very quickly, just to summarize your alternatives for 100% phrenic nerve sparing blocks, you have a big cookbook to deal with. You can do an anterior suprascapular with the axillary nerve. You can go back to the scapula and block the suprascapular nerve there. You can do a suprascapular nerve injection as well as block the posterior cord in the infraclavicular area, because the posterior cord is from where the axillary nerve takes off. You can do an infraclav suprascapular, that has also been described. You can block the lateral pectoral nerve also, as like the PEC1 block has been described. And you can do the shoulder peng block also with the suprascapular. So just the take-home message is, remember, just go low volume, make it a habit, go distal, and if you've already done these concepts, you can look at going extremely distal with the shoulder peng block. It's early in the conference, but just to remind you that next year's AORA, it will be in Hyderabad, and look forward to seeing all of you over there. Thank you.
Thank you, doctor, for, we all know that there is no chances of 100% sparing of phrenic nerve block, but still he shared different approaches to give analgesia for the shoulder surgery. Thank you very much. Now the question answer session is open. Anybody want to ask question, they can.
I am Dr. Mutha. Ujjwal, actually I wanted to ask anybody, if many times when we give a supraclavicular block of this, we get a sparing of backside of the arm, that is lateral cutaneous nerve, posterior cutaneous nerve of arm. So what can you do about that? And second thing, if when you are giving an interscalene block, the medial part of the upper arm, that gets spared. When they put the retractor inside there and pull, that time the patient has pain. So for this, what can we do?
So as I said, I did not deal with the cutaneous supplies only for the reason that most of the cutaneous supply, you can have a surgical infiltration done. And if you're talking that with retraction it's hurting, that means it's not the cutaneous supply, it's the motor supply which is hurting. Cutaneous supply primarily will hurt only at the incision. So subcutaneous infiltration by the surgeon, or maybe you can do it depending on what nerve you are targeting.
Yeah, basically when they are retracting, that time the pain is coming. So what can we do about that? When the retraction is there.
Sir, your retraction means where your...
The humerus, upper end of humerus. When the surgical neck fracture is there, they put the retractor there and they retract.
Okay, okay. So let me come to the first question. One is the posterior cutaneous nerve of arm. Whenever we are trying to do the posterior humerus, when they do on the lateral side, the shaft fracture, they do a posterior approach. So we think that because the area is supplied by posterior cutaneous, but the problem is the intercostobrachial nerve that is going to overlap with the posterior cutaneous nerve at the back. So it is not sparing of posterior cutaneous nerve, it is branch of radial. You're blocked well. The culprit is intercostobrachial nerve is going to overlap with the posterior cutaneous nerve at the back of the arm. So in all brachial plexus block, it will be spared. So there is no way that you can do a surgery only with brachial plexus block. If you have done, it is by luck, not by intention. Please take this one point. So intercostobrachial nerve spared 100%. It is going to interact with the posterior cutaneous nerve of arm as well as medial cutaneous nerve of arm. So this area is spared all the time. So if you wanted to do, you have to do a skin filtration as Ujjwal said that, because that is only consistently work. There are a lot of other methodologies to block the intercostobrachial nerve, but the one that is 100% you can rely on is a subcutaneous infiltration. When it comes to the pilus plating, proximal humerus, you might be spared. Again, the intercostobrachial is going to come from this area. So you need to do an inverted V-shape infiltration so that it is going to overlap with the supraclavicular nerves. So for pilus plating, you have to block the superficial cervical plexus also. Otherwise, the delta pectoral incision will be painful. So it is a combination of superficial cervical plexus plus complete brachial plexus block plus inverted V-shape infiltration at the delta pectoral groove to prevent the overlapping of intercostobrachial with the supraclavicular nerves. If you don't do these three things, this area will hurt.
I guess, Dr. Shiva, as I mentioned, this area should hurt only during incision. Subsequently, it should not hurt. So it is automatically ruled out that the cutaneous infiltration will work in case you are retracting. No, you have to look for the motor cause, is what I mean.
Just a comment here, nothing. We are live on ATV as well as on YouTube. So you can mention it to your friends that this hall is live on ATV and YouTube. There is also a session which is going on for the faculties, only for the faculties. By the faculties, you can take full use of that. And we have a PG section. And upstairs in the afternoon, we have 3 rooms where we have ultrasound machine, volunteers, and so one of you can pick up one of the faculties. If you want something to discuss with him personally, you can go upstairs and discuss with him. So all these facilities are available. Thank you.
Several anatomical considerations concerning block techniques being listed up here. First of all, concerning a suprascapular nerve block, we already published this in 2007 with a lateral approach, which is absolutely easy, and a low volume, which is lower than 5 ml. So please take this into consideration. It's also easy concerning the spread and also no complications at all. If you want to have further information, you can contact me. Second, concerning the nerve-sparing part of the phrenic nerve. Again, publication 2006, supraomohedral block, unfortunately in an anatomical journal. So it would be also quite nice if you do not ignore us. Yeah? And this is a block where we used at that time 20 ml, which is much too much. Yeah? It's a tsunami, what we created over there. And currently, we are in the clinical use of 2.2 ml. 2.2. 2 are for the plexus, and the 0.2 are for the supraclavicular nerve trunk. That's it. This is the use. You do not need to have, concerning the skin incision, the intercostobrachial. Yeah? Because it's an overlapping, absolutely correct, concerning the supraclavicular nerves. And then you have to search for them, and that's easy to make if you find the trunk of the supraclavicular nerves piercing and passing the prevertebral fascia. That's identifiable. Just have to know where you're looking for. And then you get the low volume over there, and you get a wonderful block. Again, it's already in clinical use since 3 years with our cooperation in Augsburg. And it was Rainer Litz who developed it with myself in last decade. We developed it for 7 years, and then we used it on the patients without any troubles. No phrenic nerve at all anymore. The problem might be that you still follow guidelines with a medial directed needle. A medial directed needle is always the problem because you get a medial spread or a high risk of a medial spread of your local anesthetic. And you will see tomorrow in my talk. Okay? Don't be feared. Okay? It's cool.
Just a comment with regards to the volume of the local anesthetic, Dr. Amjad. The observation, we are having a study going on in our department wherein we went as low as 7 ml and still the phrenic got blocked, which we came to know patient was not symptomatic, but patient was, we scanned the diaphragm, we were doing a diaphragm study. So I wouldn't agree to saying that go low on volume and you'll definitely spare the phrenic. I think it's a good idea to maybe scan and see where the phrenic is before every block. Because since we are doing a serial number of cases, 20 ml has not caused a phrenic block.
So I never said that
it doesn't
going low
always.
will not block it.
Not
so
always.
you look at that study, which was
Yes.
quite landmark at its time, 5 ml would block 33%. So you cannot do 100% when you're targeting a plexus. But if you start going distal, then your options of, your
to
chances
spare
of,
other nerves.
yeah, sparing the nerve are much better.
Any comments on periarticular vasoconstrictor infiltration, which is being done in the West? Huge volume of 100 ml, but periarticular, which reduces blood loss and spares the phrenic?
Yeah, if you use that large volume, you would probably get analgesia anyhow, anywhere. So we are, I mean,
Not
as
anyone
anesthesiologists,
practicing.
yeah, we are going low volumes. We are going specific on the nerves. We can see the nerves now. We can see what we want to block. So that's where we are, rather than those high volume things that they're doing.
I think we have to conclude this session. Gopal, you want to mention anything, please? Be brief, please. Thank you.
Just like the costoclavicular brachial plexus block, I think even the phrenic nerve palsy is overrated. Most of our patients are not respiratory cripples. And even if there is a spread of local anesthetic to involve the phrenic nerve, it's all right. It only reduces the FEV1 by FVC by about 27%, which virtually all patients can tolerate very well. Thank you.
Thank you very much. We'll conclude the session here. So thank you all the speakers for clearing all the doubts. Thank you very much.
Moving on to the next session, now away from the clavicle to the neuraxis, I invite the moderators, Dr. Sachin Arbi and Dr. Ketki Marodkar, for the next session.
Hello.
So moving on to the neuraxials now, and start with the talks straight away. I call upon Dr. Bhagyashri to talk about what happens when you have to give spinal when the patient is still on clopidogrel. Maybe missed one dose or is still on clopidogrel or other antiplatelets.
Hello, good morning all. My today's talk is spinal after one skip dose of clopidogrel. And the reason we need to discuss this scenario is this patient. She's a 67-year-old female with BMI 46. Came with lower limb cellulitis with edema extending up to groin. Known case of diabetes, hypertension, peripheral vascular disease, interstitial lung disease, and she had a recent viral-induced pneumonia, and she's still recovering from that. And she requires oxygen on nasal prongs at 2 liters per minute. The positive clinical findings are obviously obesity, difficult airway, obstructive sleep apnea, active V's on auscultation, saturation is 92%, and PO2 on ABG was found to be 46 on room air. Apart from other medications, she is taking tablet clopidogrel 75 milligram for peripheral vascular disease. She has taken this tablet in the morning and got admitted in the afternoon. And she was posted immediately for lower limb debridement in view of cellulitis, in view of impending sepsis. Now, how many of you would give an option of or choice of neuroaxial anesthesia for this patient? Happy to see few hands up. So we are not fearing the guidelines actually. So why most of us won't choose it is because the guidelines. It advises us that we should stop this antiplatelet therapy at least 5 days. So GA becomes an obvious choice even though we know that we will be putting this patient on prolonged ventilatory supports and very long hospital course. We are afraid of this because of multiple case reports in which not only the neuroaxial procedures, but there have been reports of even spontaneous hematomas on patients on clopidogrel specifically. But then there are some other very important studies which we can't ignore. Most of them are coming from our neurology colleagues, where they have gone ahead and performed lumbar punctures in patients on dual antiplatelet therapies because of the urgency of diagnosis. And trust me, they don't believe in smaller needle sizes. And they have gone from 22 to 18 gauge needles, and not a single patient has developed vertebral canal hematomas. And there are studies in our retrospective cohort study, it has been found that patients have been offered by consultants even after finding out that they're on dual antiplatelet therapy because of risk of general anesthesia, and none of them have developed the spinal hematomas. The most important study we need to discuss here is by Osta et al. This study is recognized in 2018 ASRA guidelines as well. It describes 306 patients who all came for vascular surgery, like vascular bypass, femoral-popliteal bypass. They all received epidural analgesia with indwelling epidural catheters without withholding any clopidogrel therapy. 217 patients were on dual antiplatelet therapy. In addition, they were receiving aspirin, 81 milligram. And 238 patients were on intravenous heparin, which was given 5,000 unit intraoperatively, and it was not reversed at the end of the procedure. 3 patients had bloody tap, and the placement of the epidural catheter was abandoned. And all these patients were followed up not only immediate post-op, but for 3 months post-operatively, and there was not a single clinical evidence of epidural hematoma. Why we have so many confusing reports? All these reports are true because the drug itself is confusing. Now, if you see clopidogrel, it is a prodrug, and it has to go through intestinal absorption first. And because it is orally given, and 85% of the drug is actually rendered ineffective by esterases, and only 50% drug is available for hepatic metabolism. So this drug has to undergo 2-step oxidative processes to convert it into an active metabolite, which will eventually go and will block your P2Y12 receptors on platelets, which will render them ineffective for aggregation and linking with fibrin. So this is the issue which our cardiology colleagues face. They are putting patients on very high dose clopidogrel dual antiplatelet therapies, but their patients are returning with stent thrombosis. The reason is all these patients have very marked inter-individual variability in up to 30% populations. The reasons are multifactorial. Extrinsic factors are, of course, patient compliance, non-compliance, inappropriate dosings and underdosings, and drug interactions. But intrinsic factors is something we need to look into because most of these patients will be having high pre-treatment levels of platelet reactivity. There is a variability in intestinal drug absorption, and there is a significant genetic polymorphism. If you go to this slide, here you can see so many variants pharmacogenetically have been found out. And amongst them, the CYP2, C19 variant, and ABCB1 and PON1. These are the variants they are found to be so resistant to clopidogrel that even loading doses were found to be ineffective. Now, in this scenario, is it possible for us to practically assess platelet inhibition? Traditionally, the tests are of no use, but there are some laboratory-based methods. The gold standard is light transmission aggregometry. It will give you the degree and variability of platelet inhibition, but it cannot be routinely available. It is also requires specialists for interpretation. So to overcome this problem, there are multiple point-of-care tests which are available, out of which PFA 100 and Verify Now are routinely practiced, routinely used. One such point-of-care test is thromboelastography platelet mapping, which we happen to have in our institute. Basically, it is designed to look specifically at functional platelet inhibition, secondary to clopidogrel and aspirin therapy, and it has found to correlate very well with the gold standard, which is light transmission aggregometry. The prospective study was done by Golar et al., and they found that TEC-PM is able to identify inhibition of platelet ADP receptors after clopidogrel therapy, and also platelet thromboxane A2 receptors after aspirin therapy. There's one more study which is related to anesthesia by Benson et al. They studied 13 patients who came for perioperative evaluation. They stopped this therapy for 3, 5, and 7 days in all these patients. If you see on day 3 itself, almost 4 patients were exhibiting below therapeutic level or safe levels of platelet inhibition, which is less than 10%. Based on this, there are many studies which are coming up in literature where this point of care testing is used to solve neuroaxial dilemmas which we are facing. Now coming back to our patient, is it time to implement preoperative platelet function testing for this patient particularly? We did subject this patient for further evaluation. This is the baseline thromboelastography report of the patient. It showed MA of 80.9. MA is basically a function for platelet reactivity, which is a second stage of clot formation. It suggested that the patient was already very hypercoagulable and in a significant prothrombotic state in spite of anticoagulation. The second stage is to deconstruct what were the receptor inhibitions. The ADP inhibition was found to be, MA was 54.2, which is clearly above the normal range, which is 31.47 millimeter. 37 to 47 millimeter, and aspirin inhibition, this patient was also on ecosprin, was 60.1 millimeter, which is way above the normal range, which is 34 to 48 millimeter. To rule out any other coagulation issues, there is a thrombin time which is required for clot initiation, which was found to be 7 minutes, very well within range. What it says is ADP inhibition secondary to clopidogrel was only 9%, and ASRA recognizes the safe level as less than 10%. So this patient is perfectly safe for spinal anesthesia. The take-home message from here is there is a significant inter-individual variability in platelet inhibition. We have to look into it. Point-of-care testings can be reliable for solving neuroaxial dilemma, and the validation is yet only for less than 10% inhibition of platelets. We will require more prospective studies because it's a new field for all of us. And in select patient, safe administration of spinal anesthesia is possible with ongoing antiplatelet therapy. Thank you.
Thank you, Dr. Bhagyashree. That was an excellent talk on so just one skipped dose cannot be generalized as a rule, and we need to decide with each patient what to do with patient selection. Coming to the next topic, which is very pertinent for the PGs, bloody or CSF tab during caudal. May I now invite Dr. Vrushali Ponde to deliver this topic.
Namaste, a very happy morning. Welcome to AORA, a warm, heartfelt welcome. Welcome today and welcome next year as well in August in Hyderabad. Dr. TVS is here. Please quiz him all about it. Well, let's take a moment. What should we not be? Look at that. That's interesting, isn't it? Probably anesthesiologists should never have weak nerves, especially when you're dealing with small babies. Never weak nerves. Clumsy hands? No. Sluggish minds? No. And arrogance? We fail, don't we? We fail many times, especially in RA, till we really get it. Arrogance doesn't arrive in us. And then blues. We are not supposed to have blues too. We are a happy bunch of people. Having said that, let's see how do we really handle when the same anesthesiologist gets this. So blood or CSF during caudal and what next? You know, the average attention span of any presentation is 10 minutes. I beg a little more of attention in this next 10 minutes and let's go. So this is a quintessential block, fits plethora of indications, hence important. It's relevant, it's simple, it's valuable portal to inject drugs and catheters. So we can't afford to have these kind of pitfalls, which you would just see here. So a blood coming out, what do you do next? CSF falls out, what do you do next? And a syringe is filled with local anesthetic waiting to be injected. We'll deal with it. Suspect it. When would you? What are the telltale signs of it? Would ultrasound reduce the incidence? Indeed. Logically appealing, but does it do that? What news is added by ultrasound in handling these pitfalls? So whenever you encounter telltale signs, such as, say, a tuft of hair or a dimple or discoloration on the back while you are about to paint and drape, take an ultrasound and please do the scan. You probably might have some surprises, such as an extended dural sac or a cyst waiting to be punctured full of CSF or fluid. Vascular punctures as such may be picked up. I mean, vascular structures may be picked up, may not be picked up, I'm not too sure, but this definitely shall be picked up. So these are the telltale signs, never miss them. And be very, very paranoid about these things when you see them. And an inexperienced anesthesiologist, because they really wouldn't know when to stop going ahead with their needle once they have gotten that subtle give of the sacrococcygeal ligament, once the skin and subcutaneous tissue have already been traversed. Would ultrasound really reduce the incidence of CSF, as I discussed with you? Yes, it would, because it really would show these anomalies. Would vascular punctures? Yes and no. I'm not too sure whether each and every vascular structures, as small as it can get in babies, be really seen. And what we did was, we were haunted by this question as such. So we took around 300 people, 300 babies, and we sampled them, divided them into 3 groups. Experienced anesthesiologist gave it. We looked into the complications, not long term though. We looked into the incidence of success and the incidence of complications, and we found that it was very rare. Very, very, very rare in the sense I shall show you the figures of it as well. And the success rate somehow did not really get altered because of any kind of modality that we picked. Well, what happened in pediatric regional anesthesia when they did a lot of studies were, as I just said, yes, they are very, very few. So vascular punctures around 0.63% and dural punctures around 0.08%. Again, another study, robust data, 6 dural taps, just 1 case of cardiac toxicity and nerve injury. This is what the newest report tells us. Logically appealing, however, to assume then that ultrasound should help. Now let's come to a very practical way of dealing with this. If you really kind of have this, what do? If it is a bloody tap, blood in the needle, percolating out, remove the needle. If it has tinged the local anesthetic, remove it. If it is a very small baby, I would rather think if I can give some other block. And if it is a long surgery and the risk-benefit ratio really goes towards it, I would change the needle and still give a block with a very careful needle insertion, with careful aspiration, injections in very small aliquots, and my ears and my eyes all the time on the ECG monitor and the SpO2 bleep as such. So this is what is a very technical way of handling it. If we get dural taps, I guess we should abandon. If it is really necessary, try another one and then go ahead. But please pull up the ultrasound machine at that point and see, because dural taps do not usually happen in simple, straightforward procedures. There has to be a reason, unless the needle is just far too inside. So stop the procedure, remove the needle, blood tap, new needle, LA tinge, throw it off. CSF, we just discussed what to do. And then after this, I'm going to put a scenario to you, because whenever this happens right in front of you, you have lots to do. You know what you're doing, you know what you're dealing with. But what if you get something like this? I would like to have the sound, please.
Presenting here a case scenario of 8-month-old child weighing 8 kgs who is posted for hypospadiasis repair under general anesthesia with cordon block. Patient was induced with sevoflurane as an inhalation anesthesia technique, and he was cannulated with 24 gauge IV cannula. After giving standard medication, patient was induced and a caudal block was given. Patient became apneic after given caudal block. So let us see how the case is managed.
We put in the suppository, caudal is done.
Yes, sir, just putting the suppository. Sir, we can run the patient now.
Okay, I hold the head and neck. Baby's turn. Alright, the bag's not moving. The baby is not breathing, Smriti.
Sir, I can't see the EPCO2 as well.
Circuit is connected. Fresh gas flow is on, but I can ventilate the patient.
But sir, hadn't we given the propofol before I inserted the needle?
Yes, that can be a possibility, but it has been quite a long time. No, please check your local wires. What have you given?
Yes, sir. Yes, sir.
Alright, the pulse
So they're okay.
pulse is feeble. Please, Smriti, call for help.
Yes,
Smriti.
ma'am. Could you call Gauri, ma'am, please? What's the matter? Let me ventilate. Ma'am, this is a case of apnea after giving caudal. Now he's desaturating, pulse is also falling, and BB is also not stable. Okay, I'm ventilating.
Alright, let's put in an infant feeding tube. Look at the stomach, it's inflated. Come on.
No. I think if we should intubate, it will be faster. Even if we intubate, ventilation won't be effective as the stomach is all bloated up.
Excuse me, doctor, please.
Sir, infant feeding tube.
Yeah, thanks.
Ma'am, should we give atropine? It's hypoxic, doctor. Let me intubate. Give me laryngoscope. Okay, please. Yes, ma'am. Tube is in. I'm ventilating. Ma'am, what about adrenaline? Where's the role of adrenaline, doctor? Where's the intralipid? Please get the intralipid.
Do we actually need intralipid? We are stable here, yeah, come on.
I call the surgeon. Could you call Dr. Kiran, please? What's going on here? What took you so long? We had some issues. All is well now. You can wash up.
But why have you intubated the patient? We generally don't intubate hypospadias, right?
Ma'am, all is well now. We'll explain later.
So well, this is what happens if we have something unexpected. We don't see the blood or CSF coming out. So, well, you must pardon the actors, the video script, because they were particularly and deliberately made to flaw. Take home this video and ponder on it, because I'm not too sure whether we have the time to really look into each and every step and what could have been done and what should have been done. Whether there were many fallacies in the video. Take this video home and think on it, and if we get time, we can discuss about it. So be prepared is what I would say, and aspirate your local anesthetic. Use ultrasound when you can. Use PNS definitely, because both of them shall tell you the most deadly complication that can happen with a caudal block, which is injecting the volume that has been aspirated for an epidural giving into the CSF of the baby. So think if you could in this direction. I'm not too sure whether it's going to change the entire practice, but it's definitely a food for thought. Thank you so much.
Thank you, madam. We'll take the question answers at the end. We'll go on to the next talk by Dr. Silamban. It's about stimulating epidural catheters and higher epidurals. Welcome, sir.
Yes, good morning. My previous talk about 20 minutes back was higher epidurals, about lumbar and the lower thoracic. Now the same concept, but how are these stimulating catheters going to help you is what I'm going to tell you about. And basically, we have been doing these epidurals based on certain calculations, and with the arrival of stimulating catheters, are those calculations correct? All those things have been answered. Yes. What are higher epidurals? Probably we can consider all epidurals done above T12 level as being higher, most commonly needed, but used infrequently. Say, suppose this is a classification of the upper epidurals based on the angulation of the spines. The lower thoracic from T7 to T12, where the angulation is 30 to 40, where the angulation is around 30 to 40 degrees. In the lower thoracic, it is about 70 degrees. In the upper thoracic, from T1 to T6, the angulation is about 30 to 40 degrees. And cervical, like the lumbar, it's about 90 degrees angulation. All epidurals must be segmental, and especially higher epidurals must be segmental, and it involves the nerves which are going to be blocked, desired by us only. So what are the principles of this segmental epidural? First, the upper and lower level of the area to be blocked is to be decided by us. Then you decide where you place the tip of the catheter. Then you decide what is the length of the catheter inside the space you plan. Then decide the site of needle entry, and finally decide the volume of the local anesthetic you're going to give. Deciding about the area to be blocked depends on the surgery which you're doing. For example, if it's a laparotomy, the block is going to be from T4 to T12. If it is going to be a modified radical mastectomy, it has to be from C6 to T6. So once that has been decided, then you decide where you're going to place the tip of the catheter. That is in the center of the dermatomes or central spine, which we are going to block, based on the assumption that local anesthetic spreads equally on either side of the catheter tip. Then we decide about the length of the catheter inside the space, 3 to 5 centimeters only. If more than 5 centimeters are kept, example, you put a lumbar epidural and try to push the catheter up to T8 level to do a laparotomy, almost 10 to 12 centimeters of needle catheter has to be pushed inside, then coiling, kinking, knitting, doubling, passage into the intervertebral foramen, all these things can occur. And the upper T8 can never be reached by the catheter, in at least in 30 to 40%. And then you have to give a higher volume of epidural local anesthetic to achieve your level of blockade. And needle entry is either 2 segments below or 2 segments above from where you're going to place the tip of the catheter. This is based on the consideration to cross 1 segment, 2 centimeters of the catheter will have to be threaded inside the epidural space. Finally, the volume of the drug. For lower thoracic, upper thoracic, it is 1.25 ml per segment. For the cervical, 1 ml per segment is sufficient. For elderly, obese and short statured, the volume can be decreased by 0.5 ml per segment. Agents and regimen, it's entirely your choice to choose based on your and surgeon convenience and comfort. But my choice for a laparotomy would be to start with xylocaine with adrenaline. Second dose is half the first dose after 45 minutes, because 1 segment regression starts and it's only a segmental epidural. Suppose the T5 is your splanchnic innervation. We have a block only up to T4. So at 45 minutes, the drug starts regressing. So at 45 minutes, the second dose of xylocaine can be repeated. Half the first dose will intensify the blockade. And third, the subsequent doses, till you get tachyphylaxis, you can continue with xylocaine, or you can shift over to bupivacaine at 1/3 of the initial dose to a minimum of 4 ml per time. Anatomy, angulation of the vertebral spines is very important in performing the epidural blockade. Coming to lower thoracic epidural, all abdominal procedures are done with the lower thoracic epidural with the catheter placed at T8 level. For example, laparotomy, it is T4 to T12. Center of the space is T8. Catheter tip has to be at T8. Suppose you've planned 5 centimeters of the catheter inside, needle entry is 10 or 12. 3 centimeters is planned, needle entry is 9 or 10. And volume is, there's a 11 ml, 13.5 ml is a mistake, 1.25 ml per segment, 11 ml is the volume required. Schematic representation on the difficulties of the lower thoracic epidural compared to your lumbar epidural. Because of that angulation, you go between the 2 spines, you're going to hit on the upper border of the lower spine and difficulty in threading the space. So search for the lower spine, hit on the lower spine, withdraw needle, angulate to 30 degrees and go between the 2 spines to reach the space. For post-op pain relief, 0.5 segment per ml per hour, that is 5 ml per hour is more than sufficient for lower thoracic epidural to finish a laparotomy, post-op pain relief. Upper thoracic epidurals, mainly for mastectomies, reduction mammoplasty, CABGs, beating heart. For a modified radical mastectomy, block is from C6 to T6. The same principles of segment epidural applied here. Catheter tip between T2 and T3. Place 4 centimeters inside, 2 centimeters to cross T4 and 2 centimeters to cross T3, roughly come between T2 and T3. And 10 ml, 1.25 ml per segment. This is the angulation. Here again, one of the difficult epidurals to perform in the midline approach because of the overcrowding or steep crowding of the spines there. Same way, hit on the lower spine, increase the angulation, and you will be able to find the space. Technique, it can be midline, paramedian, the sitting position or lateral decubitus position. Coming to the cervical epidural, I'm unable to show you a video of the cervical epidural with the stimulating catheter because due to certain circumstances, the case which we are supposed to take a video got cancelled. Anyway, thyroid surgeries and head and neck procedures are being done. Segments to be blocked are from C2 to C7, same principles, catheter tip between C4, C5, 5 centimeter inside, and volume is 6 ml. Xylocaine with adrenaline, but a lower concentration is generally preferred in the cervical region because a little bit vary of the phrenic paralysis. So we use sensorcan straight away at 0.25% concentration. So what is the anatomical significance of the cervical space? How is it different from your other lower thoracic and upper thoracic spaces? They are narrower than the lumbar and the thoracic spaces. It's about 1 to 1.5 mm in width, and C7T1 is the easiest to perform. C6, C7 can be tried. Above that, it is a little bit difficult to do the epidural. The cervical dura is thick compared to the lumbar dura. So axial dural puncture is a bit rare when compared to the lumbar. But same way, the diffusion of the drug through the dura to reach the spinal cord is also less here because of the thickness of the dura. But one thing you must understand when you're doing a cervical epidural is the ligamentum flavum fails to fuse in the midline in about 20 to 30% of individuals. So the classical feeling of the needle in the flavum or the crossing of the flavum may be missed when you do a cervical epidural leading to a tap. So angulation cervical spine, the technique is never difficult because similar to the lumbars at 90 degrees. So what are the drugs? Sedation during cervical epidural anesthesia. Controversy is already a phrenic block, patient is having difficulty. Further drugs causing respiratory depression, sedatives use could be a problem. But my opinion is moderate doses of opioid or benzodiazepines alleviate patient anxiety and positional discomfort because most procedures, head and neck, sandbag is kept below, and sometimes the tracheal manipulation also. All these things also, this moderate dose of sedatives keeps the patient comfortable during tracheal manipulation also. The respiration is not affected by cervical epidural anesthesia. Cervical dura is thicker, so diffusion of the drug to the spinal cord is very less. Decreased concentration of local anesthetic is what we use, resulting only in a sensory blockade. Segmental blocks pass the intercostal muscles and they continue to help you in breathing. There may be a slight reduction in tidal volume and a slight increase in PaCO2, but they may be clinically insignificant. Patients are quite comfortable without much of subjective respiratory discomfort if it is segmental and you use your drugs and their concentrations wisely. Now coming to the epidural stimulating catheters, I have given you a rough calculation of what is being done. Based on the same thing, we are going to put the catheter, stimulating catheters and check on it. This is the epidural catheter stimulating set. We have a needle, we have a stimulating catheter, then we have a connector. The connector is connected to the connecting cable and it's also connected to the nerve locator, and we have an extension tube to give the drug. So there are 2 ports in the connector. 2 ports, one is for, here we connect the needle. This is for connecting it to the nerve locator, and this is for the extension tube. Say lower thoracic, side needle entry is going to be between T10 and T11. We generally push the catheter at least about 15 centimeters inside and slowly withdraw, right? So now we are connecting it. This is being connected to the nerve locator. Here, just unlike your peripheral nerve location here, a higher current is required because you cannot control where the catheter is going. It may be very close to the nerve, spinal nerve root, or it may be a little bit far away from it also. So once you start stimulating, you can see the catheter is a high level. T4 muscles are contracting near the breast. Current is 2. As I'm slowly pulling the catheter, you can see the lower contraction coming lower down. T5, T6. Finally, you can see it come up to T7 also. So this was exactly what we had talked about earlier in the manual method. it was similar. You can see at almost T78 you are having the contractions. Next, we'll have a video of a lumbar epidural being performed with the stimulating catheter. It is L3, 4, and 5. See, final end result is at around current of 2. You have to get the patellar tap, well, like when you do a femoral nerve, because this is for knee replacement. So L2, 3, 4. L3 was targeted as the catheter tip. So you can see the patellar tap of the patient very comfortably there. When you do for the lower limb, that's the ideal endpoint where you'll have to fix the catheter. We're having it at 3, we're trying to reduce the current. You have at 3, you will have multiple muscles moving because of the high current stimulating. As you lower down, you can see the patellar tap still being maintained. At 0.7, you're getting it. Actually, the surgery is on the other knee. The tap is on the other knee. You cannot control which side the catheter goes. Only the level you can control. Some very good cases which are being done under higher epidurals, especially cervical. These are all patients with comorbidities, with bronchiectasis and so many other problems, where though there were small procedures, cervical epidural was preferred. There's a branchial fistula, high neck mass here. Because of high neck mass, it was combined with a single shot mandibular nerve block also, as you can see here. A cervical rib being done under cervical epidural. This is a radical neck dissection surgery lasting almost 3.5 hours, along with the mandibular nerve block. It was done. Wide excision, patient is not intubated, quite comfortable. Good manipulation of the drugs is essential. Not only trying to put in a needle and a catheter in the cervical space, you must know how to manipulate the drugs. And sedation also. See, generally L3, L4 space is rarely used in any segmental epidural. Please don't use lumbar epidurals for abdominal surgeries. Try to go higher up. Almost all surgeries below the level of T1 can be done under segmental epidural anesthesia as a sole anesthetic technique. And especially when you're planning an epidural neurolysis for cancer pain relief, try to use stimulating catheters. But these stimulating catheters are a little bit costlier, about 1,000 to 1,500 rupees costlier than your regular epidural needles. But still, it can serve the purpose if the patient can afford. Otherwise, if you can't afford, go for the calculation things which I had spoken in the earlier part of my lecture. Thank you so much.
Thank you so much, sir. So as we are moving more towards selective nerve blocks and peripheral nerve, so we are also moving towards higher segmental epidurals and stimulating catheters playing a vital role in it. I'm sure a lot of questions on this topic will be coming in the final session after the final session by Dr. Himajyoti Das on kiddie spinals. Welcome, sir.
Good morning. This child in the photograph is a 4-day-old preterm neonate. He already had a surgery on day 2 under general anesthesia for repair of tracheoesophageal fistula. So on day 4, he led it up to OT with bilateral impending bilateral inguinal hernia. So we decided to not go again ahead with a general anesthesia, rather we decided to go ahead with a neuraxial for this child. So most of us are scared about going ahead with neuraxial anesthesia in preterm neonate because of the size. There are a lot of concern about the duration of the surgery, then difficulties, and also I'm going to answer those questions. How many of you actually use neuroaxial anesthesia in preterm neonate of, this child was 4 days and a weigh of around 1 kilogram and 400 gram, I believe. So how many of you will dare to do spinal in this type of child? Very few. In spite of report published in as early as 1909, neonatal spinal took a back seat actually because of development of newer anesthetic drugs and monitoring. But this publication in 1984 opens the eyes regarding rejuvenation of the use of neuroaxial anesthesia in this particular age group, because it has got several advantages. If we see, it reduces respiratory complications, particularly for preterm neonates. It has got cardiac stability, of course, and it attains the stress responses much better than the general anesthesia. But still, these concerns remain with us. As I have already told you, the possibility of neuroaxial injury because the spinal cord extends much below than an adult, then the hemodynamic changes and subsequent problems. Then comes at the end of 2016 this warning from US FDA. They said probably repeated use of general anesthesia or prolonged general anesthesia or even sedation in that last trimester of pregnancy can cause neurodevelopmental issues in neonates or in children. Immediately after that, this group, GAS group, they took an international multicentric trial to see if there is actually neurodevelopmental issues in neonates being exposed to general anesthesia. But they didn't mention about the duration, but they said that yes, any surgery below than 1 hour probably might not have an issue, but longer duration of general anesthesia exposure, particularly sevoflurane, and repeated use can cause neurodevelopmental issue in developing children. That's the reason probably people started to slowly switch over to neuroaxial than general anesthesia, particularly for subdiaphragmatic surgeries. The same group told us that regional anesthesia reduces the incidence of hypotension when compared to general anesthesia with sevoflurane. Then coming to this publication in BJA, whether hypotension that is induced when giving neuroaxial anesthesia can cause cerebral circulatory problem. But they said that though in spite of having hypotension induced by spinal anesthesia, there is no clinically significant decrease in cerebral blood supply. As you all know, probably, the anatomy of spine of a neonate is different from an adult or a teenage because the spinal cord extends up to L2 to 3 level. So the safety concern here is whether we injure the spinal cord when we give a spinal anesthesia in neonate. Can an ultrasonography help here? If you see, looking at this, another concern was that the volume of the cerebrospinal fluid in neonate. We all probably knew all these days that they have a larger CSF volume. That's the reason probably they have a shorter duration of neuroaxial blockade. But this study published in BJA said that irrespective of the age, it's the weight actually. The higher the weight, the volume is higher. That's 2 ml per kg. So when we give select the drug, particularly the volume of the drug, we should select according to weight rather than the age. Coming to the third part of them, a concern is whether I'm going to cause any neuroaxial injury by putting a spinal anesthetic into those preterm child. There are multiple publications, you will get it in net regarding the use of ultrasonography. In my patients, I used to do a pre-spinal scan to see the sac extension. You can see here, well, sac is extending up to L3, end of L3 level. Then you can see a very nice conus extending up beyond T2. So you can be very careful about putting the mark of that needle entry. So a pre-procedural ultrasonography scan really help you to avoid the neuroaxial injury in neonatal age group. Even you can take the depth from the skin to the canal, thereby exactly picking up that needle you need for. You need some tool for a successful neuroaxial anesthesia in neonate. You probably cannot, substitute those spinal needle specifically made for neonates. Like that needle is been shown here is 27 gauge 2.5 centimeter. That is 25 mm protein needle. These are perfectly good for that because if you use that hypodermic, I'll come back to that in the next slide probably. So you need an insulin syringe. I use insulin syringe particularly because the volume of drug given to these neonates are extremely low. So I calculate that actual drug, and then I take that in insulin syringe and transfer it to a 2 ml syringe. Then I give it, then you have got those particular BP cuff for neonates, size 1 to 3. These are very useful for those neonatal blood pressure monitoring. We get this calculation of dose from this publication, so I personally use this dose according to the body weight, and I use 0.5% bupivacaine in all my patients. As I was talking about, look at that needle curve, the cut here. The hypodermic needle has got a much longer cut, so you have seen the distance from the skin to the canal. This longer bevel needle can enter half of this inside the canal, half remain outside, thereby loss of drug into the outside the dura, thereby giving an insufficient block. So it is not a good idea to probably take a hypodermic needle. I'll share my experiences next 2 minutes. We have last year done around 21 neonate, mostly preterm neonate under mostly diaphragmatic, subdiaphragmatic surgery under spinal anesthesia. We use 27 gauge Whittaker-Arens protein needle of 25 mm length. And average duration of our all surgeries, all the spinal anesthesia was around 90 to 100 minutes. Most of the patients, I did it in sitting position. I found it much comfortable than in lateral. We do the pre-procedural scan, followed by that hemodynamic monitoring, as I have told you, the saturation probe and the blood pressure monitoring. I am transferring the drug from the insulin syringe to the 2 ml syringe. There's a small video here. You can see the needle is so thin, you need to go really very, you need to really go very slow here. You can see the needle is bending here. Give a little bit of local and put a mark with a IV needle so that the needle enters a little easily. I usually do a little bit of barbotage because the volume of drug is extremely small, so the drug might remain in the needle. So do a little bit of barbotage and inject the drug very slowly. And you can see the same child undergoing, you need a little bit of patting around and the child sleeps very quietly. They usually don't need much of sedation. This child was operated on both sides, inguinal hernia. So to take home message, infant spinal is an attractive alternative to general anesthesia, particularly for preterm neonates. In spite of marginal hypotension, cerebral oxygenation doesn't alter. Pre-procedurals can definitely improve the success rate and safety, and the surgery of 90 to 100 minutes probably is possible with neuroaxial anesthesia. Thank you very much for your kind attention.
Thank you, sir. So we have had enlightening topics, these 4 topics. We have around 12 minutes for the question answer session. 8 minutes. So it's open to the audience.
This is a question to Silamban. He demonstrated that very nicely about those stimulating catheters. Just wondering, why would you require such a higher current in the epidural space?
Basically, why a high current is placed is because you are not in control of the tip of the catheter where it is going to go. You just push the catheter inside, it goes up. Once you have a higher current and you locate the space, you can see in my second video, the current was brought down to almost 0.7. That is why I use a higher current when I started on the epidural space.
So one more addition, if you get a unilateral stimulation, is that good enough or?
Yes, sir, because I said the tip of the catheter, whether it is going to go to the left side, right side or the center, you cannot decide. So whichever side you get a unilateral stimulation, it is quite sufficient. You can give the drug, provided it is at the segment where you want it to be.
It does not mean it is paravertebral, or you need not go for that.
That is always a problem. But what you should understand is, if it is paravertebral, we have almost pushed the catheter in for 15 centimeters and we are pulling it from there.
Okay.
You can see the contractions of the breast, at the breast muscles, as I was pulling the catheter. Suppose if it has gone paravertebral at T8 level, those muscles are not going to contract.
Okay.
So you know that it is not paravertebral because of that. But unilateral contractions, yes, paravertebral is a possibility.
Okay.
Yeah, my question is again to Dr. Silamban. What is your take on shoulder surgeries under cervical epidural? Because the surgeons tend to give a propped up position or beach chair position. So,
Madam, any procedure in the neck and cervical epidural is very good. But the problem is, you cannot have a very high concentration for long duration procedures, like 0.5% sensorcaine, 2% xylocaine, adrenaline, twice or thrice you repeat the dose. Suddenly some kind of discomfort patient develops. So with about 0.25% sensorcaine or with 1.5 xylocaine, you are able to complete your shoulder surgery. It is quite good. Post-op pain relief is also going to be quite good.
so my question is about the position. They give propped up position. What I have observed before
Whenever you have a propped up position, probably the first dose will have to be sensorcaine for longer duration of time, but you'll have to increase the second dose volume. Because
have observed that the
gravity
block-
plays lesser role in epidural than in your spinal.
I have observed the block below. I mean, rather
That
than
does happen, madam, because you're increasing the volume and gravity does play a role, but it is significantly lower when compared to spinal.
the surgery duration has to be limited.
Yes, madam.
Thank you.
Again, no, don't sit down. One more question. Well, what would you think if you get robust contractions of wherever you want them to be at lesser currents? Would that not bother you actually?
If at a lower current, say 0.2, 0.3,
Yeah.
you're going to get it. It certainly bothers you.
Yes.
But that time you can take into one consideration, it's because of the dural sleeves are covering the spinal root. Probably your needle is more closer towards the intervertebral foramina where the dural sleeves are almost lost. So at that point of time, at lower current, you can get a very good stimulation. Next is you're extremely close to the nerve. That fear is always there.
Would you also not fear that you probably are in the CSF itself?
May not, madam. How could you be there in the CSF when you don't have, when you aspirated, everything has been done? And
Yeah.
what regular precautions which you have taken for epidural, you have taken here also. It is
Sure.
nothing different. You just don't go blindly with the catheter.
Right.
All precautions which are in regular epidural is being taken here. The stimulation with higher epidurals, you want a segmental epidural. So based on calculations, we place the catheter at that point. Whether it is correct or not, whether it is reached or not, whether it is doubled on itself or not, we do not know. So for that reason alone, you're using the stimulating catheters to have a lesser volume, correct block. So you can wait.
So bilateral contractions and contractions at 0.1 milliamperes, that would suggest intrathecal. Himjot, just one, you have time?
Yes, 4 minutes.
So Himjot, that was a very nice demonstration about the kiddie spinal. We don't do much nowadays. I used to do it in the past in the lateral position. So is there any difference between a sitting and a lateral in a kid? About the spread and the adequate clinical anesthesia?
I personally do mostly sitting because I'm little comfortable about that. And as you have said that I compared both scanning of the sac in lateral and sitting. Sitting, the sac comes down a little more anatomically. So if you do a scan laterally and try to make the performance sitting, you better do a pre-procedural scan when the baby is sitting. And I have done few lateral, but mostly sitting, but I haven't seen any clinical difference in duration in both. That's my personal experience, observation.
Any questions?
This is to Dr. Himjyoti again. I mean, you have used the spinal, but can we replace it with the epidural? Will it be the same effect? Caudal epidural?
Yes, why not? But as you know, the spinal gives a much better block with a much lesser drug. So I'm much comfortable with spinal for subdiametric surgeries than caudal probably. But we
So
can
you will be using hyperbaric, sir.
I'm using hyperbaric, 0.5% bupivacaine.
Okay.
Yeah, Hemjyoti. Now, but it's fantastic what you do. Yes, there is a great role of spinal in babies. I totally agree. I've done that, been there. What I mean, we can just share with each other here openly. What I feel is a caudal epidural can be as strong as a spinal, can be as solid, motor block, as spinal. It probably shall linger even before 100 minutes, because most of our surgeons, at least sometimes, can really get caught up in bilateral inguinal hernias in this age group. So we used to do spinals before, but somehow we went more towards.
Would you personally like to go for a caudal or a spinal?
I would personally like to go for caudal with bupivacaine and lignocaine adrenaline, so that I get a very good motor block. And I'm not worried for even a couple of hours post-op. I would like that lingering analgesia that I would extract. So
the point is, this child was 1.4, and you know, the caudal drug, how much you're going to use here?
Yes, wonderful question. That needs a kind of a calculation. 1.4, so we can actually go to, if it's hernia T10 level, so we'll go to 1.4 ml per ml as such for this kiddo.
That's the reason probably I consider spinal giving here, because the child is too small, and drug volume calculated for this child will be pretty small, and I got a good block with a very small dose of spinal. Of course, caudal can be a good attractive alternative to that. Yeah, thank you.
Did you have any dry taps in this?
No, sir. At least in these last 21 cases I gave a record, I didn't have any dry tap. I'm going to talk on that, I think, day after tomorrow, on dry tap.
Thank you, sir. Again, a question for you. I am Dr. Narayanan from Andaman Nicobar Islands. So, thanks for the fantastic work you are doing. We have a pediatric surgeon who does most of the cases laparoscopically. We do herniatomies for babies, basically infants and neonates. But since it's laparoscopic, we do give GA for all the cases. So in pediatric spinal, we do frequently, more than 1 year and 2 years for all the surgeries. We do give caudal as post-operative analgesia only. And it's, as like ma'am told, it's like 0.25% bupivacaine. It's for analgesia. 1 ml per kg is the dose which we usually give. And a small doubt which I was thinking is, can we give a Taylor's approach for the neonates which you give? Will it be beneficial, because it will be still low weight, L5S1. Will Taylor's approach be beneficial?
To answer that, I think we have a good pediatric anesthesiologist here. I haven't tried myself any Taylor approach till now, because I use most of the time ultrasonography and to identify the space, and in this last series of cases I never failed.
Yes, sir,
So,
fantastic.
ma'am, if you can
Ultrasound is obviously very
you
useful.
can probably add on that, any role of any Taylor receptor. Yes.
No, we've never required any Taylor's approach. And I guess I would want you to take just one little message from here, if possible. Yes, 0.25% bupivacaine or 0.2% ropivacaine is going to give an analgesic block, but please add lignocaine adrenaline to it. It's going to give a surgical block to you. So surely, and it will help you build up the volume of say 1.4 or 1 kilogram.
Oh, fantastic. Ma'am, actually he does laparoscopically even for the neonates. So, okay, thank you, ma'am. Thank you very much.
There's a minute, you can.
Not a question, just a comment. I see that nobody complimented Jayashree Arbi for her wonderful lecture. That was a good lecture.
So one question to her is if we don't have point of care testing, is there any role of giving any platelets as a cover?
Yeah, just a question asked by one of the delegates now. The issue with patients who come on clopidogrel therapy is, if we decide to give them antiplatelets, the SDPs or RDPs, how will we measure? These studies are there in probably HELLP syndrome patients coming to us, where they will have low platelet counts, And when you give SDPs or RDPs, you have a measure value of how many platelets have increased. Here you are dealing with a patient with a normal platelet count. And how do we measure that whatever you have given is adequate or not? This is first question. And second issue is, we saw this patient. She's come on clopidogrel therapy for a significant thromboembolic risk. And she's already hypercoagulable. If you decide to give platelets in this patient, especially if this patient has come for is with coronary stents, she will land up in stent thrombosis. So we do not have any guidelines. Whatever the literature suggests is volume given is from 5 units of SDP to 10 units of SDP, but they all describe for emergency removal of epidural catheters. And these are all sporadic studies. So right now I will not, I'm not in a position to comment about platelet therapy.
Stick to point of care.
If you have, otherwise the choice is, what we are worried about more is the medico-legal aspect. Many a times we know that probably with a single shot spinal we will get away. And even many studies like National Audit Project of Royal College of Anaesthetists and ASRA close claim studies, you will find that spinal anesthesia is associated with very minimal or sometimes zero incidences of epidural hematoma. But still we are worried because of the spontaneous nature of hematoma which can occur in these patients. But we can still go ahead with an informed consent in patient where we can establish that there is a significant risk for general anesthesia. That is the only thing. And that decision has to be made by the patient after you explain the patient properly. And when you decide to go ahead for spinal anesthesia in this patient, the monitoring part is very important. You have to have at least 2-hourly monitoring instead of the 4-hourly monitoring. And problem is the patient is already under spinal sensory block. And so that becomes a little tricky issue here.
Okay.
That's it.
Okay. This was a nice discussion. We'll keep the session closed now.
Thank you, Dr. Sachin, Dr. Ketke. Going on to the next interesting session, paraneuraxial and interfacial plain blocks. I invite the moderators, Dr. Soumita Christopher, Dr. Serena Ruth.
Having looked at the upper limb blocks and the neuraxial blocks, let's come to some serious business. So we're going to talk about some technically challenging block. And for the first talk, I would invite Dr. George Fagel to come to the dais to deliver his talk.
So hello again. Oops, first slide is missing, who cares? My talk is about now the paravertebral block and the anatomy about the paravertebral block. First of all, concerning the anatomical point of view, I have to recommend that this is not a special term for that. Anatomically, this term does not exist at all. Paravertebral space is not described in the anatomy textbooks neither, nor in our huge book about anatomical terminology, either in Latin or in English. Anyway, I absolutely agree with the clinicians. There is a space, and it should take a name too. So this term is quite a useful and a correct term, which should be included in our terminology at all. So what is this term? What is this space? What is it about? As you see, it's a definition which is the space being located lateral to the spine area, which includes either the vertebral body, which is the more ventral area, and the intervertebral foramen, which is the dorsal part of this space. The content is also quite interesting because you have the spinal nerve passing through the intervertebral foramen going laterally, as you will see it in some images later on, and then dividing into ventral branch as usual, as you already heard about the brachial plexus, and in the dorsal branch. The dorsal branch runs dorsally and passes through a tiny small foramen, which is the costotransverse foramen, then to split again and to reach the dorsal areas. The ventral one passes laterally and ran laterally as the intercostal nerve you know. In addition, of course, you have several more structures, which is the sympathetic trunk, very ventrally, and the communicating branches from either the spinal nerve or already a little bit more laterally, running and having the connection to the sympathetic trunk, which is located more ventrally. Unfortunately, you also have, of course, vascular structures, which are arising from the aorta or, let's say, other origins. For example, one of the trunks arising from the subclavian artery, or you get veins draining either in the hemiazygos or in the azygos system. So, you have this space. It's a tiny space, but also get an enlargement in the dorsal area. If you just take a look on this cross-section, you see over here the rib area with the head of the rib, and also this area with the vertebral body. Some huge ossifications. Anyway, it's more important this area where you have the paravertebral space very close to the pleura. You see the spinal cord in the canal, and then the intervertebral foramen. So at this level, you do not really see a huge space. This space is visible if we put or take or remove the rib. And this is the next slide. You see the pedicle arising from the vertebral body, and then the huge space over here, which is the intervertebral foramen with the spinal nerve, and then dividing into the ventral branch and the dorsal branch. And the dorsal branch already over here passing the small, tiny costotransversal foramen. So over here you get the communicating branches running over here to the sympathetic trunk, including also the vascular structures. So it's a space, nevertheless, very small indeed, but with a very clear anatomical structure at that time. You can see this is the so-called superior costotransversal ligament, which is visible in ultrasound, and therefore one of your very decisive anatomical landmarks. When you pierce this ligament, you are in the paravertebral space, and you will reach a wonderful vertical spread also, not only a horizontal one. So, if you take this again in the drawing, unfortunately the scanning was a little bit too, as you see, enlightened, but nevertheless you see the intervertebral foramen and the costotransversal ligament. Over here this is the pedicle, or let's say, or go to the lamina, costotransversal foramen, and this is the paravertebral space where you get all your different nerve structures. Another cross sections over here, where you see this is the spinal canal over here, and then passing through. This is the paravertebral space again. You get the rib over here. It's quite huge, or let's say huge from the anatomical point of view. Nevertheless, be aware, of course, of the close relationship to the pleura, and just move or advance your needle when your needle tip is visible. If you do not see your needle tip, you must not advance, because then you know that it might pass and pierce the pleura and you get a pneumothorax. Enlarged, you see now over here, these are the ligamentous structures, and if you advance the needle just beneath, or let's say ventrally, to this superior costotransversal ligament, again, which is visible and identifiable in the ultrasound, then you reach the paravertebral space and you will have the spread. So if you reach it, you get the vertical spread. And this is, for example, a latex injection into the paravertebral spread. Nevertheless, this was another background, what we tried to get, a little bit about the myth of the erector spinae block, which is also described and published. Well, as I say, this is already the sympathetic trunk, which is included in our latex injection. So it would also create, let's say like that, a sympathetic block reaction. And also it's running along the intercostal space. So this is slightly the ideal way. Nevertheless, this was caused by an erector spinae block technique, not a paravertebral block technique. If you take the paravertebral block technique, this would create much larger vertical spreads to even more than 5, 4, 6 segments, 7 segments. It's depending a little bit on your block. However, you see the pleura is very close. It would be a little bit like a bulge being pushed away by your local anesthetic. Again, injection, you see the paravertebral space over here with the sympathetic trunk, and your region of interest is in this area where you reach the needle with, and after piercing the supracostotransversal foramen. Okay, so be aware of this anatomy, especially when you perform it under ultrasound guidance. If you really do not follow the guidelines, if you do not see your needle tip, you might create something like that. Really, it is not an easy way, so you really have to train it, either on cadavers or either on cadavers or either on cadavers. I'm not pretty sure if you should train on the living, because just imagine if you are the patient and somebody is training on you. So use really each or every cadaveric workshop and try to enlarge your experience first. If you do not respect also, everything might burn, yeah? And you really just go almost into hell, because this is something which is not quite easy concerning the complications you might create. What else can be with a paravertebral block? Of course, the spread medially into the intervertebral foramen. Well, okay, it depends a little bit on the area you're going to. But anyway, even if you have a spinal epidural spread, it's not that bad. It's already described that it's going contralaterally, so passing through the canal, but that's depending also on the volume you use, of course. Okay, so that was it from the anatomical point of view. I hope I didn't bore you too much. So thank you very much for your attention. Still not broken. Come on.
Thank you, Dr. George, for your excellent insights on the anatomy of the paravertebral space.
Yes, as we learn more and more about the anatomy, we want to relearn and unlearn many things. And so as we are also advised to go more, practice to go more laterally, but there is still a resurgence of the interest in thoracic paravertebral space and the blocks. Now, I call upon Dr. Anjali Chabra to come and give her thoughts. She's come. I think she's just come straight from the airport.
Hi.
Thank you, ma'am, for coming, and over to you to share your thoughts on this topic.
Can I get my specs for a second? So after the last talk, which I happened to listen, I'm going to be talking about, is there a resurgence in the ultrasound-guided paravertebral block? And we have so many choices where the breast and chest surgery is concerned. We have the thoracic paravertebral block, we have the erector spinae, the pecs, and the SAP block. That's why maybe the confusion. And my previous speaker, Dr. Figel, has already talked about the anatomy in detail, but we know that we need to deposit local anesthetic in this wedge-shaped space, and we can produce ipsilateral anesthesia or analgesia without hypotension, motor blockade, and if you put in a catheter, we can also get extendable analgesia. So very briefly, this block has been around for more than 100 years, introduced in 1905 by Hugo Selham because he was very upset with the hypotension produced by the spinal. And then in 1911, his student used the paravertebral block to map the visceral innervation of all the organs. In 1919 was the first time it was used for anesthesia for laparotomies. And then with the use of the introduction of the muscle relaxants, the block fell out of use. 1977, they were going to write it off, but in 1979, Eason and White resurrected the block, and they introduced the loss of resistance technique and also insertion of catheter. And then from 1995 onwards, a lot of thespians such as Greengrass, Karmakar, Chima, Longquist, they reintroduced the block. And there were so many publications on the use of the block for breast surgery and chest surgery. And then, of course, from 2000 onwards, with the introduction of the ultrasound, the block got a new lease of life. So why are we so concerned? So though we used to seeing that very nice picture, I'd like to show you this picture by Bozert et al., where he shows that the paravertebral space is actually pretty narrow. That's already been covered. And the distance is actually only 7 millimeters. So most anesthetists believe in primum non nocere, so they're scared of pneumothorax, and they'd rather avoid the block. Then epidural spread can occur, vascular injury can occur, and the block requires a bit of a technique. So if you have failure, people tend to shun the block, and there are easier alternatives available. These micro-CT images by Cho et al. Also show the proximity of the pleura to the intercostal vessels, nerve, and also the proximity of the superior costotransverse ligament. So that just emphasizes why this block keeps going in and out of fashion. And for usually to do this block, it's at a depth of 4 to 6 centimeters. We use curvilinear probes. In thin, very thin patients, we can use linear probes. But now we have curvilinear high frequency probes. So we can see at a depth with better resolution. And also we have these echogenic laser etched needles. So we can see the needle enter the costotransverse ligament and stay above the pleura. These are, of course, just a few clips to show you that. You can see that the needle is coming in. It's going through the costotransverse ligament. And then when you give saline, it falls away. So it's quite more visible than what it was earlier. This is at another level in the same patient. You can see the tip of the needle also very clearly. And so visualization has become much easier. Now, the erector spinae block is a very new block, introduced in 2016 by Ferrero and colleagues. They used the block for producing neuropathic pain relief in a patient. They introduced the needle from cranial to chorda, deposited local anesthetic above T5 between erector spinae and T5, and they got widespread sensory analgesia. And this block caught up like nothing. They did CT reconstructive images showing drug spread from T1 to T9. They also did cadaveric dissection showing that the drug might be going through the costotransverse foramen into the paravertebral space and blocking both the dorsal and ventral rami. So this block was easier to do. It was far from the pleura, dura. There was a definite end point. You just have to deposit drug above the transverse process, unlike the paravertebral where you got to bring the needle close to the pleura. And they said there was widespread pain relief. So it was being used for every possible unilateral surgery, and it caught on the imagination. Though there were papers saying that it doesn't produce anteromedial anesthesia or analgesia as required, these papers were largely ignored. A meta-analysis was done by Hussain et al. In 2020, and they said that, this block, they compared it to control for breast surgery, and they said if the difference in morphine requirement over 24 hours is more than 30 milligrams, oral morphine requirement, that means IV 10 milligrams, then we'll say that the block is clinically significant. It's only statistically significant, it's not clinically significant. They did not find a clinically significant difference. Similarly, in the pain scores also, they did not find a clinically significant difference. And in 2021, Longquist, Karmakar and Richardson, who are again thespians of the paravertebral block, they wrote this daring discourse saying that it's time to let the erector spinae block be, because the quality of the cadaveric dissections, there's no standardization. One cannot be sure the drug can go through a narrow foramen into the paravertebral space in cadavers. And the meta-analysis have shown, in addition to Hussein's, there were other meta-analysis, they've shown that it's only better than placebo, the erector spinae block, and this might be because of the systemic absorption of local anesthetic from the erector spinae space, and therefore further studies need to be done where the control group gets similar systemic concentrations of local anesthetic. Now we also know we have the PEX and the serratus plane block for breast and chest surgery, and PEX2 involves PEX1 as well, and PEX2 involves depositing local anesthetic above the rib and between the pec minor and major, and the serratus plane block involves going little laterally and depositing drug between the latissimus dorsi and the serratus muscles at the level of the fifth rib. Now, Franco, he said, why go that lateral? You don't want to block the thoracodorsal and long thoracic nerves. So he said give at the fourth rib between pec major and serratus. And all these blocks block the intercostal nerves, which the paravertebral block is doing. So how do we know which is the best intervention? There was this network meta-analysis that was done by Dr. N.P. Singh and colleagues. He's from Chandigarh, and published in Canadian Journal of Anaesthesia in 2022, where they've combined a number of RCTs in one analysis to find which is the best intervention for breast surgery. They included 79 RCTs comprising of 5,686 patients, out of which 54 underwent major breast surgery, 51 RCTs used the ultrasound, and primary outcome was pain at rest at 24 hours. And what did they find? If you see the pain at 24 hours and morphine requirement, the best block is the continuous thoracic paravertebral block, followed by the SAP block, and followed by the continuous wound infiltration. But the studies were of inferior quality and had a lot of heterogeneity, so it was removed. If we compare pain at 24 hours and PONV, again, the best block is the continuous thoracic paravertebral block, followed by the SAP block and the single level thoracic paravertebral block. So paravertebral block is found to be consistently ranked higher than all the other outcomes for breast surgery, and prospect guidelines also say it's the first choice for major breast surgery. And with the ultrasound, a single level paravertebral block is non-inferior to a multi-level paravertebral block, so chances of complications are lesser. As far as analgesia goes, you can use a single level paravertebral block. Now, complications can occur, but the incidence of pneumothorax, number of studies have studied this, including Cochrane meta-analysis by us. And in this particular network meta-analysis, they said the incidence of pneumothorax is 0.9%. That's less than 1%. Epidural spread and vascular puncture is less than 0.5%. That occurs otherwise also. It's not that it is life-threatening vascular puncture. So though complications can occur, if you're wary of them, they are not such a high complication rate. Then PEX or SAP block are alternatives. And continuous wound infiltration, like I said, is ranked lower. And in this network meta-analysis, they found the level of evidence was moderate to very low. So we need to do further studies and further work to find out which block is the best. Thank you. Questions are at the end.
Thank you, Dr. Anjali, for the in-depth insight into this topic, and definitely we cannot do away with this champion of peripheral nerve block.
The question and answer sessions will be in the end.
Thank you.
Now I invite Dr. Archana to give her talk on ultrasound guidance for thoracic epidural space.
I think, yes, good afternoon, everyone. Welcome to Pune, and thank you to the organizers for having me here today. It's my privilege to talk about our work. I'm from Pondicherry. I work alongside my boss, Dr. Shiva Shanmugam, to whom I owe all my ultrasound regional anesthesia knowledge. Sir, this is dedicated to you. So with that introduction, let me start. So I'm going to disclose here, this is a brief technical report. You've already seen the landmark technique being shown, the loss of resistance. You've also seen the stimulating catheter. So let's see what we can do with the ultrasound. So the outlay of my talk today is basically I'm going to connect with the lumbar spine because that's what we are all familiar with. And then finally, we will look at our approaches, what we follow, the ultrasound-assisted approach and also the guided approach. So yes, why is the lumbar more easy? We can very clearly see what it is. You can see the spinal cord. You can see in the ultrasound the posterior complex and the anterior complex. But when it comes to the thoracic, everything is closed off. The spine is closed and totally shielded within the bony canal. So how do we navigate this? Well, you all know you routinely use the paramedian approaches. We use a very steep angulation. Almost the entire needle goes inside. And it's quite difficult to manage, and the failure rate is also high. That's why sometimes they say the cervical is actually much more approachable than the thoracic. So we're going to focus more not on the lower thoracic levels or the higher thoracic levels, but more on the mid-thoracic levels. So just to recap and review, this is the lumbar views that everyone knows, all the tried and true and proven signs, the trident sign, the camel hump sign, the horse head, the tower, and sometimes the cat head or frog head, whichever one, everyone knows what these signs are. So let's just take a quick look at them. This is the sonoanatomy. We all know the transverse process view where you see all the trident sign. But when it comes to the thoracic spine, you have here with you, we have ribs. So when you do have and you start at a lateral approach, you identify the ribs first. So here you call it the parasagittal ribs or costal view. So how you identify? Well, the most glaring thing and the brightest thing that you can see here is the pleural line. And that is how we identify that you are on the ribs and not anywhere near the neuraxis. The next thing you do is we want to move into an articular process view, and that's where you get your camel hump sign. So this is the articular process. You can see it on the spine model as well. But when it comes to the thoracic, as you go medially, you're going to start seeing the change in the anatomy of the bony shadow. So the rib starts joining to the transverse process, and now you have the costotransverse joint. You will also notice that below, at a lower point, the pleura actually starts to disappear as you're going closer and closer medially, right? So this is the costotransverse, parasagittal costotransverse view. Next, when you come into the lumbar, we go from the paramedian sagittal to a paramedian sagittal oblique view. In that, you look at the horse head appearance, and here is where you beautifully can see your targets through the interlaminar space. That is your posterior complex and your anterior complex. But what happens in the thorax? Well, if you go medially still, this is what you see. And most of the times, the bright white line, we mistake it as the posterior complex. But in fact, when we try to attempt or put a needle at this point, we always encounter resistance, that is a bone. So there is a study also on this that has also mentioned that more often than not, this is the superior articular process of the interacting vertebra and not exactly your posterior complex. So then this is the third view that we look here in the paramedian sagittal, and getting an oblique view, this is the same image that you're going to get. It does not ever go into an interlaminar space. Very few cases are there, that is in very young adults, or very thin, lean individuals, where the interlaminar space can open up, but again, that is very rare. So then what do we do now? How do we approach it? How do we get it there? Right, so that's the superior articular process. I've just zoomed in to illustrate it further. Then you come to the transverse view. In the lumbar spine, you have two views, as you know. One is the spinous process view, and then you have the interspinous process view. But when it comes to the thoracic spine, you only have one view, that is the tower sign. However, there is a modification a little bit on this. In the thoracic epidural, if you're looking at the thoracic the vertebra, and you start in the midline, this is the view that you will all see, right? As you move laterally, you can see that the transverse process comes into view, and what hump you're seeing here laterally, that's where my center line is, that's the transverse process. So this is the transverse view where you can see the spinous process and you come to the transverse process. Let me just show you that again. And as you move the probe down, so I'll just have to play the video a little bit here. This is where the transverse process is. If you move the probe down, you see that the transverse process is missed and you're actually coming to the articular process view, right? So this is much more closer to your central neuraxis, and this provides the point at which you can access, or the level at which you can target your interlaminar space. So we move on to the ultrasound-assisted approach and how we mark it on the skin. So this is one that everyone is familiar with when you do it in the lumbar region. You mark the center, you mark your the best intervertebral space that you have, and then you look at the approximate depth. Of course, in the thoracic, this does not apply. When you use the marking that I've showed you in the views that I've showed you, I'll elaborate on this a little further. This is the endpoint marking that we get. So we are calling this a box-in-box technique approach to the ultrasound-assisted thoracic epidural, right? So let me just further elaborate to you what this is. The center line, or the first line that you see here, is marked in the transverse view at the spinous process, right? This one is the articular process. I'll further elaborate to you, don't worry, okay? And then the horizontal lines are the interlaminar view. So when you superimpose this image onto a spine model, you can see what I'm talking about, right? You identify the spinous process in the center, then you miss the transverse process and you get the articular process just paramedian. And then you have, this is the interlaminar space of T6, T7, this is T7, T8. So our target is going to be where now, right? Let's take a look at that again. So this is our interlaminar lines, this is our spinous process line, and this is our articular process line. And now you have your box. So your needle approach is going to be from the middle of the box, and you're going to direct it medial and a little bit cephalad just to get to your, so your interlaminar space is going to be behind this point right here, okay? So this is done in real time by Shiva sir. So how he has done this is, again, he has identified, he has scanned it, and the minute he goes in, he can feel a bony resistance, that's the lamina. So then he just redirects himself, since he knows the direction of where the articular process is and the spinous process is, and he redirects accordingly till he gets his, feels the ligamentum flavum, after which he will be attaching the loss of resistance syringe. In this aspect, he knows where to go and how to direct his needle. How far to go? Well, that's a different story altogether. You still have your loss of resistance technique, so that tells us how far we can go. Right. And we'll have the loss of resistance. Yes, okay. So this is the assisted approach. Now let's move on to the ultrasound guided approach. So this is where you are in full real time, we are doing it on the patient. And this is how the scanning happens. So you start at the transverse view. So we're looking at the costal view where you see the ribs. And then from the ribs, you need to move medially. As you move medially, you will see that these ribs are changing over into the costotransverse joint. And as you go medial still, it will finally become the laminar view. So these are the lamina, and this is the superior articular process that you can see. Now, from this point, what we're going to do is we're just going to rotate the probe a little medially. That is, the cephalad end is going to move medial, and the lateral end is going to, the caudal end is going to move lateral. So what this actually does is it gives you a paramedian approach into a directed approach towards the interlaminar view. Where here you will see of the lower vertebra, this is the transverse process of the lamina of the view of the space that you need to approach, and this will actually be the base of the spinous process. I'll just show you a spine model of how that can happen. So in a vertebra, this is the approach that we are taking, where you are on the distal caudal end, you are seeing the lower transverse process. In the middle, you are seeing the T5 lamina. So if I was approaching to a T4, T5 interlaminar space, I am directing it. So this is the base of the spinous process shadow that I'm seeing here. My needle angulation and target is going to go in this paramedian fashion. So we, in our group, we are calling this the paramedian cross view, also known as the PX view. Please look out for our publication. And also, please do come for more details and information on how we do this to our workshop that is going to happen at Manipal Hospitals on Sunday. Thank you very much.
Thank you, Dr. Archana. Now I would request Dr. Vandana to please come on the stage and deliver her talk on the transverse process where to inject laterally at the mid-axillary line.
Good afternoon, everyone. At the outset, I would like to thank Dr. Diwan for giving me this opportunity to be here. I bring greetings from Jaipur, the pink city of India. This is where I work, SMS Hospital, my alma mater, SMS Medical College. So, nerve blocks have traveled a long way from central neuraxial blocks to peripheral neuraxial blocks to facial plane blocks. And we have a big list of facial plane blocks and new plane blocks coming every day. So, where to inject? Laterally at the mid-axillary line. I'm sorry for that spelling mistake. So I think we all are clear that we're going to talk about the SAB block. So the outline would be from evolution to evidences to spread, indications, how to do a SAB block, and the message to the performer. So serratus anterior plane block, as we all know, was introduced in 2013 by Dr. Rafael Blanco, and we are all fortunate to have him for this academic meet, so we can clear our doubts with him. He thought of it as an alternative to thoracic epidural or thoracic paravertebral block. A lot has been talked about since morning about them. So he took 4 volunteers, primarily to block the thoracic intercostal nerves for analgesia of hemithorax. 0.125% levobupivacaine was used, and 0.4 ml per kg with 0.1 ml per kg of gadolinium was injected on the 5th intercostal space in the mid-axillary line to record the degree of paresthesia by pinprick and the extent of spread by fat suppression, MRI. He found a very consistent sensory block from T2 to T9 of the hemithorax. He had injected the drug superficial to the serratus anterior between the latissimus dorsi and serratus anterior. Now, let's look at what is the evidence available for this block. So, the SAB block has been used in thoracotomy and VATS, and they have found it as a useful adjuvant to multimodal analgesia. It has appeared to be safe and effective way of analgesia in thoracotomies, VATS, minimum invasive thoracoscopic surgeries, and also in minimal invasive heart surgeries. So, a meta-analysis finally concludes to say that it is a study of 2020. It says that the SAB block plays an important role in the management of pain after thoracic surgery by reducing pain scores, postoperative opioid consumption, and PONV. Another situation in which it has been used is breast surgeries, which Dr. Anjali has already elaborated. And they have all come to a common conclusion that it is useful in breast cancer surgery. The block is given before general anesthesia is instituted, and usually the dose is 0.4 ml per kg of either bupivacaine or ropivacaine in varying concentrations. The sensory block is mostly anterolateral, and the time to first rescue analgesia is delayed. Opioid consumption within the first 24 hours is decreased, and the block has been administered both superficial or deep to the serratus anterior muscle, but the results have been similar. The effective postoperative analgesia decreases the prevalence of chronic post-surgical pain also in these situations, which is a common problem. SAP has also been used in rib fractures, and it has been described to be, although there is no robust evidence at present about SAP being definitely that it offers an advantage in terms, there is no robust evidence, but there is no doubt that SAP definitely offers advantage in terms of pain scores, decreased opioid consumption, less pulmonary complications. And we have a study by our own Dr. Sandeep Dewan and Dr. Nair. They have also recommended the use of SAP at an early stage in multiple rib fractures. So now let's see what's the evidence on spread of the drug in this particular plane. So there have been a couple of studies on the cadaveric studies, and they have injected 20 to 40 ml of the methylene blue dye, both superior and deep to the serratus anterior muscle, and they have found that the spread of the drug is more when the volume injected is more. Then another study, they again tried doing, they found that the spread of the drug was similar, but the medial and lateral pectoral nerves were not frequently stained. Then this is a study about the spread of the drug in cases of rib fractures. So mostly the clinical presentations, whether it is thoracotomies or it is breast surgeries, the spread of the drug is mostly seen anterolateral. But in rib fractures, because of the breach of the continuity of the various tissue planes, it is seen that even the drug is seen to spread posteriorly also, which probably explains the effectiveness of this particular block in posterior rib fractures also. So we can say that the indications would be breast surgery, chronic pain after mastectomy, rib fractures, thoracoscopy, thoracotomies, and contraindications would be the routine ones, but yes, surgical emphysema is going to be a hurdle in these cases. So how to do the SAP block? The patient can be positioned supine or lateral. The probe will usually be a high-frequency linear probe, unless the patient is very thick. It's in the mid-axillary line in the 5th intercostal space. An echogenic needle, if it is available, should be used. Otherwise, the other routine needles that we are all using for doing the blocks can be used. Bupivacaine or ropivacaine can be used. Usually the volume used is 20 to 30 ml, and the site of deposition can be superficial or deep to the serratus anterior muscle. So 3 sites can be there. Either you can deposit it superficial to the serratus anterior muscle, deep to the serratus anterior muscle, in the mid-axillary line in the 5th intercostal space. And this is a modified approach where you deposit the drug superficial to the serratus anterior muscle, but the probe is placed in the posterior axillary line in the 6th intercostal space. So when it is deposited between the latissimus dorsi and serratus anterior is the superficial block, and when it is between the serratus anterior and the intercostal muscles is the deep block. So this is how we will place the probe in the mid-axillary line, and this is what a sono picture would look like. So there's nothing comes for free. So if we're not careful, we can cause damage. So there's a case report on pneumothorax following serratus anterior plane block. So deep serratus anterior plane block was done after induction of general anesthesia on a spontaneously breathing patient on the 5th rib in the mid-axillary line. And the needle was directed from caudate to cephalad in the coronal plane. And the trajectory of the needle was flattened to avoid, and advanced to extend the hydrodissection to the 4th rib. And they landed up with the pneumothorax. So the message is that SAP block is a useful and promising component of multimodal analgesia for anterolateral thoracic wall procedures from breast to post-herpetic neuralgias. It provides analgesia in posterior rib fractures also. It is easier and safer to deposit the drug superficial to the muscle, as the results are similar both when the drug is injected, either superficial or deeper to the serratus anterior muscle. The time to first rescue analgesia, pain scores are less, total opioid consumption in first 24 hours is less. Evidence is insufficient to support that it can substitute thoracic epidural, paravertebral, or erector spinae block, but still there is enough evidence to say that it is a useful block in these situations. Significant improvement in the understanding of fascia and high-quality clinical trials are needed to improve block technique and analgesic consistency in facial plane blocks. For these blocks to become more consistent, studies are needed to determine the optimal site, plane, and direction of needle access, as well as the speed and pressure of injection, and the desired sonographic endpoints. I think AORA is the correct platform, the most appropriate platform to find answers to all these questions. Thank you. Thank you for your patient hearing.
Thank you, Dr. Vandana, for that refreshing our knowledge on this topic and also on the approach that you have presented. Now we'll be enlightened by another approach, which is posteriorly at the costotransverse junction. I call upon Dr. Shweta Patambekar to give her thoughts on this approach.
Good afternoon all. Welcome you all to Pune. So we are quite playing safe here. We are on the transverse process and at the posteriorly at the costotransverse junction, where do we inject? So this is my outline. Everybody knows about erector spinae plane block, which we'll be discussing with the basics. And I'll be just touching two new blocks which are now in the discussion because, as ma'am said, ESPB had, compared to thoracic paravertebral, definitely had few fallacies, but definitely paravertebral should get more safer options. And these are the two, midpoint transverse process and the costotransverse foramen. So starting with the ESPB, this is the anatomy, and we all know that this is the space which we are interested in. We have to avoid this. That's why we are posteriorly here. And this is the area which we are targeting this is the muscle and this is the transverse process. So erector spinae plane block target is here. And this is the costotransverse ligament. So just remember this anatomy. These are the muscles from cervical to the sacrum, and this is the erector spinae, which we can, block can be given from thoracic level to the lumbar level. As we all know, it's described in 2016 by Ferrero. It is basically described, first described was for thoracic analgesia and chronic neuropathic pain. But as we all know, acute post-surgical and post-traumatic pain is also getting relieved by this block. It is paraspinal facial plane block. It is given deep to the erector spinae muscle and superficial to the tips of the transverse processes. So this is supposed to be a mechanism of action. It the local anesthetic diffuses and involves the ventral and dorsal rami. In cadaveric studies, Chin et al. Had described the spread of local anesthetic as to the ventral and dorsal as well as the cranial and caudal. So it spreads 3 to 4 levels. That is one more advantage, that even single injection can give you multiple level block. So what are the indications? This is a post-operative analgesia in thoracotomies, breast surgeries, laparoscopic cholecystectomies, spine surgeries, retropubic radical prostatectomies, and open heart surgeries as well. Also in chronic pain management, we can give the erector spinae plane block. The contraindications for general, these are the general contraindications for all the regional blocks: patient refusal, infection at the site, coagulopathies, bleeding disorders, drug allergy, and sepsis. So general considerations, as we are sticking to the basics, we'll start with for any block, we have to take the consent, IV access to be secure, standard monitoring to be attached. All the resuscitation facilities must be available while giving the block. The procedure to be carried out in aseptic manner. So regional anesthesia type, as we all know, all these things to be kept. Now, what is the ultrasound scanning technique for ESPB? The position can be sitting or lateral decubitus or in prone. The target to identify is the transverse process, obviously, and the ultrasound probe used in thin limb patient, we can use the high frequency probe, linear probe, or in obese patient or the muscular patient, we can use low frequency, that is 2 to 5 megahertz, curvilinear probe. Position of the transducer should be paramedian, sagittal orientation, approximately 3 centimeter away from the midline. So, as we are using the curvilinear probe here, we can see the trident sign explained by the ma'am. So, these are the transverse process. This is our target. This is the erector spinae muscle. So, this is the target. And as we can see, here is the paravertebral space, which we want to avoid. So, this is how, as even the Archana ma'am has explained, how the position changes with the medial to lateral, the spinous process, the lamina, and the transverse process. More laterally, if we go, we can encounter the rib and their pleura. So here is our target, not too lateral, not too medial, on the transverse process. Under all acceptive precaution, using the echogenic 10 centimeter needle, the direction of the needle should be in plane, cranial to caudal. The spread deep to the erector spinae muscle and superficial to transverse process. The volume which we use, because it is an interfacial plane block, we have to use the more volume. And according to the surgical levels which we are targeting for the analgesia, we can use approximately 3.5 to 4 ml per segment. So 20 to 30 ml approximately. Drugs which we can use, ibuprofen 0.25% and ropivacaine 0.2%. It can be given single shot, or we can keep the catheter for post-operative analgesia and keep the drug infusion through the catheter. So this is how the needle direction, and this is the target. Local anesthetic spreads craniocaudally and the erector spinae muscle gets lifted up. So what are the advantages? As we all know, it is quite safer than the paravertebral. It's easy to perform, good analgesic efficacy, and low risk of complications. It is very much safe as compared to paravertebral, also as compared to epidural, because it's close proximity to pleura as paravertebral and close proximity to spinal cord in the epidural case. So complications are very few which are reported. It can be inadvertent drug spread to paravertebral space, or it can be local anesthesia, systemic toxicity, because we are using the large volume here. So these are the few studies where they have compared erector spinae plane block for all the postoperative analgesia surgeries, and it's very much proven that it has given effective postoperative analgesia in many surgeries, like thoracotomy surgeries, breast and thoracic surgeries. They have compared to other blocks or no blocks. In laparoscopic cholecystectomy surgeries, the beautiful part is we can give unilateral as well as bilateral, and we are safe here. Also, it can be given in cardiac surgeries patient for postoperative analgesia. So now, this was about erector spinae plane block, which we all know. Now, what is midpoint transverse process block? So here, we are going slightly deeper, but not very much to the superior costotransverse ligament. So the target point is between the posterior border of the tip of the transverse process and the pleura. It is posterior to the superior costotransverse ligament. We are not crossing it, so we are not entering the paravertebral space. And the mechanism of action, it's suggested that it's a spread is through the porous structures of the superior costotransverse ligament, and it enters the paravertebral space. So this is how it's explained. This is a transverse process. This is a superior costotransverse ligament, and this is a paravertebral space. So our target point is, this is a transverse process and the pleura, and the midpoint of line joining the two lines. So this is our target point for MTP block. So very few studies are published, but this is showing the case report showing analgesic effect of single level injection at midpoint transverse process is non-inferior to the thoracic paravertebral in the patient undergoing VATS. So if we have such option, then why to take more risk for analgesia, I'm saying. Then another thing which is coming now is costotransverse foramen block. The anatomy is same. We are posterior to the superior costotransverse ligament, but we are not at the midpoint, but at the base of the transverse process. So here, this is a target for costotransverse foramen block. Here is a transverse process. This is a pleura, and this is a superior costotransverse ligament. So we are not crossing it, but we are at the base of the transverse process. Even if we don't see the superior costotransverse ligament, this costotransverse foramen block can be given at the base of the transverse process. So these are the this is one study where they have shown that even cadaveric, compared to the erector spinae plane block, they have shown that the ventral rami in ASPB has not been stained, but in costotransverse foramen block, it has been stained. So it is superior to the erector spinae. So what are the advantages of these two blocks? As compared to erector spinae, obviously they both are safe also, but no identification of SCTL required. When you want to enter the paravertebral space, for thoracic paravertebral block, you have to identify the ligament and cross that. Here, you don't need to identify the ligament. Lower incidence of pleural puncture because you're not crossing that ligament, you're not near to pleura as compared to paravertebral. Low risk of injury to the intercostal nerve and vessels, and also no heaviness or uncomfortable pressure sensation till now reported with these blocks. Again, I want to mention this study by Divan sir only. So this is showing us the different points of needle tip and where the block can be given when we are entering from the posterior costotransverse from the posterior. So this is the erector spinae, which we all know. This is the transverse process. This is the back. These are the erector spinae muscles. So when the tip is just anterior to the erector spinae muscle, posterior to the transverse process, this is the spread of erector spinae. It's not showing. Okay. So second is you are just behind the superior costotransverse ligament, but in between, not crossing it. So this is interligament space, as it is being mentioned in the article. So that this space is more, I'm saying about midpoint transverse and costotransverse foramen is in this space. And that last is paravertebral, crossing the superior costotransverse ligament. So ultimate question is where to inject. These are the target points which I want to mention. This is the erector spinae, costotransverse and midpoint transverse. So I would like to target this. So this is a take-home message about the 3 blocks. Much more studies are needed for these 2 blocks, and we are definitely playing safer here. So you can, tomorrow also you can go to OT and try all these blocks. So thank you, and I hope you're enjoying this CME. Thank you so much.
Thank you, Dr. Shweta. That was a very interesting talk. The session is now open for questions, queries. We have 5 minutes.
Hello. My question is to Shweta. What is the advantage of MTP or costotransverse foramen block over erector spinae?
As we have seen in a few cadaveric studies, they have mentioned that few erector spinae plane blocks might not involve the ventral rami, but midpoint transverse and costotransverse, there are, again, the more studies or the patient's clinical studies required, but still the cadaveric studies showing that ventral rami, if spared by ASPB, can be covered by the costotransverse or midpoint transverse. There are more chances of covering the ventral rami too as compared to erector spinae plane.
Any tips to include the ventral rami in ESPB?
As we all know, ESPB is very easy to give, but definitely you should not be very lateral, I mean too lateral at the ribs. You have to see the sign of transverse process, like a squaring of the vertebrae, squaring of the process, and ribs are rounded. So try to identify the costotransverse junction and don't cross that junction. If we cross and become too lateral or too medial, then definitely the spread through the costotransverse foramen, as it is mentioned in the ESPB, has less chances of spreading that drug to the ventral rami. So you have to identify the transverse process.
Yeah, thank you.
How much volume would you give, Dr. Shweta, for this approach? How much volume in comparison to ESP?
Okay.
How much volume would you reduce it?
Yes, ma'am. I would like to reduce it, but definitely it is again multiple level. It also gives you multiple level of analgesia. So I will give more volume according to the segments I want to give analgesia to. So the volume will be depending on the level of analgesia. It will be definitely lesser than 3.5 ml per segment. It will be 2.5 ml because it will spread faster through the SCTL.
So you're saying it's multiple single injections?
Yes, it is single injection giving multiple level.
Okay, sure.
Sorry to bother again concerning the anatomy. I'm not pretty sure if you are aware that the costotransverse foramen can be closed by a dense connective tissue. And this might be your problem, that it is not previewable and not comparable to a paravertebral spread. Because if you're in the paravertebral space, you do not have any limitations concerning any fascial structures. And this is the disadvantage of anything what is performed dorsal to the costotransverse ligament. Second, an ESP block is not a fascial plane block. Why? Because there is no plane. Regarding the erector spinae muscle, the erector spinae muscle, especially at the area where you have the peak of the transverse process, has many origins and insertions of the different systems of the erector spinae. So what we create over there is not a plane, but an inter- and intramuscular injection. So it's spreading around inside of all of us because we are the different muscle fibers, and we might be lucky if it's going ventrally. And it is the same with yours, but yours has more, let's say, opportunity to get with your needle direction ventrally. Anyway, I'm pretty much sure it is not constant enough. So that's the disadvantage, but it's a good idea. Yeah? And the second thing is regarding the cadaveric dissections. Again, please review the way it is injected and dissected. When I see a methylene blue or ink injection and then the dissection is performed from dorsal, you create your spread with your dissection. The only way how to evaluate such an injection is you coming from the other side and not to open the space. It's the only way. And you have to really trust me, because I already made this error often. And that's why I went away from methylene blue injections. Otherwise, you do it in the way as I realized later on. So be very critical with such investigations, especially concerning the method. Thank you.
Any other questions, queries? Dr. Anjali, if you have to give a single tip for a successful thoracic paravertebral block, what it would be?
There is no single tip. It's like, not being scared of the block. What I've been hearing all along is people are safe. Then I think we should stop doing epidurals, because that is the most dangerous block we do, and all of us do it blindly without seeing where we are going. So I don't think paravertebral is a dangerous block. It's a pretty simple elementary block, especially the loss of resistance technique. With the ultrasound, you can see the needle in plane. What more could you want? And I think you need to persist. First, do it in simple patients, and lower thoracic spine for analgesia, single level blocks, and then go on to using it for surgical anesthesia. Thank you.
Thank you. So if there's nothing else, we'll break for lunch and come back at 1:30 for the next session. Thank you all.
चल रहा है. It's not working, no? Good afternoon. Hope everybody had a nice lunch. We start with our next session. I invite Dr. Anjali Chabra and Dr. Archana Areti for the next session moderation. The session is truncles.
So, good afternoon, everyone. The most difficult session is the one after lunch, and it's my proud privilege to invite Dr. Divesh to come to the podium for the talk on
Good afternoon, ladies and gentlemen. I bring greetings from Asian Hospital, which is a 425-bedded hospital situated in Faridabad in the heart of Delhi NCR. And as Madam said, post-lunch sessions are a little difficult, and I offer quadratus lumborum block as a cup of coffee to keep you awake. So how do we define this block, my dear friends? It's an interfacial plain block where local anesthetic agent is injected adjacent to the quadratus lumborum muscle with the goal of anesthetizing the thoracolumbar nerves. So Dr. Rafael Blanco first introduced this block in 2007, and since then we have had various variants, and I'll be touching the variants which are most important to us in daily practice. So the principal key structure is the quadratus lumborum muscle, which is actually encased in thoracolumbar fascia, and the location of needle tip in relation to the quadratus lumborum muscle is used to define various types of quadratus lumborum blocks. So currently the nomenclature is lateral, posterior, and anterior, and we have various variants for anterior quadratus lumborum blocks, and I'll be discussing few of them in next 7-8 minutes. So let's do a quick brainstorming as to the mechanism of action of quadratus lumborum block. It's related to the direct block of nerves, particularly the ilioinguinal, iliohypogastric, and subcostal, which are situated on the ventral surface. Then there are a lot of sympathetic fibers as well as free nerve endings situated in the thoracolumbar fascia, which get blocked by direct action of local anesthetic agent, and definitely the continuity of the transversalis fascia with the endothoracic fascia is the principal mechanism whereby the drug ascends up till the thoracic paravertebral space. So coming on to lateral quadratus lumborum block, my dear friends, where the drug is actually injected at the lateral margin of quadratus lumborum muscle, and with the patient in supine position and the transducer being placed in the posterior axillary line. The aim is to block the ilioinguinal, hypogastric, and the subcostal nerves. And if you look at it closely, it is essentially the same as the transversalis fascia plain block, which is actually performed 1 centimeter proximal to it. So coming on to posterior quadratus lumborum block, the beauty of this block is that it can be done in supine as well as lateral decubitus position, and you can use both probes, the high-frequency linear as well as curvilinear probe, depending on the body habitus of the individual. Both posterior to anterior as well as anterior to posterior direction of needle can be done. So let's have a look at the video in patient in supine position with a linear probe and the anterior to posterior direction. So we trace the anterior abdominal wall muscles, and the needle is coming through the anterior abdominal wall muscles, and the aim being to deposit the local anesthetic in relation to the posterior surface of the quadratus lumborum muscle in between the epimysium and the middle thoracolumbar fascia. So this is how we complete in supine position with the linear probe. Let's have a look in a lateral decubitized position. A curvilinear probe is being used, and the needle direction is posterior to anterior. And in the literature, it has been shown that the posterior medial direction, that means close to the transverse process, the drug effects in terms of craniocaudal distribution are much higher. So now coming on to anterior quadratus lumborum block, the Shamrock approach, which was described by Dr. Jens Boglam in 2013. He calls it tequila block, and it relies on the sonographic pattern recognition of the thumbs up sign or the Shamrock, with quadratus lumborum muscle being attached to the tip, the psoas major on the anterior surface, and the erector spinae on the posterior surface. So in order to perform this block, we should actually use a posterior to anterior direction, my dear friends, because if we use the reverse as a beginner, anterior to posterior, our needle is going to come through the retroperitoneal fat, and at times there are vessels which can lead to retroperitoneal hematomas. So again, it relies on the recognition of sonographic pattern of Shamrock sign. So let's have a quick look at the video. How do we actually do it? It's done in lateral decubitus position, curvilinear probe, and posterior to anterior needle direction. Now, as you can see for yourself, the needle is traversing the substance of quadratus lumborum muscle. We should be careful of the posterior surface where actually the vessels are situated, particularly the lumbar arteries. I've done a test injection. It looks okay to me. The remainder injection is being done, and generally we inject around 25 mL of local anesthetic along with dexamethasone to prolong the duration of the block. Once the block is finished, always do a follow-up scan in the longitudinal axis to see the ascent of the drug towards the thoracic paravertebral space, as I've been doing in this video. So another approach is the transverse oblique paramedian approach to the anterior quadratus lumborum block, again described by Jens Boglam. The beauty of this approach is that you do not have to turn the patient twice as you would require in Shamrock, particularly indicated in laparotomies where we have to do a bilateral quadratus lumborum block. It relies on the sonographic pattern identification of the flag sign, with the pole of the flag being the transverse process and quadratus lumborum muscle representing the flag itself. So as I suggested, a follow-up scan in both Shamrock as well as longitudinal position is recommended in this approach. Now coming on to big question, can the Shamrock approach be done in the supine position? The answer is big yes. We have papers from Dr. Sandeep Diwan where he has actually stated supine coronal mid-axillary approach. Now I'm showing you my technique. How do I do it in supine position? We place a wedge underneath the buttock and the ipsilateral limb is internally rotated so as to give us good space, and the needle direction can be from posterior to anterior, anterior to posterior, or out of plane. As I said, as a beginner, do come from posterior side, not from the anterior side. The indications can be broadly divided into abdominal indications as well as hip indications. And as a beginner, we are surprised how come a block which was described for abdominal surgeries can work in hip surgeries. It is one of the three mechanisms. It's the direct diffusion of the local anesthetic toward the lumbar roots. Another is the diffusion of the local anesthetic if we actually breach the transversalis fascia towards the lumbar plexus. And another is the continuity of the thoracolumbar fascia with the fascia iliaca inferiorly. These are some of the postulates that it works in hip surgeries. So you have to stay close to the L4, and you can use either the Shamrock technique or the suprailiac technique or the paraspinous sagittal shift quadratus lumborum block. As regards contraindications, it's a deep block in patients who are taking clopidogrel or anticoagulants. One has to be careful. As per ESRA guidelines, we should not be performing this block. So, and the complications are particularly related to the needle. If we are coming from anterior to posterior side, and if we do not use protective lung ventilation, then there are chances that we might stick our needle through the kidney. We have to be careful of that, and retroperitoneal hematoma can occur. So then the big question comes, my dear friends, which approach to quadratus lumborum block? So we have discussed anterior, posterior, and the lateral. Lateral has got limited indications, my dear friends. So in terms of anterior, posterior, we have limited randomized control trials which compare head-to-head between these two. On the basis of those trials, as well as my personal experience in terms of duration, dermatomal coverage, quality of analgesia, and patient satisfaction, anterior is a clear winner. So which anterior to choose? As a beginner, start with Shamrock approach, and as we know, as we graduate with our needling skills and better knowledge of the mechanism of action, we can progress towards a subcostal approach, which is closely performed at the L1 level and can give good coverage for upper abdominal surgeries. For hip, as I have said, we have to stay closer to L4 and use either of these two approaches. So do we have the evidence? We have good quality evidence in form of randomized controlled trials as well as meta-analysis that it works pretty well for abdominal surgeries as well as for hip surgeries. So my dear friends, this brings me to end. I'd like to give you some clinical pearls as take-home message. It's an advanced level block. And we have to realize that quadratus lumborum muscle is a hypoechoic muscle, and we can confuse it with pararenal or perirenal fat, which is also hypoechoic, but it will definitely move with respiration. So the aim is to inject closer to the transverse process. A caudal tilt generally helps to identify the shamrock pattern, my dear friends, and a posterior to anterior needling, and we have to inject between the epimysium of the quadratus lumborum muscle and the anterior thoracolumbar fascia. If we actually cross one step ahead, it will result more in lumbar plexus and less craniocaudal distribution. It's a volume block, my dear friends, so I inject 25 mL of 0.3% ropivacaine with dexamethasone 8 milligrams. Do follow up in a longitudinal axis, and remember that it's basically an analgesic block, and it provides somatic and visceral analgesia. Thank you very much for your kind attention, and I'd like to leave you with a small quote, my dear friends. The quest for knowledge never ends. It just leads to more curiosities that leads to a greater mind. This is just a reminder in case you forget to clap for me and you've already forgotten. Thank you very much.
Thank you very much, Dr. Devesh. That was very wonderful and explicit. I now invite the next speaker, Dr. Neha Singh, to talk about at the facial yaka. Thank you.
Okay, very good afternoon to all of you, and welcome to this post-lunch session. Okay, so first of all, I would like to thank Sandeep Diwan sir and team AORA 2023 for having me here today, and greetings from my place, that is AIIMS Bhubaneswar, Odisha. So moving from cephal to caudal, we'll move at fascia yaka plane here, and I have neither any disclosure nor any conflict of interest. And we'll be discussing about a bit of history, indication, contraindication, anatomy and preparation, approaches and literature evidences, and summary. So as we all know, here it was a block introduced as 3-in-1 block in 1973 long back, and further modification of fascia yaka compartmental block came in 1989. The first time Hubbard has used ultrasound-guided suprainguinal fascia yaka block, and now it's quite clear that suprainguinal versus infrainguinal, a lot of research was going on to be the which block is superior and all. We'll discuss all through in line. Desmet et al. Has given even a longitudinal approach for this block. So various indication both for anesthesia and analgesia here, like the plastic surgery procedures, grafting, biopsies, and hip procedures, femur fractures, and knee procedures, they have used this fascia yaka block. Time tested and long time back also we were using that. We are using this block for even knee procedures during my PG days. Now, of course, we are shifted to some newer block like PENG and all. Contraindication not as such there, but relative contraindication we can say it's coagulopathy and all. Although with the coagulopathy interfacial plane block, again, I would suggest you need to weigh risk and benefit for individual patients before proceeding for any of these blocks. Coming to the background here, as we all know, before proceeding for any of the procedures, we need to know about the osteotome, dermatome, and myotomes. And of course, we need to know about the plan of the surgery, surgical incision before planning any of the block. Basically, we are targeting here femoral nerve, lateral femoral cutaneous nerve, and obturator nerve. We all know that all these 3 nerves used to descend from the lumbar plexus into the pelvis along the psoas, and they share a common compartment beneath the fascia lata. If we see here the cross section at the iliac crest, we can see the fascia lata and femoral nerve and fascia iliaca. So arrangement is traditionally when we were given this block, this we have started as landmark guided, so we need to feel for the 2 pops here. Coming to the preparation here, we need to take informed consent. IV access and monitor has to be there. Position is supine here. Checklist, we have to follow every time that we have followed everything. And aseptic precaution has to be taken. So first confirm and then perform before going for any of the blocks. So we are comparing here this is just my personal opinion. I would say that we should not, although we are having a lot of gadgets, be it PNS or ultrasound, but we should not forget about the landmark guided approach. Of course, it depends on which approach you will take according to your setup and the things available at there. So first of this first diagram shows the landmark technique which we used to follow, that is from anterior superior line joining the anterior superior iliac spine to the pubic tubercle. We used to divide it into the medial and lateral, medial 2/3 and lateral 1/3. And the point of insertion used to be it's 1 to 1.5 centimeter just below the meeting point of lateral 1/3 and medial 2/3. The other two diagrams shows the orientation of the ultrasound probe. The second diagram shows the orientation of the probe in the transverse direction, which is usually we were following previously. The third diagram shows the ultrasound probe orientation for the suprainguinal fascial iliaca block. So we'll come to the zone anatomy here. We can see these three compartments. Again, we have divided into lateral 1/3, middle 1/3, and medial 1/3. And here is the fascia iliaca, and this is the iliacus muscle and sartorius muscle. The more lateral we'll go, we can see the tensor lata muscle even. So again, in the cross section, we can compare here the orientation of the ultrasound probe will make a difference in the anatomy here. The above diagram shows the orientation with the SIFI block, where we can see abdominal muscles and sartorius in single plane along with the fascia. The target area is again same, be it a landmark area, landmark guided, or the ultrasound guided approach. Ultrasound we can go for different orientation and direction to go for the target tissue, target fascia, that is fascia iliaca. Laterally we can see here, in this is the diagram showing the in-plane approach for the deposition of local anesthetic along the fascia iliaca. Local anesthetics is there just below the fascia lata, and this red line shows the fascia iliaca. So the two pops technique used to go once the needle crosses the fascia lata first, and the second pop came when we are crossing the fascia iliaca. So even if we are doing ultrasound, what is happening nowadays that we are forgetting the concept of feeling the tissue and feeling the needle going down to the tissue. That has to be followed along with the ultrasound guided technique even. So coming to the suprainguinal fascial iliaca block here, we are using linear high frequency probe, and we need to keep the probe in the sagittal plane at anterior superior iliac spine. The first structure we see there is the iliacus muscle, and sartorius and abdominal muscles will be in the picture also. We need to move the probe medially to identify fascia iliaca, sartorius, iliopsoas, and internal oblique muscle in one plane. If we see here, this will give us a picture of bow tie or a horizontal hourglass appearance. So there, you can see there the vessels are there. You can see some vessels there. Those are deep circumflex iliac artery, which once we are injecting local in the plane, they used to move upward. Even if we are not seeing the frank upward movement, if the local is getting deposited between the fascia lata and fascia iliaca, then we are in the right plane, which we can confirm with the hydrodissection. And we need to introduce needle here 1 centimeter cephalate to the inguinal ligament in plane approach, and the tip has to be beneath the fascia iliaca. We can confirm this by hydrodissection, as we have already discussed, and the fascia, the fascia has to spread in cephalocaudal direction, as we can see here. The studies have shown that the bupivacaine 0.25%, approximately 30 to 40 mils is needed, while 0.3% ropivacaine, even the lower volume, like 25 to 26 ml, is sufficient for the blocking of the obturator nerve. Why this suprainguinal approach has come, that the obturator was getting spared with the classical and traditional approach of the fascia iliaca block. So by increasing the volume or by making the puncture little more cephalad, we are targeting the obturator nerve to get blocked. As you can see here, the needle is coming from the cephalad direction, and the local is getting deposited between the fascia. Now coming to the literature evidence here, there are a lot of studies nowadays. We can see which have compared suprainguinal approach versus the infrainguinal approach. Even people have come with the modified infrainguinal approach. Here, they have done the study on 32 patients using 30 mils of 0.2% ropin, and they have found that it has got better analgesia, reduced pain intensity, and the tramadol consumption over 24 hours of the block. Again, a retrospective study in 168 patients they have done, which has shown that suprainguinal approach is superior to the like at the fascia block or the traditional or conventional approach by reducing the opioid consumption over 24 hours. A human volunteer study was also done using 40 mils of lidocaine 0.5%, where they have given the conventional and suprainguinal approach in both the limbs, right and left, and they have found that it was better clinically, and they have confirmed it with the consistent spread with the MRI even. Electromyographic study also have proven that CFI block is having better postoperative analgesia and increased incidence of successful operator nerve block. So suprainguinal approach emerges by a loophole, I should say, in the inguinal or classical approach, that the obturator nerve was getting spared. So this has been taken care by the suprainguinal approach. So what next? Should we go for the landmark or ultrasound? Okay, we need to go ahead with the availability of the equipments and whether landmark or ultrasound, but we should not forget our landmark approach. Even if we are having ultrasound, if ultrasound is available, good, go for it. Approaches among suprainguinal and traditional approach, as such, it is out that suprainguinal is a better approach for analgesia and decreasing the opioid consumption. Volumes, we have already discussed that it should be 30 to 40 ml of 0.25%. If we are increasing in the concentration, like 0.3% ropin, we can come down on the volume up to 25 ml. Catheter, there is not enough evidence about the catheter placement here, and maybe this is an area of future studies to put the catheter in these planes. Safety and complication, very few have been reported, like local hematoma and 1.7. So to summarize, it is easy to perform, high success rate to cover all the 3 nerves, and low rate of complication. A promising component of multimodal analgesia it is coming up with, and there is still scope for future research. Thank you.
Thank you, Dr. Neha. That was a very detailed talk, and we'll do the question and answers after the next session. And now I'd like to invite Dr. Medha Kulkarni to give her talk on my preferences of TAP. I think it's a pro-con session. So Dr. Medha Kulkarni has 10 minutes for pro-con on preference TAP for abdominal laparotomies.
Good afternoon, everybody. I'll straight away start with my talk about abdominal laparotomies. And my preference, like most of you, is a TAP block. It's a traditionally time-tested block and one of the first interfacial blocks to be described because of its peculiar anatomy, that the anterior primary rami of the intercostal nerves, which have a very straight course along the interfacial plane between the internal oblique and the transversus abdominis. And once the internal oblique muscle is reflected, what you see is the emergence of the intercostal nerves from T7 to T9. They emerge from the below the costal margin, and the others, like from T10 to T12, they emerge from the lateral aspect of the abdomen, running along the anterior aspect of the entire abdominal wall. So classically described first by Rafi in 2001, it was the point of insertion of the needle was in the lumbar triangle of Petit, where the internal oblique forms the floor of the triangle, and with a single pop, a large volume of local anesthetic, around 20 to 30 ml, could be injected in this TAP, the TA plane, to give analgesia for the hemi-abdomen. But once in this cadaveric dissection, we see that the prior to the mid-axillary line, the T9 to L1 nerves, they have a relatively constant course in the TA plane, and hence they can be effectively blocked in this region, providing analgesia to the lower part of the abdomen. Hence, depending on the approach, it can be described as a lateral or posterior tab block and a subcostal tab block. The subcostal tab block or the oblique subcostal tab block is along the costal margin, whereas the lateral or the posterior tab block is on the in the mid-axillary line and the lumbar triangle of Petit respectively. So when it comes to the technique, linear ultrasound transverse probe is placed in the mid-axillary line, midway between the costal margin and the iliac crest, and the needle is inserted from medial to lateral side in plane to identify the plane between the internal oblique and the transversus abdominis muscle, and the local anesthetic is injected in this plane. Now, there were studies on the spread of local anesthetic solution in this tab plane, and what they found was with a lateral tab block, the local anesthetic remained confined to the plane between the internal oblique and the transversus abdominis, whereas with the posterior tab block, the spread of the local anesthetic went up to the paravertebral space up to the level of T5. So, and there was also pooling of the local anesthetic near the lateral margin of the quadratus lumborum, which was not there with a lateral tab block. Now, there was this cadaveric study by Tran, where with a lateral tab block, they found that only the T10 nerve was marginally stained with the dye, whereas there was 100% staining of the T11 and T12 nerves, and hence this was correlated with a clinically correlated with a study by Shibata, where the zone of analgesia was demarcated with a lateral tab block below the umbilicus, that is below the level of the T10. Hence, they suggested that this lateral tab block was sufficient only for lower abdominal surgeries. Hence, a subcostal approach was described by Peter Hebard, and it was along the costal margin where the probe was placed just parallel to the costal margin, and a needle was inserted near the xiphoid process in plane to reach the plane between the rectus abdominis and the transversus abdominis, and local anesthetic was injected in this plane. The needle was further advanced to inject some more local anesthetic to flood the entire plane between the rectus sheath and the transversus abdominis. This, when the analgesia offered by this method also correlated with a cadaveric study by Murorki, where the T9 and T8 nerves were also stained, thus giving a good block of the upper abdomen. Thus, a dual block was suggested, which is an extended tab block, where the subcostal or the subcostal oblique tab block was combined with a lateral or a posterior tab block to give analgesia for the entire hemiabdomen. And the probe placement was as shown in this figure. The distribution patterns and the dermatomal anesthesia was studied by Jens Boglum, and where they injected 30 ml of local anesthetic on one side of the abdomen with a lateral approach, and on the other side they performed a dual block with 15 ml injections at the subcostal and the lateral plane. So, with ropivacaine not exceeding its safe dose, peak levels were found to be at 35 minutes, and the dermatomal anesthesia was achieved for maximum of 7 dermatomes on the side of the dual block. There are hardly any complications with respect to the tab block. Isolated liver trauma and case reports of liver trauma and some visceral damage have been described, but they are statistically insignificant. So it's a very safe block if placed properly, as described in these 2 articles by McDermott and Assew. They concluded that only 23 to 25% of the tab block were in the right plane, whereas the rest were outside the tab plane, and an alarming 18% were found to be intraperitoneal. Hence, they suggested the use of ultrasound for giving a tab block for proper placement of the needle tip. Regarding the evidence for analgesia after abdominal surgery, in this review article by Charlton, they reviewed 8 studies which included 358 patients and with a TAP block, and they concluded that there is a limited evidence for the effectiveness of this block. However, at the same time, they also suggested that TAP block needs to be more research, has to be done for TAP block and compared with other analgesic modalities like morphine or opioid analgesia and epidural analgesia. So finally, there is a level 1 evidence for herniorrhaphy and hysterectomy where TAP decreases the opioid consumption and decreases the pain scores, and a level 2 evidence for appendicectomy and cesarean sections where it decreases the neuroendocrine stress responses, and it also decreases the 24 hours opioid consumption. At the same time, there's also evidence that it should not be, it is not recommended for laparoscopic appendectomies and laparoscopic hysterectomies. So finally, any positive outcome related to the TAP block should be viewed as approach specific. So with different approaches, the outcomes will be different. Like for a lateral TAP block, it will be for the lower abdomen. With a subcostal TAP block, the upper abdomen can also be covered. Findings of the comparative trial will depend upon the control group. So what analgesic regimen the control group has received, the comparative trial will, the findings will depend on that comparative trial. Thirdly, with a TAP block, since it offers only does not offer visceral analgesia, it is important to follow a multimodal analgesic regimen which has to be adopted as with other regional anesthetic techniques. Thank you.
Thank you, Dr. Medha. I now would like to invite Dr. Sachin RB to come and give his preference regarding for abdominal laparotomies with his quadratus lumborum block.
This is a slide changer. Slide changer. Yeah, okay. So, good afternoon up to the post-lunch session, and thank you everyone for gracing the AORA 2023. At the offs, yeah. Okay, so I call on Dr. Gajanan for moderation of this session. Please come on stage. So my time has started. So Divesh made my job a little bit easier because already described the QL block, so I can just go straight to the fighting part. Okay, so my title suggests the same, that quadratus lumborum is the best. So I come from Ruby Hall, which is a multi-speciality hospital in this city, and we have a well-organized RA fellowship course running on. No disclosures. See, what are we debating here is between QL and TAP. We are discussing is which block has a longer duration of action, which is a larger area of distribution, which can be easily performed or learned, and which has less complications. Let's tackle one question, one after the other. So this is a recent meta-analysis. The most extensively studied TAP and QL dual has been for LSCS or cesarean sections. And the recent meta-analysis shows that QL is equal to TAP if you're going to avoid intrathecal morphine. If you're going to give an intrathecal morphine or intrathecal opioid, then there is no advantage of either giving QL or a TAP. But if you give both, if you're omitting the opioid and you're giving both, then they both are equal. So as regards LSCS, TAP would probably score because it is easier to give, it's in the supine position. So still, if you look in terms of analgesia, both are equal. Now let's go to the other major abdominal surgeries like nephrectomies or colectomies, small bowel resections. This was a meta-analysis way back in 2018 where 4 studies with 188 patients they found that QL led to a significant more reduction than TAP in the 24-hour morphine consumption. I'll just rush to the meta-analysis one after the other. This was 8 RCTs involving 576 patients. Again, it was better pain scores up to 24 hours as compared to TAP. One more, this was a big meta-analysis with 22 RCTs, and they again found the same thing. So here we see that the quadratus lumborum definitely extends the duration till 24 hours, much more than TAP, which usually goes up to 12. The QL in some studies will extend up to 48 hours. So as regards the duration, it definitely is more beneficial than TAP, except for LSCS, where I would give the score to TAP that it is easier to give. Okay, this was described by Dr. Divesh, where he described the thoracolumbar fascia, where it has 3 layers, anterior, middle, and posterior. So which has a more extensive spread in a single injection. We are talking about a single injection. Here, one injection done in the anterior or the middle thoracolumbar fascia would extend as per the cadaver studies and as per the coverage that is tested after the block is given into the endothoracic fascia in the thoracic paravertebral space as well as in the lumbar paravertebral space, which is also responsible for visceral action. Now that is not there in TAP, we all know that. But TAP would involve 2 injections on one side, and if you have to block both the sides, it would involve 4 injections of a subcostal and a posterior. This is how the nerve goes. So this is what we meant, that injection deposited in the anterior thoracolumbar fascia would move through the lateral arcuate ligament into the endothoracic fascia, possibly onto the thoracic paravertebral space, into the TAP plane, and also into the lumbar paravertebral region. This is the reason for a single injection, even on one side, giving a extensive spread and extensive action. Now, this is where you compare all the 4 approaches to the QL, and you see that average spread is from T7 to L1, you can say T6 to L1 in most of the studies. Now, let's come to the third question, which is easier to give and which is easily learned. Okay, here I can vouch that QL2, the posterior, since it is not a deep block and it is the needle trajectory is more superficial and depth to the target area is also small, it can be easily learned. Don't get stuck with the level 1 blocks that TAP is easier, patient is supine, you can just give the TAP and get somatic analgesia. It's time to move to the level 2. So if you are proficient in TAP, it's time to move to the QL2 and a QL1, which is just an extension of the TAP. QL3, I understand it requires more scanning, more precision, and it also involves more longer needle trajectory. So your first target should be to learn QL1 and 2 probably, once you're progressing from the TAP and then on to the QL3. So in all the 3 aspects, the duration of analgesia, the coverage, as well as the ease of giving or ease of learn, it can be done with a QL. So this was a newsletter of ASRA in 2019, where they had said potential visceral analgesia. We now know that there is visceral analgesia. There is a longer duration of analgesia also with QL as compared to a TAP, which extends up to 12 hours. So my verdict is the QLB. QLB wins supreme. Okay. Which QL is better? Well, that is a debate. That is something which we have already said in ease, in learning. Okay. In terms of extension, the QL1 is definitely the QL3 is definitely the best in terms of the coverage, but QL2 is not far behind. So if you look at all the factors, if you look at novices who are going to be learned, who are going to be in the middle path of learning, then QL2 is much better because it gives good enough analgesia, which can be covered with a little bit of multimodal analgesia, and also it's safe. It's the safest. So for some pointers for QLB2, we use the lateral position, the linear probe. The advantage is that it has better ergonomics. Bilateral blocks can be given in one patient position, and it has a shorter needle trajectory. like Dr. Divesh said, for QLB3, still lateral position is the best. You can give it in supine position, but you need to elevate. He had shown the position much better than me. And it has a longer needle trajectory, so you have to be careful when you're going from medial to the lateral movement. Okay, ergonomics are difficult. When you are in supine position and giving a bilateral block, you need to move, bend over the patient. If you don't want to bend the machine or take the machine on the inside, take yourself on that side. It becomes a little bit of a cumbersome technique. And quadriceps weakness is definitely a possibility. Okay, this needs to be monitored. If you're giving a QL3 and if you have violated or injected into the psoas muscle. Are there any side effects of quadratus lumborum? So this is, I am talking in favor of TAP a little bit. So these were a report of 2 cases where they have given preoperative quadratus lumborum, and they found unexplained hypotension during the intraoperative period, which they attributed probably to the sympathetic blockade or to there being no surgical stress response. They are not able to definitely say, but then they say that you need to study now, giving preoperative QL as well as postoperative QL, and see the difference of how the hemodynamics behave intraoperatively. These were already mentioned by Divesh. So QLB is best in major abdominal surgeries. We are talking about nephrectomies, colectomies, right? So these are major surgeries which will probably not suffice with the TAP. It has a better visceral coverage, longer duration of action, and a learning curve is present, but it is surmountable easily. Thank you.
John? We will take questions in the end. Now I will invite Dr. Abhishek Lonikar for talking on neurolysis by phenol in refractory pain after acute trauma.
Good afternoon, everyone. Myself, Abhishek Vidhadhar Lonikar, and thanks for giving me the chance to present phenol neurolysis in refractory pain after acute trauma in truncal regions. I have prepared this presentation under guidance of Juan Francisco Asenjo. He was professor at McGill University where I got trained. So first case is 86-year female, came with a complaint of pain on the left side of the thorax, and she had a history 10 years back, managed conservatively. CT thorax revealed acute on chronic rib fracture on the 5th rib. On treatment part, she refused going for any kind of oral opiates. So we decided to do a diagnostic nerve block, intercostal nerve block, with 2% lidocaine, 5 cc and DEXA, 4 mg, and bang on. Her pain went from 7 to 2, thus helping us to diagnose she is an acute onset intercostal neuralgia. Second case is 64 male, came with a complaint of pain in right thoracic region due to fall from a staircase within his height. He had a bruising on the right side and needed high flow oxygen mask to maintain his saturation above 90. Surgical team diagnosed it as an fleal chest with 5th, 6th, 7th rib fracture, and it was a difficult epidural as he was not cooperative. So, and even systemic meds were of no use. So we decided to do an ESP catheter with bupivacaine 0.25%, 25 ml bolus, and 0.125 bupivacaine infusion at 6 to 10 ml per hour rate. His pain went down from 8 to 3. He was operated on post-admission day 3, and epidural was done intraoperatively under anesthesia. On day 6, he was weaned off epidural, CT drain was removed, and once again his pain shot up to 6 to 7 by 10. On palpation, there was tenderness in the 5th intercostal space, so we did an intercostal nerve block in the 5th rib region with the same lidocaine 4 ml, 2%, and his pain went down from 7 to 1. Once again diagnosed with acute onset intercostal neuralgia. So basically, what is intercostal neuralgia? Any condition causing painful condition, any painful condition of intercostal nerve is intercostal neuralgia. Common etiology includes herpes zoster pain, post-thoracotomy pain syndrome, traumatic injury, iatrogenic, most commonly due to chest drain insertion. Patient can be diagnosed on history and physical evaluation. We can elicit Scapelman sign and Carnett sign. Imaging is also helpful, while diagnostic intercostal nerve block is the most confirmatory. Management include mitigating the insulting problems so that patient doesn't lands up in chronic pain. And in post-thoracotomy pain syndrome, we have to keep in mind that not only regional anesthesia techniques are not only going to be the options. We have to consider multimodal analgesia plan. Before going further, we will just revise briefly the innervation of thorax. Thorax is supplied by 12 pairs of spinal nerves. They are further divided into ventral and dorsal rami. Main focus for this presentation is ventral rami. So in ventral rami, first two are typical ventral ramis. They contribute to the brachial plexus, and first intercostal nerve is the intercostobrachial. Then second and third ventral rami go into the intercostal spaces between the internal intercostal muscles and innermost intercostal muscles, where they further terminate as a lateral cutaneous nerve and anterior cutaneous nerve near the sternum. Now, various techniques for mitigating the rib fracture pain or intercostal neuralgia is thoracic epidural or thoracic epidurals, thoracic paravertebral, intercostal nerve block, serratus anterior plane block, and erector spiny plane block. Amongst these, intercostal nerve, serratus anterior plane, and erector spiny are the ones which are commonly used for neurolysis techniques. Going briefly, this is a chart very widely available online on World Federation Society of Anesthesiology, and I'll go through the drawbacks of the techniques. Thoracic epidural, thoracic paravertebral, of course, they can't be done patients who are on anticoagulations or have coagulopathy. Also, thoracic paravertebrals are kind of technically challenging. Anjali ma'am still just now gave a very good lecture on thoracic paravertebrals. Intercostal nerve blocks are relatively simple, but there is a risk of pneumothorax, high systemic absorption. Erector spiny plane and serratus anterior plane, these two techniques have got a drawback of variable spread of local anesthetic. Then a review article was published in 2015 in Korean Journal of Pain, and they went through all the neural ablation techniques. They basically divided neural ablation techniques in two broad categories: chemical neurolysis and physical neurolysis. Chemical neurolysis involved alcohol, phenol, and glycerol. There is nothing but there happens nothing but axontomesis and Wallerian degeneration for around 3 to 6 months. Mechanism of action is denaturation of protein. It is most commonly used for visceral as well as somatic pain. Complications include skin necrosis, anesthesia dolorosa, prolonged motor damage. But anesthesia, American Society of Anesthesiology and Regional Anesthesia Pain Medicine does not recommend doing it for chronic pain other than origin of chronic pain, other than origin of oncologic pain. While physical neurolysis, thermal radiofrequency ablation is most commonly used, in that there is protein denaturation at 60 degrees Celsius. Mechanism of action is alternating current causing coagulation of nerve protein, used for facet pain as well as sacroiliac pain. Most common complication, even though transient, is post-procedure discomfort, neuroma formation, and neuropathic pain. Shortcomings include stimulation. Every time you do this technique, you have to first do sensory and motor nerve check. Early recurrence, unwanted motor deficits are common, and cannula has to be placed parallel to the nerve. But then neurolysis in intercostal nerve block, various techniques were compared in this review article, a retrospective review and treatment of paradigm of interventional therapies for patients suffering from intractable thoracic chest wall pain in oncologic population. It was done by Amit Gulati et al. At Solon Kettering Hospital, and they recommended that chemical neurolysis to be the most effective technique. Radiofrequency ablation or cryoprobe is a difficult technique, as you have to, as finding nerve. Even in ultrasound guided intercostal nerve block is difficult, and author recommended always do an diagnostic nerve block, initial diagnostic nerve block. Then in Chronic Pain Medicine Journal, nice case series was published based on 20 patients. This was done in University of Hong Kong, chemical denervation for inoperable hip fractures. And in this, they injected volume of alcohol of around 8 ml in PENG, and as well as covering the obturator branches supplying to the hip articular branches. Main outcome was the pain score, and the results were that median pain went from 3 to 1 post-procedure. Total hip flexibility or flexion improved from 43 to 86 degree after the procedure, and there was no quadriceps weakness. Then also recently in RAPM in 2023, case report was published, genicular nerve and fracture site chemical neurolysis for distal femoral fracture. It was done in University of Toronto in Canada. Patient was having distal femur fractures with a lot of pain and a lot of comorbidities. So patient himself denied that he didn't want to go for any kind of surgeries and want to manage it conservatively. On post-admission day 10, PAD 10, his pain was 9/10. On that day, he received an continuous femoral nerve block catheter. His pain went to 7 when he was assessed on post-admission day 16. And still on post-admission day 23, his pain was 5/10, which is kind of a lot of pain. So acute pain team decided to go for doing a chemical neurolysis for genicular nerves on day 24. Just within 24 hours after receiving the chemical neurolysis, his pain went to 0/10, and it stayed in the same way till post-admission day 83. Also, pain scores on movement were 3/10 towards the end, and his opioid consumptions also went significantly down. So back to the clinical cases. First case, the 86-year female. She received a phenol-guided intercostal nerve block with 3 ml, 8% at the site of fracture, or proximal to the site of fracture, I'll say. And her pain went from 6 to 1 to 2/10, and she was discharged next day. While in case 2, the guy received same block. His pain went from 8 to 2, and he was also discharged within the next 48 hours. So take-home message, chemical neurolysis can be an excellent alternative in the cases where we are facing problem in covering the pain. Proper patient selection is necessary. Careful technique, yes, it is a challenging thing doing a neurolysis, so it should be reserved for those who are trained in regional anesthesia and pain medicine. And being an acute pain physician, you always have to think out of the box and be open for the new ideas. Thank you.
Thank you, Abhishek, for this wonderful lecture. Now, next, I would like to invite Dr. Arunakankshu Chakraborty. He will talk on the PEX block.
Good, they have a footstool here. Otherwise, you wouldn't see me. Hi, good morning, everyone. Has my time started? Oh, good. So, first of all, I thank the organizers of AORA to give me this opportunity to speak here, and my esteemed chairpersons, thank you. I'll today speak briefly about the fascial plane block, which is known as a PEX block. It was, first of all, I would declare that I have no conflicts of interest. Some of the images have been taken from Anaesthesia. The videos are for my own, and I have taken consent from my patients to display those videos here. So the PEX block probably came as the first alternative to the thoracic paravertebral block for breast surgeries described by Dr. Blanco way back in 2012-13. And since then, it has grasped the imaginations of most of the regional anesthesia enthusiasts. And amongst them, you can count me also. I had my share of work with PEX block. So what we do here is basically, we want to block the lateral and medial pectoral nerves, which are the branches of the brachial plexus, along with the intercostal nerves, anterior intercostal nerves, which innervate the skin and the muscles of the chest wall and the breast tissues. Now, how we do that, it's, this PEX block is one of the initial fascial plane blocks that came. And the concept when it came was new, that we are not targeting any particular nerve, rather we are targeting a fascial plane where we deposit a volume of local anesthetic, and then we expect that volume of local anesthetic to work on that particular nerve and the nerves which are they want to address, and then the block will work. That was the plan, and it works pretty well. So what are the planes? The first plane is between the pectoralis major and the pectoralis minor, for which the PEC1 injection was devised. And the next plane is a plane between the pectoralis minor and the serratus anterior, for which the PEC2 block was devised. PEC2 block actually consists of 2 injections. I will come to it later. Now, these are the fascial planes I was talking about. As you can see, this muscle is a pectoralis minor, and it is covered by a fascial sheath which actually extends up to the clavicle as the clavipectoral fascia. And the pectoralis major muscle is retracted here. Below that, you can see the serratus anterior muscles from the 1st to the 8th rib. Sometimes it extends up to the 9th rib, but a bit lateral. And these are the fascial planes here. Okay, so in the PEC1 injection, the injection is given between the PEC major and the PEC minor, and the orientation of the probe is slightly oblique. It is along the anterior axillary line, generally over the second rib. And this is how the block looks like. And the PEC2 injection is given a little lower, generally over the third or the fourth rib. Fourth rib is better because it is where you can get all the three muscles in a one plane, that is the pectoralis major, the minor, and the serratus anterior. And you need to move the probe a little lateral so that you can also get the serratus anterior when it is just inserting on the lateral edge of the ribs. So it looks like this. You will see the serratus anterior tapering and inserting on the ribs, and the needle comes inside, and first injection is usually given the deeper one, which is between the serratus anterior and the pectoralis minor, and you deposit around 15-20 ml of local anesthetic of your choice there. And then while withdrawing the needle, the next injection is given in between the pectoralis major and minor. And there the volume is about 10 to 15 ml. So this is the PEC2 injection. Now, these are the things, the theoretical part. But when you do it practically, what I have faced is that, first of all, you need to know if it is for a breast cancer operation, you need to know where the tumor is. And nowadays, our surgeons are also using ultrasound to locate the tumor. Sometimes they locate the tumor with a mammogram, so you need to go through the mammogram or whatever kind of information about the patient's tumor you have. So make sure that your block needle does not pierce the tumor. Otherwise, you will receive a lot of abuse from the surgeon and maybe some lawsuit also. So that is one thing you need to be sure about where you're going. And second thing is, sometimes the breast is big size quite, and then you need to ask some assistant under the drapes, under the sterile drapes, to retract the breast so that when you are imaging, you can, you can displace a little bit of fat and you can go in. And the third problem that I have faced in my last 7 years of practicing PEX block is that the direction of the ultrasound probe, the ultrasound plane, when you're doing an in-plane injection, it is usually a little bit cephalad, and you need to remember that when you are putting in the needle, because otherwise you can see the plane but you cannot see the needle, and where you see the needle you cannot see the plane. That kind of thing happens. So I'll just quickly go through what we did. We came up with this technique a little bit different from what Dr. Blanco described, in that we did not get the cross section of the rib, rather we got the long section of the rib so that the needle would be flat on the rib and then can touch the rib and then come back. And we published that in Clinical Journal of Anaesthesia, Journal of Clinical Anesthesia way back in 2016. And then we followed it up with some more modifications of the serratus anterior plane block and our CT also on this PEX block. Now, I'll just show a few videos. The first one is through the classical technique, like Dr. Blanco showed, that here you can see this is the cross section of the rib, and these are the pleura, right? And just on the top of the rib, before I start the video, I'll just say that you can see this is the serratus anterior muscle. So the needle has to aim to touch the rib first, that is safe, and then gradually withdraw and give a little bit of local anesthetic to dissect the plane. This is very important because sometimes you might end up injecting inside the muscle. And because this, due to the orientation of the muscle fibers, the initial intramuscular injection may look like a fascial plane block. So you need to give a small amount of saline or even local anesthetic and then just scan laterally and see the displacement, how the drug is distributed. So after finishing the deeper injection, then you come out and give the next injection between the pectoralis minor, and this is the major. So this is how the block was initially described by Dr. Blanco, and it is quite a useful technique, and that is how it should be done ideally. And we did a little bit of experimentation with this, and we found out that when we are using a different pattern, different probe holding, here the probe is not held like I showed in the picture. Here the probe is held parallel to the ribs, where you can see the continuous rib shadow, right? This is the shadow of the rib, and on top of that you see the this serratus anterior muscle. On top of that you see the pectoralis minor, and on top of that you see the pectoralis major. So this is like you are used to seeing in your tab block. So 3 layers you can see, and then you can hit the rib and then come out. I'll just play the video to show it. There is no voiceover, so I'm doing the voiceover myself. So this is the rib shadow. You see, if the probe shifts, you can see the pleura in between. But if the probe doesn't shift, the pleura should not be seen like that. So this is the rib. Once you strike the rib, then you have to slightly withdraw, and depending on the position where you have held, and depending on the thickness of the serratus anterior, you withdraw accordingly. And do a little bit of hydrodissection just to confirm that you are in the right plane, and then deposit the 15 to 20 ml local anesthetic you are supposed to deposit in that first layer between the serratus anterior and the pectoralis minor. Then you withdraw the needle gradually, and while withdrawing, it is sometimes confusing where is the plane between pectoralis major and minor. Because in the PEC 1, in the direction of the probe held, that difference of the muscle fibers orientation is quite clearly seen. But if you are holding like this, the difference is a bit tricky to understand, but with time you will come to it. And when you come to it, you just initially inject a small amount and then see the spread. If the spread is well, then you can deposit the remaining volume of the drug there. That is a trick with this thing. Okay, so pretty much that's it. And then what are the indications? The indications are breast surgery, mastectomy with axillary clearance is very useful. Maybe not for just breast conservation surgery or lumpectomy, you may not need, this is an overkill for that, but definitely for the surgery that includes the axillary clearance, it's good to have this block with. And then other surgeries like breast implant or breast expander insertion, other chest wall surgery like chemoport insertion. This is a port that is used in for long-term chemotherapy in children and adults also. They need to do a bit of dissection on the pectoralis muscle, so this block is useful there. And also in pacemaker insertion, you can give analgesia for that with PEC 1 block. The drug that we inject is around 10 to 15 in PEC 1 and 10 to 15 ml between in a PEC 2 level. You can give that higher amount, 15 to 20 ml between pectoralis minor and serratus in the PEC 2. Drug is of your choice. Generally, I use ropivacaine 0.2%, but many people have used ropivacaine 0.5% also. With that, I will conclude my talk. Thank you all for patient hearing. I thank my patients who have given me the chance to learn these blocks on them. It has been a journey of learning and exploration, and in the end, I invite you all to the first cadaveric USRA workshop that we are going to do in Kolkata on 22nd July. Dr. Diwan is going to come here, and thank you.
Thank you, Dr. Arunangshu. Okay, so the session is now open for question answers from the audience. Does anybody have any questions they'd like for any of the speakers? No, yes, sir. Yes, Dr. Figure.
Hello. Concerning the postprandial phase, I want to wake you up a little bit. Okay. First question is concerning the posterior QLB. I just really want to know what's the intention to inject over there. What nerves do you reach?
This is for laparotomies or for the first talk? So we have two speakers on QLB. We have Dr. Arbi and we have Dr. Devesh. So who would like to answer it? I think Dr. Arbi wants to answer it.
Yeah, I would try to. So the question is, what nerves are we targeting?
With the posterior QLB block, yes. Because it's posterior to the thoracolumbar fascia. And what nerve is over there?
So we are.
What is over there?
There is more of the sympathetic plexus that would come there, but we would be aiming for the flow into the lateral anterior as well as the medial parasympathetic flow, the spread.
I don't get that.
So the nerves,
sorry.
I get your point. The nerves would be in the anterior thoracolumbar fascia between the anterior and the QL.
The anterior is absolutely clear. It's for me, it's fantastic. It's an absolute good idea to go over there. But the posterior one, nothing is over there. There are no sympathetic plexus. They are ventrally. There is nothing over there.
I think the plan is for the drug to go to the paravertebral space. So
And to the tap side.
that's what it's aiming for. Whether it achieves it or not is
Doesn't
questionable.
work.
There
It doesn't work.
It doesn't work.
There is this theory that when you do a posterior approach to the QL, you're targeting the lift or the lumbar interfascial triangle, which is rich in
Okay.
nociceptors, mechanoceptors, and there are certain studies which have shown that the ascent up to the endothoracic fascia in the paravertebral space in the thorax is pretty much the same, even when you target the posterior approach.
Let's shorten it. We have altogether, myself, yourself, not a real idea for that. I want to show you some images. I want to show you some cross-sections. It is absolutely not clear what you are blocking over there and what's the intention over there. I just want to bring up a new controversial discussion about this. Anterior, lateral, perfect. Posterior, not perfect.
So is it that the...
okay. I just want to start a discussion about that.
My point is the nerves that are with the QL2 deposition, the drug flows into the tap plane, and is it more that the nerves are based in the QL1 part and the visceral part is taken care of by the mechanoceptors and the...
That's working on the Nisora images, but the Nisora images do not show any fascias at all.
Okay.
Watch out for that. And this is one of the second points I want to show you. The PAX block, the anatomy in the Nisora images are wrong. You're following wrong images. Take care. Take very care about that. Always criticize the images. Always review the images. This image of Nisora is wrong, wrong, wrong. I'm sorry about that. Because the lateral pectoral nerves enter through the clavipectoral fascia medial to the lesser pectoral muscle, or the pectoralis minor.
Okay.
Medial to it, for sure. And the only problem
pierces through
is...
the pectoralis minor and then enters the pectoralis major.
But it is not shown on the images, and that's the problem.
Right.
If you take images, review the images, and take correct images, these are wrong. Okay. Really. If you need some, you get some.
Okay.
Thank you, Dr. Figel. I have a question. Dr. Devesh wants to make a point.
Just 1 minute. Coming back again to posterior quadratus lumborum block, there are 3 principal mechanisms how it can act. These are postulates. One of the thing is that there are no nerves running in that plane. There are free nerve endings in thoracolumbar fascia, that is the middle thoracolumbar fascia, if we explain by 3-compartment model. We are injecting the drug between the epimysium of quadratus lumborum muscle as well as middle thoracolumbar fascia. So free nerve endings and sympathetic nerve block can lead to some kind of analgesia. Number 2 is, as Dr. Sachin said, or Dr. Gopal said, through the lumbar interfacial triangle. It is actually a lateral band which extends from the iliac crest up till the 12th rib. So there is a postulate that the drug can ascend up towards the paravertebral space. Number 3, as I can think, is when we inject 20 to 25 mL of the drug, the quadratus lumborum muscle is encased in thoracolumbar fascia, anteriorly anterior, and on the posterior side, the middle thoracolumbar fascia. We are injecting in between the epimysium and the middle thoracolumbar fascia. So the drug has a fair chance to travel through the lateral surface towards the anterior surface, which I have seen in my practice if I inject 25 to 30 mL. So these are 3 postulates. I think it works. But in my clinical practice, I always practice anterior, which works well for me, and it has got good craniocaudal distribution in terms of ascent towards the thoracic paravertebral. That's what I think. Thank you.
Thank you, Dr. Devesh. Any more questions? Then I have a question for Dr. Devesh. I think he mentioned that the anterior QLB or the transmuscular QLB is associated with drug spread to the lumbar paravertebral space. Just let me finish. I don't think it happens. The nerves, just let me finish. The nerves emerge from the lumbar plexus, which is encased in the psoas muscle, and they're enmeshed in the psoas muscle. You don't have a plane where you can separate the lumbar plexus from the psoas. And as the nerves emerge from the psoas muscle and come to lie in the plane between QL and psoas. Psoas is anterior and QL.
And the first nerves that come out are the T12 and the that's a subcostal, ilioinguinal, iliohypogastric nerves. So this is T12 to L1. These are the nerves that get blocked. The drug doesn't go into the lumbar paravertebral space or the psoas compartment. And this area is where the incision is given. It's the lateral part of the thigh for a posterior hip arthroplasty. So we can't just say drug is spreading everywhere. I agree to some extent with Dr. Figel that we postulate too much. We just imagine a bit on our sides. But now, as far as the QL, transmuscular QL is concerned, it is now well known that it doesn't go to the psoas compartment. In fact, even cadaveric studies have not shown it. Only one study has shown it, and that they injected the drug into the psoas. So I think we should not just postulate too much also.
Ma'am, actually what I mentioned, there are 3 postulate mechanisms as to how the drug can reach to these lumbar nerves. One is if we actually accidentally breach the anterior thoracolumbar fascia, then we are reaching a compartment where is between the anterior thoracolumbar fascia and the psoas major. And the plexus lies in the psoas major. That is a diffusion towards that lumbar plexus. That is one.
If we puncture the psoas muscle,
at
then
times
it's not a QL block anymore.
Yeah, at times we cannot recognize. As a beginner, I have made a mistake. I cannot. If I go back to my images in 2016, I still have videos where I've actually crossed, and I think I gave a QL, but actually I was breaching that. That is one of the mechanisms. Number 2 is direct diffusion towards the nerve roots. The nerve roots actually come for a short distance in the lumbar paravertebral space, and then they actually enter the psoas major. And number 3 is the continuity.
No, Dr. Devesh, that doesn't happen. I'm so sorry, but I disagree.
Lumbar paravertebral space is an
He's inside the psoas. I think Dr. Figel is there, right with us. He's the one who's going to tell us.
Lumbar paravertebral space is an existence which we cannot deny.
I think this entire discussion will not come to an end today. And it makes it clear that this region needs to be really discussed anatomically, especially concerning the fascia. And you will see one image later on, just in a few minutes. And this is something why I just said, okay, come on, that's not working. There is a morphological reason why I'm asking for that. Okay? And we should discuss this later on, based on dissections, based on real, good, embalmed cadavers, and not on interpretations which are forming images like that. No way. Okay? These are causing the failures. You don't need to, because you are following postulations which might not be true. And then you do not following the truth. And this is the important point, to be honest and critical about it. It's what I'm doing. And as you already know, I was wrong in different anatomical interpretations, and I had to change them. But do not trust everything, especially images. I'm sorry about that, of Nisora. It's not the first image, and you will see so many others which are definitely wrong.
Peter, sir, Mike.
Dr. Figel, the thing is, what you're pointing out, till now we have been using it. It has been working, okay? Why it is working? The thing is, obviously you are into a dissection part, you are seeing things, but in our clinical practice, we have been applying these blocks, okay? Even posterior QL, I use regularly in my lap hernia surgeries. And obviously it works. And it is not that 25 ml which I am putting it is acting by the absorption of the local anesthetic. There must be some mechanism. I am getting the patient clinically pain-free. It means they are working. How it is working? Obviously, we don't go into cadavers. You and Sandeep are going into cadavers. So we will see once you come out with your cadaveric publications and everything, and then we can apply clinically and we can compare both.
Yeah, but the problem is just to say, okay, it works, well, let's follow it. You should know a reason why it is working. Don't you want to have the reason for that?
For that, I cannot go to a cadaver.
I think, Dr. Ritesh, the next
Well, I'm
talk,
working with enough collaborations clinically. I'm sorry about that.
That's why we are telling.
Really,
Dr.
I'm
Ritesh,
sorry.
I think next talk is going to talk about the lumbar plexus. And we need to learn from cadavers, even if we can't go to
I am glad we had this animated discussion. It actually woke all of us up. And I'm even gladder because my lecture follows and I'll have an awake audience. So thank you all for your participation. Let's please move on to the next session.
No, Dr. Anjali, I have a comment on this. See, we have a cadaveric study which Dr. George has mentioned. I have also gone through this. Posteriorly, you do not have nerves at all. You're depositing the drug there, and you postulate that it could be a sympathetic innervation which is blocked. That is one thing. Second, anterior thoracolumbar fascia, you have got just one nerve, which is really passing through that. That's the ilionic venous nerve. The subcostal is very lateral. Do you want to block the, invade the whole of quadratus and then into the anterior thoracolumbar fascia just for one single nerve? That's the second thing. Third thing, we have followed with clinical studies, and a lot of we have been doing, all of us. We find that this clinical impact. Block efficacy, yes. To some extent, in some surgeries, it may be dependent on some of the surgeries. If you follow this with contrast studies, we have seen the contrast extending sometimes to the thoracic paravertebral area, not all the time. Not all the time. So it almost remains surrounded in the thoracolumbar fascia. So does it really work? You need to have a cadaveric clinical and contrast correlation for this.
Sandeep, just one thing. Would cadaver and a living person who has a rhythm of breath and pulsatility of the arteries and the veins, so will the spread not be affected by that?
It does, definitely, yes. The tone of the muscles, the characteristics of the fascia, and the local anesthetic, the volume that you inject, the compliance of the fascia, everything is going to affect the block. It's not only one single factor that is going to affect the block. So you have all these things. If you give a ESP at the level of T6, in the evening you'll find his buttocks getting numb. Why it happens with the catheter technique? So all these things matter.
So I think we've had a very interesting session, and we are looking forward to Dr. Figel's next talk. I think he's going to talk on the lumbar plexus. And I think it's an eye-opener. We should not believe everything that's told to us, and we should have, open view to things. So we're changing, Dr. Figel. We're no longer the chairs. So we end the session. Thank you very much.
Thank you, Dr. Anjali, Dr. Archana, Dr. Fultambekar. We go on to the next session, lumbar plexus. I call upon moderators Dr. Hetal Vadera as well as Dr. Arunangshu Chakraborty to please moderate the session.
So, ladies and gentlemen, we are about to start our today's session. The session is on lumbar plexus, and our first speaker is none other than the highly celebrated and a little bit debated Dr. George Figel.
Thank you. Fortunately, I'm debated. Unfortunately, it's not only the lumbar plexus, it's also the sacral plexus, so it's again a little bit hurried through. Just an overview, a brief one here about the lumbar plexus. And I see two of these, at least three of these, we will not discuss very much indeed. And concerning the sacral plexus, we just focus a little bit on the sciatic nerve because of the time. 10 minutes is not very much indeed. Just a view of the retroperitoneal region of the right side over here. Where you see the iliac crest, you see branches from the lumbar plexus running down. This is the thoracolumbar fascia, transversus abdominis fascia. Inserting is the deep portion of it. You see the quadratus lumborum, the psoas major, and nerve fibers running laterally and then piercing the abdominal wall, or let's say the transversus abdominal muscle. And the other ones are just much more caudally, and two of them are the most important, the lateral femoral cutaneous and also the femoral nerve, which are the nerves of interest. Concerning these already a little bit discussed, enthusiastically discussed blocks, you just see over here the kidney, the retrorenal fascia, quadratus lumborum, thoracolumbar fascia splitting, and this is the point also concerning the discussions only in two fascias, which is the superficial and deep portion. And over there you see now the ilioinguinal nerve, and over there already the nerves of the iliohypogastric and subcostal nerves. And as you see the fascia splitting, there might be the lateral nerve fibers, but nothing concerning the lumbar plexus, and that's why the discussion arises. And you see, it's a little bit questionable concerning the anatomical point of view, concerning also the lumbar plexus. So these are the QLB situations, and dorsally, well, we have to discuss, I think. You see the nerve fibers running down. This is now the inguinal ligament, where you can see or properly then block femoral nerve and lateral cutaneous femoral nerve. Well, you need the femoral triangle over there. As you see, the sartorius, the gracilis, and the inguinal ligament. These are, of course, the Latin terms, so you have to change a little bit now, not from the English terms to the Latin ones. You get the femoral vein, the femoral artery, and laterally already split regularly and divided into different nerve fibers and also layers, the femoral nerve itself. On the most lateral part, you have the lateral femoral cutaneous nerve, and medially, as you see already, deep underneath the pectineus, and then dividing into the anterior and posterior branch, the obturator nerve. Well, concerning the femoral triangle, you see how it looks like in the soft embalmed cadaveric specimen. With the fascias on it, we can go deeper, and then you see they're already splitting very close to the inguinal ligament. It's still a trunk, or let's say a trunk, but already dividing into the different nerve fibers. If you get now a cross-section, you see the femoral nerve just underneath the iliac fascia, as you can see over there. Some of the nerve fibers already arose, running laterally. These are regularly the innervations of the sartorius muscle. Then, if you just make an enlargement, again, the iliac fascia, just running and inserting over here at the terminal line. So it means if you just insert over here or inject, you will never get a medial spread to the obturator nerve, which is unfortunately covered, or let's say separated by this fascial wall. So if we just go now to the lateral femoral cutaneous, which is really clearly laterally viewable, you have another dissection over here, very close to the anterior superior iliac spine, spreading or splitting then in different nerve fibers. And this is one of the most important topography, that you have medially, regularly, the sartorius muscle, and lateral, the tensor fasciae latae. So it's in between, you have a triangle, a so-called fat-filled fascial tunnel, where you find the lateral femoral cutaneous easily, and then block him before splitting into different nerve fibers. This is just before he's reaching the anterior superior iliac spine. You see it's accompanied by an artery in the area, and then, oops, if you see it over here already distally, you see the spread it. This is the tensor fasciae latae, sartorius, and the different nerve fibers over here when he's already split it and divided in different nerves. Concerning the obturator, you have the pectineus muscle, elevated and partially removed. You have the adductor longus. You see now the fascial plane of the anterior branch, and if we split it, you can see the enlargement now just underneath the suprapubic ramus, where you find over here the anterior branch, the posterior branch, here separated by the obturator externus muscle. If we make a cross-section in the area of the three adductor plane muscles, you see the two planes where you have the anterior and the posterior branch. And this is something what you really can easily block and also reach. These are real fascial planes where you can inject your local anesthetic. So how do we find them? Also following the inguinal ligament, you first just take the landmarks of the femoral artery and the vein. Laterally, you will find the femoral nerve. Then you just move laterally to get into the triangle for reaching the lateral femoral cutaneous, and then going medially again for and a little bit distally regularly when you want to have the obturator nerve already split into two planes. If you go more cranial or more proximally, you're just underneath the superior pubic ramus, and in a depth of about 2 and 2.5 centimeters, you will find the trunk of the obturator nerve before dividing. So just summarizing over here, you see hypogastric ilioinguinal with the psoas compartment quadratus lumborum. Tab is the ilioinguinal, already a little bit a questionable nerve because he's too close to the iliac crest at that time. Genitofemoral is a different story, running absolutely not like the textbooks. We had an investigation about that. The lateral femoral cutaneous and the femoral with a suprainguinal or infrainguinal block, perfectly reachable, and the obturator with a 3-in-1 questionable because over there you just need a spread reaching the spine area where the nerve passes dorsally to the psoas muscle, because you cannot get the medial spread directly. This is one of the disadvantages of the suprainguinal or infrainguinal block. Finally, sciatic nerve, splitting into the two main nerves, common peroneal or fibular nerve and the tibial one. You have the exit in the infrapiriform foramen, passing then superficial to the entire deep muscles of the hip joint, as you can see over here, and accompanied by different nerve fibers. One of them you will hear tomorrow is the posterior femoral cutaneous. If you just see over here, this is the nerve passing to the pelvic trochanteric muscle group, and then running distally. We are here just close to the infrapiriform foramen. You see it's just continuing medially into the lesser pelvic area. So if you want to have a parasacral block, absolutely good idea, but just really be careful concerning the needle tip not to advance too far into the depth. If it's running more distally, you will see the nerve running distally over here, very close to the sciatic tubercle, and even just more medially there would be the pudendal nerve, which is even another story. So if we make a cross-section over here at the area of the quadratus femoris muscle, you see it's more an oval nerve fiber, nerve structure, but anyway very clearly identifiable in this level where you can perform the block. If you go now to the popliteal fossa, watch out, this is the left one. You have the common fibular nerve and the tibial nerve with all the different muscular structures forming the margins and the borders. You see over here the tibial nerve running straight distally and the common fibular nerve running laterally with all the different branches arising from these nerve fibers. And of course the tibial nerve is one of the is this most superficial structure in this area. And if you make a cross-section over here, you see that these nerves are really in a so-called paraneural sheet, very close together. You can separate them easily because there is a soft connective tissue layer in between. And just want to give you, a focus on this little boy down here. It's a nasty one. This will really harm you concerning, for example, block techniques in the ankle joint and the Achilles tendon area, but you will hear about that tomorrow. Okay, so that's the short overview about it, and let's continue. Thank you very much.
Thank you, Dr. George, for a wonderful presentation. We will take question answer at the end. Next presentation is by Dr. Venkateshwaran, And it is on what makes lumbar plexus block a high profile block. Usually we believe that it is a high profile block, it is a high risk block, but Dr. Venkateshwaran will throw some light how it can be given. Over to you, sir.
Good afternoon, everyone. First of all, I would like to thank the organizing committee and Sandeep Devan sir for giving me an opportunity to talk in this CME. My topic is what makes lumbar plexus block a high profile block. First of all, I have no conflict of interest, and all the photos what I have taken are from the clinical photos from the patients which usually get consent from them. So introduction. Lumbar plexus block is considered an advanced regional anesthesia technique with proven efficacy. And it is always a part of multimodal analgesia in lower limb surgeries. And it has got the potential for systemic toxicity is high since the needle is placed in deep muscles. And this lumbar plexus and sacral plexus are like twin brothers. When they come and act together, it provides a complete surgical anesthesia to the lower limb. I have a case scenario, two case scenarios. One is a 55-year-old male with a gangrene of left leg. He has got so much of comorbid illnesses and we're having severe nephropathy, ischemic heart disease with an ejection fraction of 30%. The plan was to do a left ebony amputation. So this was done under lumbosacral plexus block with a PNS guidance, and ebony amputation was done. The second one is a second case scenario. We had a 65-year-old male with a bilateral below knee amputee with a necrotic right below knee stump. So he was in sepsis. So he needs a right ebony amputation for that. He's also having a lot of comorbid illness with an ejection fraction of 30%. So we did this under lumbosacral plexus block with a PNS guidance, and the surgery was done only with this block. And regarding this patient, we did a sacral plexus block because there is no foot to see the end point, end motor response. So we just look at the hamstring contraction as well as gastrosoleus contraction with the nerve stimulation and gave a sacral plexus block. So why lumbar plexus block is a high profile block? Because the resultant sympathetic block is unilateral and it is postganglionic, and there is no hemodynamic fluctuations as you compare it with the neuraxial anesthesia. It also reduces the opioid requirements and blood loss in total hip replacement under general anesthesia. Continuous lumbar plexus block provides an early ambulation and effective physiotherapy in hip surgeries. And when it combined with the sacral plexus block, it gives complete surgical anesthesia to the lower limb. Therefore, it is a gold standard for unilateral limb surgeries with severe comorbid illness and with severe diabetic autonomic neuropathy, which were having a low ejection fraction. So, keeping this in mind, we had about 647 diabetic foot surgeries in last year, and then these are all the amount of comorbid illness the patients was having. You can see so much amount of n number of comorbid illness the patients are having, and all these were done under regional blocks. Almost 85% were done under regional blocks in the form of peripheral nerve blocks. And we can see that lumbosacral plexus block, about 57 cases was done. We have specifically isolated this lumbosacral plexus block for ebony amputations, which are very useful for so much amount of comorbid illness these diabetic foot surgery patients are having. How will you identify the lumbar plexus? So it can be identified by peripheral nerve stimulation and also by dual mode, that is ultrasound as well as peripheral nerve stimulation. So the position of the patient is lateral position with a slight forward tilt, with the hip being flexed at 30 degrees and knee being flexed at 90 degrees. So all these patients needs a small amount of IV sedation with fentanyl and midazolam. The landmarks are, we have to first see about we have to find out the posterior superior iliac spine, which looks like a small dimple in the back, and we have to identify the upper border of the iliac crest, and from the upper border of iliac crest to the opposite upper border, we have to draw a line that is called intercostal line or Tuffier's line. And from the PSIS, we draw a line perpendicularly up where it meets the Tuffier's line. So this is the point of insertion for lumbar plexus, and this is what we can call it as by Vinnie's approach. The next one is Capdevilla's approach. They insert the needle 1 centimeter medial to what the point for Vinnie's approach. So this is a lumbar plexus block by nerve stimulation. So we inserted the needle in such a way, by 4 centimeters, we landed up in the transverse process, and by stimulating with 1.5 milliamps and going 1.5 to 2 centimeters from the transverse process, we got a good quadriceps twitch, and then we slowly reduces the current from 1.5 milliamps up to 0.5 milliamps. Since the quadriceps twitch was still present, Then we aspirated and injected about 20 ml of 0.5% bupivacaine was injected. And it has to be very careful that it has to be injected very slowly in such a way that every 2 to 3 ml you have to aspirate and inject. The most important thing is the distance from the transverse process to the lumbar plexus is not more than 1.5 to 2 centimeters. So whenever you move the needle from the transverse process, don't go beyond 2 centimeters. Always start with 1.5 milliamp current and slowly reduce it until you get a palpable twitch of quadriceps muscle at 0.3 to 0.5 milliamps. The possible depth is 6 to 8 centimeters. The volume of the drug, what we inject, is 20 to 25 ml. In pediatrics, it is 0.7 ml per kg. The pitfalls and corrections: after walking over the transverse process, if there are no quadriceps contraction, you deviate the needle 5 to 10 degrees on either side. Instead of quadriceps, if you have a hamstring stimulation, then the needle is quite medial, so there has got a high risk of epidural spread. You withdraw and direct it correctly. If you have both quadriceps as well as hamstring twitch, it's because of the needle touching lumbosacral trunk, you have to redirect it laterally. But if you have a flexion of thigh, that means it is because of the psoas major muscle stimulation, you withdraw and redirect the needle. Then the next one is lumbar plexus block by Shamrock method, that is by dual mode. We have to mark the same thing like how we do it for the nerve stimulation guidance, and then you keep a curvilinear probe just above the iliac crest. You'll be able to see the lumbar vertebra and all the Shamrock sign of all the 3 muscles. And then we introduce the needle like how we did for Vinny's technique. As the needle goes inside, you'll be able to see with the Shamrock method, the in-plane technique, where you can see the needle which is coming inside, and once it reaches the lumbar plexus, then before itself we have to start stimulating, and once it reaches it, you'll be getting a good quadriceps twitch. We are starting with the nerve stimulation, and you can see a quadriceps twitch which comes, and later, if it comes at 0.5 milliamps, then we can start injecting the drug. You can see the drug always covers, and you can see the lumbar plexus is being soaked with the drug. Now they say there's a superiority of ultrasound-guided Shamrock lumbar plexus block because you're able to see the needle very well in in-plane technique. Assessment of the block is onset time is 15 to 20 minutes. The first sign of onset of block is loss of sensation over the saphenous region, that is just above the medial aspect of the leg. Regarding perineural catheters, we can also give continuous lumbar plexus block by Vinny's technique, where we keep the needle opening just facing cephaloid so that it facilitates the catheter placement. Catheters are inserted not more than 5 centimeters beyond the tip of the needle, and it's very important that you have to give a continuous infusion, requires intermittent boluses for the success. Regarding complications of lumbar plexus block, it's because of the needle puncture. It can cause direct trauma to the nerves. It can cause the injury to the renal capsular, injury causing renal capsular hematoma if you go at L3 level. Suppose if you puncture one of the retroperitoneal vessels like ascending lumbar vein, it can produce a concealed hemorrhage and hypovolemic shock. If you keep the catheter for a long period of time, we can see most of the patients are diabetics. So there is got high chance of psoas abscess in these patients. And sometimes if injuring the psoas major muscle can produce a psoas major hematoma, which can land up in lumbar plexopathy. The complications from indirect lumbar local anesthetic placement is it can produce an epidural spread in 3 to 27% of the cases, and it can also produce a spinal spread. Another complication from local anesthetic is it can cause local anesthetic systemic toxicity. Now we should know how to, you can see this picture showing a lot of ascending lumbar vein and lumbar artery, all are lying close to the vertebra, body of the vertebra.
The nerve root and lumbar plexus, a blood vessel, if any, and the lumbar paravertebral space. Depending on the ease of visibility of all of these structures just listed, a score of above 20 was supposed to be good, and a score below 10 was poor. And the authors saw that in the combined group where ultrasound was combined with nerve stimulation, the number of needle passes were lesser, and the overall block failure incidence was also lesser. And this was a dose-finding study wherein the authors looked at the Shamrock approach to the ultrasound-guided lumbar plexus block, and the conclusion was that a volume of 20.4 mils of 0.5% ropivacaine was sufficient to produce an effective lumbar plexus block. And in this particular RCT, Benston and colleagues, they combined in healthy volunteers 2 approaches to an ultrasound-guided lumbar plexus block. They compared the ultrasound trident approach with the shamrock approach, and they concluded that the shamrock approach was faster than the ultrasound trident approach, was more comfortable for the patient, and required fewer needle insertions. And in this particular study, the authors compared 3 different ultrasound-guided approaches. In the picture on the left is the placement of the low-frequency curved transducer just lateral to the spinous process. In the picture in the center is what we do typically by placing the probe just lateral to the transverse process. And in the picture, which is far right, is the shamrock. And the authors concluded that the contrast between the lumbar plexus and the psoas major muscle was best when the probe was placed in the paravertebral area. This particular article by Sandeep, Abhijit, and colleagues from Pune actually hit the nail on its head. We tend to use a combination of lumbar plexus and sacral plexus blocks in elderly geriatric sick patients who present for surgical fixation of proximal femoral fractures. These patients are supposed to be too sick even to tolerate the hemodynamic perturbations that follow a spinal or an epidural. And as per this retrospective case series in a limited number of patients, the authors noted that the psoas major appeared quite bright when visualized on ultrasound. So the echogenicity of the psoas muscle was altered. And this is owing to sarcopenia of the psoas muscle, an increased fibrous content, and a decreased water content of the psoas muscle. And in addition, bony structures were not too easy to identify either, owing to disc degeneration or osteophytes or facet joint arthritis. Therefore, the authors concluded that we must always do a pre-procedural scan with ultrasound before venturing to do the block, and they concluded that we must combine ultrasound with nerve stimulation in this age group of patients. And in conclusion, given that in the group of patients where we definitely need to do a lumbar plexus block for surgical anesthesia, ultrasound does not help that much. I cannot conclude that ultrasound makes the practice of lumbar plexus block safer. Look forward to seeing all of you in Hyderabad in August next year. Thank you very much for your attention.
Thank you, sir. Our next presentation is the how deep the needle be in the sacral plexus. So for lumbar plexus, we know that we should go 1.5 to 2 centimeter beyond transverse process. But what about sacral plexus? Dr. Vedika Shankar will tell us how deep it should be. Dr. Vedika.
Good afternoon. Thank you for the very kind introduction. I would like to extend my gratitude to the scientific committee at AORA for having given me this opportunity. My topic today is how deep the needle be in sacral plexus blocks. Skipping straight to the topic proper, what do we need to get through in order to reach the sacral plexus? First, we start with skin and subcute, which we reflect. Then we move to the gluteus maximus, which is a very thick muscle that extends from the iliac crest till the femur. Now let's reflect that as well. Zooming in a little, these are the muscles we see. From superficial to, from cephalad to caudate, we have the gluteus medius, the piriformis, our target structure, the sciatic nerve in this case. For point of reference, any block that's given to the sacral plexus before it reaches the inferior border of the piriformis is a sacral plexus block. Below the inferior border of the piriformis, it becomes a sciatic nerve block. And we have the gammeli, the tendon of obturator internus, and the quadratus femoris. Now, flipping the patient anteriorly, we're now looking into the pelvis, pelvis tilted forward. we can see that the sacral plexus has been formed by the anterior ventral rami of S1 to S4, and we also see the contribution from the lumbosacral trunk. Now, a little messier image, but it gives you an idea of what all is surrounding the sacral plexus. The white gauzy material we see is the pelvic fascia. We can still see the sacral plexus behind, and anterior to it, separated by just the pelvic fascia, are the internal iliac vessels and the rectum, structures that as a regional anesthetist, I absolutely do not want to be poking. So again, going from superficial to deep, we have the skin and subcute, varying depths of fat, the gluteus maximus, piriformis muscle, the sciatic nerve or sacral plexus, superior gemelli, the pelvic fascia, the pelvic viscera, and the internal iliac vessels. So now that we have this image, I'd like to draw, or rather target, a few areas. That is the PSIS. This is the ischial tuberosity. Now let's connect the two with a line. And we have a point being marked off 6 centimeters below the PSIS on this line. This is the classical Mansour's approach to the sacral plexus. Now, this block was originally described in 1993, not a very long time ago. The depth of the sacral plexus becomes very relevant when attempting a sacral plexus block in PNS, more so than in ultrasound, but nonetheless, it is important in either technique. So, the depth, the needle is inserted at this point, 6 centimeters chordate to the PSIS. Needle is perpendicular to all planes, is passed on through straight, and you should get the sacral plexus at a depth of 6 to 8 centimeters. In the original article, Mansour also describes that if bony contact is made, withdraw the needle and reinsert the needle 1 centimeter chordate, and that the needle is not to be passed or moved more than 2 centimeters from the depth at which bony contact was made. This might sound a little familiar because we do have similar endpoints for the lumbar plexus as well. Your target end motor response is toe and ankle movements, but we can also accept hamstring movements at this point. Now, so this is a patient positioned for the sacral plexus block in Sims position. Markings have already been done for the lumbar plexus, which has just been completed. To highlight again, this point over here is the PSIS, this is the ischial tuberosity, and over here we have marked off Mansour's point for the parasacral block. Now, what's the fuss about the sacral plexus block? What I have highlighted here, what is highlighted here, are the osteotomal, myotomal, and dermatomal coverages that you can get with a sacral plexus block. Now, added to something as simple as a femoral and LFCN block, this is the analgesic and anesthetic distribution that we are likely to get. You are safe to perform an above-knee amputation, which typically happens in your sickest of patients. I have not caused an epidural, but this is enough. Now, suppose we have added a lumbar plexus to our sacral plexus. We have a completely anesthetized lower limb. The entire leg is highlighted in analgesic and anesthetic coverage. This is the original article put up by Mansour in 1993. Now let's fast forward to the 2000s. We have a study by O'Connor et al. In 2009. Now he performed an MRI study on 10 patients in the lateral position in the MRI suite. Now, once these patients were scanned, they also had plotted on their scans a potential needle trajectory had they undergone a sacral plexus block through Mansour's approach. Now, 5 of the patients had successful needle passes in the exact way that Mansour had described, as you can see. Now, 5 out of 10 so far. 4 of the 5 had sacral plexus blocks that were successful. 1 out of 5, the plotted trajectory reached the sciatic nerve, which is fine. In the remaining 5, however, the first pass was unsuccessful. Now, following Mansour's technique, we then remove the needle and plot a new trajectory 1 centimeter chordate. In all 5, the second needle pass was unsuccessful as well. Now, more dangerous still was what they targeted instead. Rectum in one, small bowel in another, blood vessels in a third, acetabulum in a fourth. It's one thing to get a failed block, a whole other to have a needle in the rectum. So in all of these, if you notice, the distance is less than the 2 centimeters described after you've reached bony contact. So this study called into doubt the veracity of the statement, if bone contact is made, reinsert 1 centimeter chordate, but limit further depth to less than 2 centimeters. So what are our options? So a study published by Dr. Sandeep Diwan in 2022 suggests using gluteal contractions as a gateway to the sacral plexus. 10 adult patients were used in this study. All 10 of them had gluteal muscle contractions at 1 milliampere in the performance of the block via the standard technique. Once the current was dropped to 0.4, loss of response was obtained. Loss of response to the gluteus muscle contraction occurred. Needle was advanced further by just 0.5 to 1.5 mm, and successful block was performed. So this, before we go on further, is a video from the same article. This is from Sandeep Devansar's article. So as you can see, there are gluteal muscle contractions. The whole gluteus muscle is contracting, and within just a very short amount, you will start seeing target EMR for the sacral plexus. Now, what other options exist? Of course, I would say you have dual guidance. Many ultrasound-guided approaches exist, and these are not very old. The first ultrasound-guided block was first described by Ben Ari et al. In 2009. Then we have the parasacral parallel shift in 2011, and Taha's approach to the sacral plexus, which is a slightly modified version of the parasacral parallel shift in 2012. Now, all of these techniques first aim to see the iliac bone as a common continual line with the gluteus muscles overlying. Move your probe caudal. The way you move your probe varies between the PSPS as well as Taha's approach, but the idea is you look into the sciatic notch and visualize the sacral plexus as it exits the sciatic foramen. In the parasacral parallel shift, you will see a long axis of the sacral plexus exiting, versus in Taha's, you will see it in short axis. Now, this is in a pediatric patient, hence the linear sector view you can see here. There is my sacral plexus, and I don't know if it's appreciable, the pulsations of the vessel. So I've highlighted here. This is the inferior gluteal artery, which is medial to the sacral plexus. So that makes this my iliac bone, and this is my greater sciatic foramen. In this, again, usefulness of, I've only used ultrasound in this technique. Needle has come in. There is a loss of resistance as I pop through the fascia, and after negative aspiration for blood, because I'm very close to the inferior gluteal artery, there is deposition of local anesthetic around the sacral plexus. So finally, the high yield points. Unlike lumbar plexus, the sacral plexus block does not have a fixed safe distance for needle passage beyond bony contact. MRI studies and imaging modalities have revealed that you can encounter not go-to areas for a regional anesthetist before that 2 centimeter mark. This is very important. Risks of injury to the intraperitoneal viscera and iliac vessels are very real. Blind redirections following bony contact should not be done. And gluteal muscle contractions are a very effective marker of proximity to the sacral plexus if you're using a PNS-guided technique. But be warned, this is within 0.5 to 1.5 mm beyond the infragluteal nerve. The dual guidance approaches are strongly advised, are safe, and allow visualization of targets as well as non-targets. These are my references. Thank you so much for the time.
Thank you, Vedika. That was a wonderful talk. And our next speaker is Dr. Varshali Kenia. Is going to speak on femoral LFCN and obturator below inguinal ligament, landmark guided.
Good afternoon, all. Yeah, here I am in the era of ultrasound, talk upon the landmark-guided femoral obturator and LFCN block. Before starting the talk, I want to declare there are no conflict of interest. The pictures are taken from the net, and the necessary consent has been taken from the patient while showing the clips. Coming to femoral nerve, as we all know that from the detailed anatomical discussion by Dr. George, the femoral nerve is the anterior rama from L2, 3, and 4. And it's the largest nerve of the lumbar plexus, which runs through the psoas muscles, and it comes from in the middle of the psoas muscle, and at the level of the inguinal ligament, it just passes below the inguinal ligament, where it lies in the femoral triangle. The important applied anatomy, when it lies in the femoral triangle, it is superficial to the inguinal crease and where it can be approached by landmark guided. And it immediately divides into anterior and posterior branch. So if you block distally or more caudally, you can miss one of the branches. So it's very important that you block it as cephalad as possible. That is one thing. And the second thing, as mentioned again in the earlier lectures, that the fascia are different for the femoral vessels and the femoral nerve. The femoral nerve is entrapped in two fascia, like fascia covered by two fascia, fascia lata and fascia alata. So we need to remember this. And it lies immediate lateral to the femoral artery in the femoral triangle. The indications could be analgesic and anesthetic. For like the analgesic, like fracture femur, skin grafting, pain related, saphenofemoral vein ligation, and analgesia for above and below the knee amputations. Anesthetic again for skin grafting, and in combination with sciatic or popliteal block in the lower limb. So coming to the procedure, we identify the anterior superior iliac spine and pubic tubercle, and the line joining is the inguinal ligament. The femoral nerve lies at the center of the inguinal ligament. So you first palpate the artery, mark the artery, and now the femoral nerve is 1.5 centimeter lateral to that and caudal to that. So once you have marked the femoral artery, under all aseptic precautions, you palpate the femoral artery and keep a thumb over there and take a needle prick or 1.5 centimeter lateral and distal, and as you either take a perpendicular incision over the skin and go directly down perpendicularly. With the two pop of the fascia lata and fascia iliaca, the nerve stimulation can be seen. So as you can see here, once you approach the femoral nerve, the contractions of the quadriceps muscle are observed, the typical patellar tap or dancing patella. Here one should be careful enough that if you are stimulating the anterior branch, the sartorius muscle can get stimulated and which can be confused with the quadriceps muscle stimulation. So you need to be careful about that. So coming to obturator nerve, the obturator nerve is the anterior division of the L2, 3 and 4 lumbar plexus. The obturator nerve, as it advances down, it runs along the medial border of the psoas muscle. At the level of the pelvis, it lies lateral to the ureter and below the iliacus vessel and runs along the lateral border of the bladder. As it passes below the inguinal ligament, it runs into the obturator canal and then runs into the different planes of the adductor muscles and on the medial side of the leg, where it divides into anterior and posterior division. The anterior division lies in the adductor brevis and adductor longus, while the posterior between the adductor longus and magnus. Again here, the important thing to remember that the obturator nerve can divide in the obturator canal itself or maybe cephalad to that also. So that is important to remember. And one cannot forget the accessory obturator nerve, which is anterior, forms from the anterior rama of L3 and L4. Coming to the indications, so for the hip joint pain, again relief of the adductor muscle spasm associated with the hemiplegia or paraplegia, and in the urological surgery to suppress the obturator reflex during TURBT. To give the block, the patient is positioned supine with the slight abduction of the hip joint around 20 to 30 degrees, and pubic tubercle is palpated, and a point of insertion is to 1.1 to 1.5 centimeter lateral and caudal to this point. A perpendicular needle insertion is done, the 10 centimeter needle used of PNS, and after going out almost about 2.5 to 3 centimeter, you can get a contraction of the anterior division of the obturator nerve, and the adductor longus contraction can be observed. So here you can see the contractions of the adductor longus muscle. After decreasing the current, the contractions can be observed again. So you can decrease the current till 0.4. Yeah, so here we are stimulating the anterior division of the obturator nerve. Coming to lateral femoral cutaneous nerve block, it arises from the posterior division of the second and third lumbar plexus. It's a pure sensory nerve and it supplies over the lateral aspect of the thigh. The nerve traverses through through the psoas muscle. It takes an oblique turn towards the anterior superior iliac spine caudally, where at the level of the anterior superior iliac spine, it runs below the linguinal ligament. At times it runs above the inguinal ligament also, and it then lies at above the sartorius muscle or the lateral angle of the sartorius muscle. Again, for LFCN, it is important to note that there are various different variations, almost 7 to 8 variations are seen. And it is very common that it may not lie near the anterior superior iliac spine. So when we are giving with the landmark block, it may be missed at times. So these variations are needed to be kept in mind. The indications are diagnosing and treating nerve entrapment like meralgia parasitica, skin grafting along with the femoral nerve block from the upper thigh, muscle biopsy, and postoperative analgesia after hip surgery. The point of insertion, you mark the anterior superior iliac spine. The point of insertion is 1.5 centimeter medially and caudally. You insert the needle in the skin, and as you go perpendicularly down, you can get a pop of the facial lata, and there you can deposit the drug for the LFCN block. For all these blocks, either if you want to use analgesic block, then you can use 0.25% of either bupivacaine or ropivacaine, and for anesthetic block, you can use 0.5% of bupivacaine or ropivacaine, and this can be done around 15 to 20 ml of the solution you can deposit there. Yeah. Thank you.
Thank you, Dr. Varshali. Our next speaker is Dr. Rasika Tamane. She is going to speak on the femoral, obturator, and sciatic nerve targets, all ultrasound guided.
Good afternoon. Okay, so I'm going to talk about the anterior approach to the femoral obturator and the sciatic nerve altogether. In my opinion, this block should be idealized for lower limb surgery, especially the surgeries on the knee joint. So why do we have to have an anterior approach to these nerves? Because some patients, we can't really turn them around and perform the posterior approach to the sciatic because of bed sores. Some patients have fracture constructs. Some patients are on splints. Some patients have scheduled traction devices. In them, it is not really advisable to flip them over and perform the blocks by the posterior approach. So to overcome these difficulties, we came up with the FOSS block, as the term was coined by Dr. Sandeep Diwan, my mentor. So we started doing this initially as a double puncture. We graduated and started started blocking all the nerves through a single puncture approach. Adding sciatic nerve block to the femoral nerve is, for the painless knee arthroscopies, it is one of the ideal things to be done, as the posterior part of the knee joint is mostly supplied by the sciatic nerve. When we talk about the obturator nerve, the modern indications for obturator nerve block are minuscule, but when knee is concerned, the posterior capsule do have innervation by the knee joint, for the knee joint, right? So when we have a look at the knee innervations anteriorly, we'll come to know that majorly it is supplied by the femoral nerve. Some part of it on the lateral aspect is supplied by the branches of the sciatic nerve. The posterior aspect, majorly sciatic nerve, and some divisions of the posterior obturator nerve, right? So when we talk about sciatic nerve, it exits from the greater sciatic notch. Initially, it is covered by the superior and inferior gemelli, followed by the obturator internus, and as we go further down, it is covered by the quadratus femoris muscle. Principally, the gluteus maximus covers it. It exits from the lower end of the piriformis, as we all know that. So this is an image from the archive of Dr. George Fiegel and Dr. Sandeep Diwan. So when we perform a FOSS block through an anterior approach, the trajectory of needle is going to be through the muscles. These are sartorius, the rectus femoris, the pectineus, the adductor longus, brevis, magnus. So when we are actually trying to reach the sciatic nerve from the anterior approach, we may come across the anterior and the posterior division of the obturator nerve, the branches of the profunda femoris artery, and the branches of the circumflex femoral artery, medial and the lateral. Right, so why not block them all together? Okay? So when we are going through, we'll see how we scan. So if we are planning to have a single puncture, so as I said, initially it was a little tough for us even to, plan and block all the nerves through a single puncture. So we were doing femoral and obturator block in the single puncture, and we were going down and trying to locate the sciatic nerve. And depending upon at what level you're scanning, the sciatic nerve will be covered either by quadratus femoris, if you are scanning at the superior level, or by the adductor group of muscle as we are going down. So it will rest on the biceps femoris as we scan distally. So what should be the position of the leg? So technically speaking, we would say that we should laterally rotate the leg, like externally rotate, so the sciatic nerve will fall exposed, but that's not the case. When we did some MRI studies, we realized that the lesser trochanter actually covers the sciatic nerve if you take the leg in the external rotation. So the ideal position is actually the medial rotation of the leg or the neutral position of the leg. So the position of the probe is going to be on the femoral vessels first. Start scanning from the femoral vessels. Take the probe medially to isolate the pectineus muscle. As I said, we can block the obturator main trunk as we go on the way, or we can block the obturator anterior and the posterior division as we scan distally for the sciatic nerve. We change the probe to see the sciatic nerve in the longitudinal or the transverse section, depending upon our choices. So how do we locate the obturator nerve? We scan the femoral vessels, turn the probe medially, turn the probe towards the medial aspect of the thigh, and then point it cranially to isolate, to recognize the superior pubic ramus. Once the superior pubic ramus is isolated or recognized, we will see a thin strip of obturator external muscle and the pectineus muscle. So femoral triangle's floor is formed by the pectineus muscle. So as we go medially, we'll see the big chunk of muscle, which is pectineus, and the three group of adductors, which are stacked on top of each other. So you'll come to know that there is an inverted E or a W sign on the medial aspect. This is how the muscles are arranged. So this is the position for the obturator nerve, how to isolate the proximal trunk. So this is image taken by Nielsen et al., the study which is conducted, but that is the proximal trunk block under the subpectineal fascia. So as I've described earlier, so the pectineus will be just below the pectineus, the obturator main trunk is formed, and it divides in two branches, the anterior and the posterior. This is a small short video which shows how the pectineus muscle and the formation of the adductor group of muscles on the medial aspect. As I said previously, it will form an inverted V or a E-shaped appearance. These three muscles are stacked on top of each other. You can see a small artery pulsating there. That's the medial circumflex branch of the femoral artery. So that can get in your way. So for identification of the sciatic nerve, there are not many literatures how to, they are describing how exactly the sciatic nerve appears on the anterior side, when we are scanning it anteriorly. So at the level of lesser trochanter, it may happen that the nerve lies behind it, so it may not be visible. Sometimes it is covered. So in my opinion, it is better identified in the longitudinal section. Right, so when we are trying to isolate it, the nerve is usually isoechoic, so it usually sort of mixes with the surroundings. So you may find it difficult to isolate the nerve in the transverse section. So ideally, we should be doing a longitudinal scan to see the entire cable-like arrangement of the nerve fibers. Majority of us are using portable ultrasound and other machines like G and Sonosite. So trust me, the resolution is not really good for these machines. So if you're using a Volusin, which costs around 48 lakhs, probably you'll see an entirely different image of what we see in our operation theaters. So as I said before, better to use a longitudinal scan to identify the sciatic nerve rather than using a transverse scan. So when we are scanning the sciatic nerve in a transverse section, we'll see that the two facial planes, they form between the adductor muscles. The anterior plane will hoist the anterior division of the obturator nerve. The posterior plane will hoist the posterior division of the obturator nerve. Then why not just block it on the way? Right. So this is a short video of how the patient is positioned and how do we block it. So conventionally, how we do femoral block is we place the probe laterally. Right. So here we place the probe laterally on the femoral nerve and get the needle even more laterally. Here we'll take the probe on the medial aspect and bring the needle in from the medial aspect of the probe rather than coming from the lateral aspect. So we have to be very careful because there are chances of injuring the femoral vessels. Right. If you can see it. So that's the pectineus muscle which is formed. These are the femoral vessels and that's the femoral nerve. The same video, same continuation of the same patient. Sorry, this video is playing before this one. I'll just try to demonstrate this again. Right. So on the left-hand side of the screen, we can see the femoral nerve being anesthetized. I have taken the needle from the medial aspect of the probe, deposited local, and then repositioned my needle in the subpectineal plane to block the proximal division of the obturator nerve. Right, so identifying the sciatic component. As I said, it depends on the level where you scan. If you're scanning proximally, you will probably see a small muscle which is called a quadratus femoris muscle. It looks like a less than sign. If you're scanning distally, if you have just given up, no, I can't see the sciatic nerve in the plane above. So probably you will have to go a little down. And it happened to me initially. So I was using double puncture approach. First, I used to block the femoral and the obturator, and I was coming down and scanning one more time to see the sciatic nerve lower down. So it is little easy to identify a sciatic nerve lower down because it forms an equilateral triangle with the femur and the femoral vessels. So this is a short demonstration of how we isolate it. So this is a single puncture, same patient, which is continuing. Yeah, so we have isolated the nerve. We have recognized it, the needle is coming in from top, and that the longitudinal cable-like thing is the sciatic nerve. So this I showed how to do it in plane by using an in-plane approach. This we will be doing out-of-plane approach. The video is from the archives of Dr. Sandeep Diwan. So he's used an out-of-plane approach to block the femoral nerve. Then we will reposition the needle to block the anterior division of the obturator and the posterior division of the obturator nerve. That's it. Thank you. I apologize for the inadequacies in my presentation.
Thank you. Thank you, Dr. Rasika. It was a wonderful presentation. And now we are coming to the concluding talk of this session. Dr. Ramamurthy Kulkarni is going to talk on the PENG block. Following that, we'll have the question and answer session.
Good afternoon, everyone. So I'll be speaking about the PENG block, which is an acronym for the pericapsular nerve group block for the hip. So before going to the PENG block, in per se, so it's imperative to look into the nerve supply of the hip. So the nerves which consistently supply the hip on the anterior aspect are the femoral nerve, the obturator, and the accessory obturator nerve. Whereas on the posterior aspect, we have the sciatic nerve, the nerve to quadratus femoris, the superior and inferior gluteal nerve. But when it comes to the analgesia of the hip, we block mainly the nerve supplying the anterior aspect of the hip, that is the femoral obturator and the accessory obturator nerve. We don't bother about the posterior hip nerves. That's because you can see that all the nociceptors are crowded in the anterior capsule of the hip. That's the reason why the hip pain is mainly coming from the anterior capsule rather than the posterior capsule. So when it comes to the innervation of the anterior capsule, it's convenient to divide the hip region into 4 quadrants: the supralateral, supromedial, inframedial, and infralateral divisions. The articular branches of the femoral nerve are divided into high and low depending upon whether they arise above the level of inguinal ligament or below the level of inguinal ligament. The high branches are given at the L4, L5 level, and they pierce the iliacus muscle, go deep to the psoas tendon between the anterior inferior iliac spine and the iliopubic eminence, and they supply mainly the superior aspect of the capsule, and some fibers, they supply the infralateral aspect of the capsule. Again, the fibers of the obturator nerves, they divide into high and low, depending upon the high fibers arise from the obturator nerve trunk, main trunk, either within the obturator canal or proximal to it. And then the low fibers, they arise from the posterior division of the obturator nerve. They go up and they supply mainly the medial aspect of the capsule. The accessory obturator nerve, usually a single nerve arising from the lumbar plexus. It runs along the medial border of the psoas muscle and runs posterior to the psoas tendon over the iliopubic eminence, and mainly supplies the medial aspect of the capsule. So this is the nerve distribution pattern of the femoral nerve, mainly supplies the superior and the infralateral aspect of the capsule. The obturator nerve supplies the inferior aspect of the capsule, whereas the accessory obturator nerve supplies the medial aspect of the anterior capsule. So this is the transverse section at the hip where we do the peng block. You can see that's the iliacus muscle, and that's the psoas tendon, the articular branches running between the muscle and the bone and supplying the hip joint. And then when you do a peng block, hopefully we block all these articular branches and causing the analgesia of the hip. So the bony landmarks pertaining to the peng block are the anterior superior iliac spine, the anterior inferior iliac spine, the iliopubic eminence. So you do scanning systematically to look at all these bony prominences to do the peng block. So you start with the anterior superior iliac spine using the curvilinear probe. You can use a linear probe if the patient is thin, and then systematically scan downwards and medially towards the iliopubic eminence for the peng block. So this is the video to show how do you scan for the peng block. You start with the anterior superior iliac spine first. That's a bony and easily palpable landmark, and then you slide the probe downwards and medially to bring the anterior inferior iliac spine in the view, and then further medially and downwards what you see is the iliopubic eminence, and the muscle that you see is the iliacus muscle, and the bright structure that you see is the psoas tendon. You can see the femoral artery and the femoral nerve there, and from this position, if you slightly bring the probe slightly caudally, what you start seeing is the head of the femur there, and that shows that you have come down too caudally, too downwards. So that's not the area where to do the block. You slightly, again, go back cranially, and you have to see the bone as one straight line. So that's where you have to do the peng block. So this is the block video again. You can see the femoral nerve, femoral artery there, iliacus muscle, right? Right, then that's the psoas tendon there, and that's the iliopubic eminence, which looks like one single line. So now the needle is coming from the lateral to the medial direction, going through the muscle, iliacus muscle, and then landing on the bone lateral to the tendon. So make sure that you don't pierce the tendon, otherwise it will be very hard to inject the local anesthetic. The aim is to deposit the local anesthetic, which lifts the muscle off the bone, so that the local anesthetic now traverses medially just beneath the tendon, and it is not injected within the intramuscular area. The injection should never be done intramuscularly. So that's how the block is done. You can see the local anesthetic is traveling beneath the tendon and it's going medially. Again, in this video, you can see that nice medial spread of the local anesthetic. It's a needle coming there. Needle is not very seen clearly here, but you can see that the local anesthetic is spreading medially beneath the tendon above the bone. So how much volume to be used? There is an article by Tran where he used 10 and 20 ml. He compared the two volumes, and both the volumes soak all the three articular branches from the femoral obturator and the accessory obturator nerve. So you can use anywhere between 10 and 20 ml. We commonly use 20 ml, which gives good duration of analgesia. So when PENG block was compared to no block, it decreased the opioid requirements and it improved the pain scores. And when PENG block was compared to the suprainguinal fascia iliaca block, the analgesia was comparable, but at the same time the PENG had less motor block because you are not targeting the femoral nerve, the main trunk. So it is a motor sparing block for the hip. So what are the concerns with the PENG block? There are few case reports where there have been a quadriceps weakness. This is because of either intramuscular injection or too medial or large volume injection. What happens when you inject too medially and with the too large volume, the drug seeps along the medial aspect of the iliacus muscle and it can go back and block the femoral nerve. Second injection is intramuscular. When you inject intramuscularly, so it can go back and block the femoral nerve. So how to prevent this complication? So you use not too large volume and don't inject too medially. And second thing, to avoid the intramuscular injection, so when you pierce a fascia in other parts of the body, you indent the needle first, the fascia, right? Indent the needle and then you pierce the fascia. But that cannot happen here, right? Because there is a bone beneath the fascia. You cannot indent the fascia here in the posterior aspect. So what you have to do is just slightly twist and turn and push the needle so that you can pierce the fascia and you can inject the local anesthetic between the fascia and the bone so that you don't do an intramuscular injection. To summarize that, the PENG block is a safe, simple block to do and it's very effective. It's motor sparing block for the hip and it is comparable to the suprainguinal fascia iliaca block for the hip analgesia, and avoid intramuscular injection and too medial injection to prevent the facial nerve block and causing the quadriceps weakness. It's all about the PENG block. Thank you very much.
So thank you, Dr. Ramamurthy. I invite all speakers to come on stage for question answer.
Do we have any question from the audience to any of our speakers?
George, you want to make a statement?
Sorry if I bother somebody, but and somebody will not be quite happy with that. I dissected it myself concerning the PENG block. Guess what? There are no nerves in your plane. Really. It's now the 10th cadaver in the row, no nerve at all. I compared also the original manuscript, which is lacking very important information concerning the method. First, they do not exactly describe where they start. Second, no layer is really set on where the nerve fibers are. They just elevated and removed the entire muscle. So I'm pretty sure that some parts will go intramuscularly, and over there are the nerves. So you have to have an intramuscular diffusion. Nevertheless, it's quite an interesting way. It's working. But how? Again? No idea. So this is one of the major problems. Also that you have to take into account the volume you use over there. That's huge. So you might create also the so-called regional anesthetic tsunami. What you do not get with your needle, you get with your volume. Over there, fortunately, no problem. Okay? So again, we are looking, I'm an anatomist, I'm looking for nerves, I'm looking for structures. There is nothing currently. I haven't seen it yet. The accessory is an interesting one, but again, I have to doubt the dissections provided into the original manuscript because they look more like vessels, not like nerves. I have never seen a splitting of a nerve in a 90 degrees angle, but more or less in a just sharp angle. Okay? And these are 90 degrees.
Okay.
So this question goes to both Gopal and Venkatesh. That our study where we saw nothing in the SOAS elderly patients, as you rightly said, where this block has to be performed. In that case, suppose a neurostimulation also doesn't help. So do we abandon the block as a whole, or what should be the goal? Because I have not yet come to answer to this.
Sandeep, I'll try to hazard an answer. If you do not get a neural stimulation, I would probably abandon the block, because between ultrasound guidance in a geriatric patient and neural stimulation, I would believe that the endpoint for proper location should be nerve stimulation. I have a question for you, Rasika. For a knee joint arthroscopy, why would you need a sciatic nerve block? I mean, these are day surgery procedures. Yeah, the FOSS, you said, right? You combine it and you said it's good for knee joint arthroscopy.
So they do harvest tendons from gracilis and posterior aspect of the semitendinosus, so hamstring tendons. Yeah. So for the construct of the ligaments.
Okay, you're talking of reconstructive surgery.
Yes, sir.
Okay,
Yes.
that's fine.
So yeah, Venkatesh, please.
In one of our patients, we are not able to get a neurostimulation. That, sir, you asked about that. So in such a case where surgery has to be done for the patient, he is in quite an amount of sepsis, and then amputation has to be done. So we just use the local anesthetic and individually block the nerves. We just block the femoral nerve, obturator nerve, lateral femoral cutaneous, and we got a good twitch for the sacral plexus. So that's how we just try to complete the procedure. And that if you block all the nerves individually, there's also that it also gives a very good tourniquet. We can also apply a tourniquet and reduce the bleeding during surgery. That one possibility that I can think about it, sir.
I just want to add a point here. I know this is a regional anesthesia conference and we should be talking about advocating nerve blocks, but GA is not a bad option. You can put the patient to sleep. I would not want to put 40, 50 mils of local anesthetic into an old man.
So this is regarding the PENG block, Ramurthy. Recently we did 8 cadaveric sections, so around 16 specimens, and we had injected methylene blue dye. I'm sorry for that, but could not help. That's latex, we don't have it here. And Rasika and Pallavi both, they were there as a part of that study in JSS Mysuru. Believe me, it just stained the alveopubic eminence and nothing else. There were no nerves, as you rightly said. What we saw was in only 1 out of 16 specimen, there was an accessory obturator nerve. That's all it had stained, that too not complete from its dorsal aspect, not on the ventral aspect. But it had stained the whole of the dorsal part of the facialicus, and it had percolated through the muscular slips and had come ventrally. So does it mean that it's just another sort of facialica block, which we now term as a dorsal facialica block? Just a change of terminology. Yes. Going right up to the ASIS, in cross sections where Archana was there in Madurai, we had cross sections. It had gone onto the LFCN and close to the femoral nerve. So it's just acting like that, and that's the reason why you're getting around 24 to 52% of quadriceps weakness.
Yeah,
could be a possibility.
Just extension of what Sandeep was talking. Isn't it the pain block is much glorified name or something like that, rather than it's a LIA? You are injecting, in your presentation you say you are lifting from the bone and this thing. Maybe we are deviating from many blocks, as I was listening to many presentations in the infraclavicular fossa. Instead of locating the nerves, now they are finding out place where you inject, like a corner pocket injection in infraclavicular at a particular point, and expect all the nerves to get blocked. Just. What are your comments?
Peng block is still a relatively new block. I think more studies are needed, especially the cadaveric studies to revalidate the block technique.
So what I understand is, as Dr. Ramamurthy showed in his presentation, that with 20 ml of LA, drug is spreading towards femoral nerve also. So what Sandeep sir is telling is the course of the drug, or where drug is going to the femoral nerve, is a different way rather than what is showed by Dr. Ramamurthy.
Apart from that, there is also, I think, ileopectineal bursa over there, just over the top of the iliopelvic eminence. When you're trying to needle in this area, are you really trying to go inside the bursa? Inject that. 15% of the times the bursa communicates with the hip joint. So it's sort of, I have a feeling now that the Peng block is just an intrabursal block. Can change the nomenclature.
Do you have any other questions from the audience? Okay, I have one question to Dr. Gopal. You have, regarding this lumbar plexus block, the psoas compartment block, you said about the two approaches. One is the parasagittal and the other is a shamrock, like in the trident and the shamrock approach. Given the anatomical disposition of the lumbar arteries and veins, which approach do you think would be, possibly cause more hematoma or trauma to the lumbar arteries and veins?
I'll give you an honest answer. I am not an exponent of ultrasound-guided lumbar plexus blocks. I did this lecture because Sandeep asked me to do it. But intuitively speaking, I would say that the shamrock approach would give you a better exposure to the ascending and descending lumbar arteries and veins when compared to the ultrasound trident.
That means that the shamrock is like it will cause more hemorrhage. The chance of hemorrhage is more with shamrock.
You would be able to pick up vessels better and make sure your needle doesn't impale them when you do your block. This is what I believe. Sandeep, want to corroborate?
Okay. Thank you all faculties.
So apart from that, Dr. Vedika, it was a very nice presentation. Thank you very much.
We'll conclude the session. Our next session is on sacral plexus. I invite the chairpersons, moderators for the session, Dr. Neha Singh, Dr. Ramamurthy Kulkarni, and Dr. Ravi Jamkhande.
Moving on to the next session of on sacral plexus, we have Dr. Ganesh Bong, who will be speaking about between the sciatic posterior or anterior approaches, the choice.
Good afternoon, everybody. My topic of presentation is posterior versus anterior sciatic block. What is the choice? To start with, let us discuss functional anatomy of the nerve in brief. So nerve is formed from L4-5 S1-2-3 roots, which converge to form sacral plexus on anterior surface of the lateral sacrum. These converge to form sciatic nerve on the anterior surface of piriformis muscle. Nerve exits greater sciatic foramen by passing below the piriformis muscle. Below this, nerve lies between two bony structures, that is ischial tuberosity and greater trochanter. Here, nerve runs superficial to obturator internus, two gamellae, and quadratus femoris muscle. Here nerve is accompanied by posterior cutaneous nerve of thigh on its medial side and inferior gluteal artery. Below this, the course of the nerve can be shown by drawing a straight line from the midpoint of GT and IT to apex of popliteal fossa. During this course, nerve lies between bicep femoris muscle and adductor magnus muscle. Now, first we'll discuss posterior approach, which first described by Gaston Labat in 1923. This figure shows distribution of anesthesia of posterior approach, which results in anesthesia of back of thigh and complete leg below knee, except skin on the medial aspect of the lower leg and foot, which is supplied by saphenous nerve. This slide shows landmarks of neurostimulation technique, that is Labat's approach, which are greater trochanter, posterior superior iliac spine, and sacral hiatus. This is the needle entry point. This is the diagrammatic presentation of this approach, where needle entry point is on the top of the nerve. Now coming to ultrasound-guided posterior approach, patient is in lateral position. Low-frequency curvilinear probe is placed in transverse plane between greater trochanter and ischial tuberosity. The needle will come from lateral side of the probe and will be in plane. Sonoanatomy of this approach. The nerve can be identified between two hyperechoic bony prominences, that is greater trochanter and ischial tuberosity. The nerve appears as a hyperechoic triangular or oval structure with honeycomb pattern with it. It appears as a structure sandwiched between gluteus maximus and quadratus femoris muscle. The nerve usually appears closer to ischial tuberosity than greater trochanter. This is the trajectory of the needle coming from lateral to medial side. This is the video of posterior approach, where this is greater trochanter from lateral side, ischial tuberosity on medial side, needle coming through gluteus maximus muscle. Once the position of the tip is confirmed, local anesthetic is injected. The nerve is best imaged after injection of local anesthetic. Now we can appreciate triangular sciatic nerve floating in hypoechoic local anesthetic. Now coming to anterior approach, first described by George Beck in 1963. This figure shows distribution of anesthesia by this approach. As posterior cutaneous nerve of thigh departs at the level proximal to this level, so the distribution is limited to below knee. This slide shows landmarks of anterior approach described by Beck. These are inguinal ligament, which is divided into 3 equal parts, and a line from GT parallel to inguinal ligament. This is the needle entry point. This is the diagrammatic presentation where needle entry point on the top of the nerve, which lies in close relation to the femur. And these are the different needle passes which are required to perform the block. Now, ultrasound-guided anterior approach. So probe position is that probe, low frequency linear probe is placed on proximal medial thigh, just distal to inguinal crease. This photograph shows the needle position, which is in plane, out of the plane. Sonoanatomy. So sciatic nerve can be identified as a spindle-shaped or oval hyperechoic structure below adductor magnus medial to femur bone. Other structures we see are femoral artery, sartorius muscle, and adductor muscles, that is adductor longus, brevis, and magnus muscle. The in-plane approach is less practical, as we can see the femoral artery or femur bone itself can come in the trajectory of the needle. So out-of-plane approach is commonly practiced. So once nerve is identified medial to femur and deep to adductor magnus, it can be confirmed by tilting the probe in the longitudinal axis so that the sciatic nerve appears as a long, thick, cable-like structure. This is a video block technique. The sciatic nerve can be identified below the adductor magnus. We can appreciate pulsations of femoral artery. The needle coming from above and out of plane approach. Once needle tip is closer to the nerve, neurostimulation is started, and we can appreciate contractions of adductor magnus on the ultrasound image. Once after confirmation, the 1 to 2 ml of the drug is given, and this will delineate the sciatic nerve from the rest of the musculature. This will displace the nerve away from the needle. We always perform the UAG guided anterior or posterior sciatic block along with neurostimulation only. So twitches we are getting are inversion. This dual technique is a confirmatory as well as a safety measure. Alternatively, sciatic nerve can be blocked in the longitudinal axis by anterior approach, where probe is placed in the groove between sartorius and rectus femoris, distal to the inguinal crease. So once probe is placed, we see femur bone with dark shadow beneath it. Then probe is slided medially to see sciatic nerve in longitudinal axis as a long, thick, cable-like structure embedded between the adductor magnus and bicep femoris muscle. This is the video of longitudinal approach, courtesy Dr. Diwan. So as needle is advanced towards the sciatic nerve, we can appreciate twitches of adductor magnus. On further advancement, these twitches ceases and twitches of foot indicate successful needle position. So once confirmed, the local anesthetic is injected, which appear as a thin hypoechoic horizontally expanding line, which opens up the fascia in both cranial and caudal direction, anterior to the sciatic nerve. The advantage of anterior approach is that there is no need to change the patient's position. This is helpful in patients with spine fractures, polytrauma patients, patients with external fixator, and patients having severe pain. But nerve is at deeper location with this approach. Also, steep angle of the needle makes difficulty in needle tip visualization. Again, this is a highly skillful block, and this block can be utilized for anesthesia below knee only. A posterior approach, the nerve is superficial as compared to anterior approach. This approach is easy as compared to anterior approach. Again, posterior cutaneous nerve of thigh is blocked, so along with lumbar plexus or femoral block, anesthesia of complete leg can be achieved. But we need to change the position of the patient. These are the 3 studies which compared anterior versus posterior approaches, where this study which showed that posterior sciatic nerve block is superior to anterior sciatic block with respect to the onset of time, quality of anesthesia, and patient satisfaction. But earlier these 2 studies which concluded that there is no difference between both approaches with respect to onset, the duration of action, and quality of anesthesia as well as patient satisfaction. So to conclude, both approaches provide comparable anesthesia. Our choice depends on site of surgery, the level of skill of the performer, and other patient factors which differ the change in patient's position. Thank you.
Thank you, Dr. Ganesh. Now I would like to invite Dr. Santosh, who will be speaking on neurostimulation. Dr. Satish Fadke, who will be speaking about neurostimulation. What would be the ideal evoked motor responses?
Good afternoon, delegates and friends. I have been given the topic of popliteal block neurostimulation and what would be the ideal evoked motor response. So, for every block to be successful, one has to be accustomed with a good knowledge of anatomy of the block. So, what is a popliteal block? Popliteal block is the block of the sciatic nerve approached in the popliteal fossa at the apex of it, where there is generally at the bifurcation of the two terminal branches of the sciatic nerve. The aims and objective of popliteal block generally are achieving the complete anesthesia of limb below the knee joint, except for the saphenous nerve. The indications are obviously any any surgical condition below the knee joint and without a tourniquet or tourniquet of a short duration. Coming to anatomy of sciatic nerve is a very big nerve. It starts from L4, S5 segments, spinal nerve roots. Though it has two components, the tibial and common peroneal, they are physically joined, but actually they maintain the functional differentiation. Bifurcation point of sciatic nerve is variable, and by statistics, it is generally 60 mm plus minus 27 mm above the knee crease. So block of sciatic nerve 10 centimeter above the knee crease gives maximum success. Sciatic nerve location is 1 centimeter lateral in the parasagittal spleen, and it is located halfway between skin and bone. The popliteal vessels are more deeper and medial. These things are very important to remember when you are giving a sciatic block to prevent complications. Then certain histological feature of popliteal nerve in this area. Popliteal nerve is, the sciatic nerve which becomes a popliteal nerve has unique anatomical feature. It's like a trouser. That means there is a common epineurium. All other nerves in the body have epineurium, but here there is one more layer that is called as a common epineurium, and block will be ideal when the needle placement is under the common epidural. That is, if the needle tip is somewhere here, you will get maximum success. Material required is 100 mm insulated needle and PNS machine because it's a fairly deep block. Before approaching a popliteal block, one has to be familiar with the anatomy, and these two pictures are permanently have to be fixed in your brain before approaching, so the chances of complications are minimum and your direction of the needle will be appropriate. For the needle insertion, there are two approaches described. One is the posterior approach, that is in the prone position, and the other approach is the lateral approach. For the posterior approach, the position is prone, the knee is slightly flexed, and the leg is supported with a roll of towel. So it is in a neutral position and the rotation is prevented. And the roll of towel keeps the foot off the bed. This is the position, typical position. As you can see, this side is to be blocked. Otherwise, there is some amount of rotation. Landmarks for the posterior approach are biceps femoris muscle on the lateral side, semimembranosus and semitendinosus muscles on the medial side, popliteal fossa crease, tip of popliteal fossa. This is one picture showing the landmarks, that is the knee crease. And even in obese patients, finding of knee crease is not difficult because there are typical dimples at the insertions of both these muscles, biceps femoris and this tendon. These are invariably present even in obese patient. And when the patient is asked to lift the leg, these muscles become prominent and you can mark those tendons portion of those muscles. Coming to puncture point in the posterior approach, the crease is marked by joining these two tendinous insertion points. A midpoint is marked on this line. A perpendicular line is drawn from the midpoint cranially, and a point is marked 7 centimeter on that line. Our puncture point is 1 centimeter lateral to this point. So the puncture point is on lateral side. We have to remember every time that the nerve is on lateral side and you never have to go on medial side, otherwise you are going to puncture the vessels. Classic posterior, there are different approaches described even in the prone position. The classic posterior approach, intertendinous approach, or an alternate approach. But the technique is same in all this, that is insert the needle at 45 degrees anteriorly and in the cephalad direction. These are diagrammatic representation. This is the classic approach, the puncture point is 1 centimeter lateral to the midline. This is the intertendinous approach, and this is a modified approach where the puncture point is 10 centimeter above the crease on the medial edge of the biceps femoris muscle. Coming to needle position scenarios, what are the things which will happen when you insert the needle? You may not hit the nerve directly in first go many a times. So what are the possible situations and how you need to modify them? That has to be learned. If bone is contacted without muscle response, what are you going to do? That means you might be too medial. Withdraw the needle to subcutaneous level and redirect first 10 degrees in lateral direction or maybe 10 degrees in medial direction, mostly in the lateral direction. Needle should be inserted to about half the bone contact depth. You have touched the bone, that means you are too deep, which is dangerous. So, nerve should be contacted somewhere in a halfway. Second scenario, you will get a dorsiflexion and eversion of the foot, which is a fairly common scenario. That means your needle is contacting the common peroneal nerve. Is it the acceptable response? It can be accepted, but better scenario can happen. This is the diagram where you are hitting here to the common peroneal. So, withdraw the needle and slightly redirect in the medial direction to seek inversion of the foot. This is the modified technique where your needle is slightly going that way. So, you will get an inversion of the foot. That is the ideal response. Then the third phenomenon which can happen, directly there is a plantar flexion of the foot. That means you are directly targeting the tibial nerve. What you have to do? Withdraw the needle and redirect slightly in the lateral direction to seek the inversion of the foot. So, inversion of the foot is the best possible response. Inversion is possible when the needle is somewhere in between the two components. Coming to lateral approach, patient is supine with leg in neutral or slightly internal rotation. Patient resting supine with a pillow under the leg to make the position neutral or slightly in a medial rotation. Mark the apex of patella and mark the groove between biceps femoris and vastus lateralis. This is the vastus lateralis muscle and this is the biceps femoris. Patient is supine, so biceps will be posteriorly. Mark the apex of the patella, then draw a line in the groove, mark a point 7 centimeter above from this point, that is your puncture point. Needle insertion. 10 centimeter 19 gauge or a 22 gauge BB weld needle is selected. Inserted in the horizontal plane till femur is contacted. Needle withdrawn to subcutaneous level and redirected in 30-degree posterior. Needle advanced 1 to 2 centimeter deeper than bone contact to get a motor response. First pass needle is inserted. Can I have 2 more minutes, 2-3 minutes? I have to show the video. I will go a little faster. I think the bell has rang. Na? Needle is inserted in horizontal plane until femur is contacted. Second pass needle withdrawn and reinserted posteriorly, as you can see in this picture. Tibial response is plantar flexion of the foot and toes. Common peroneal is dorsiflexion and eversion. I will directly go to the video, I think, and then we will discuss the tip. This video shows with a slight movement of the needle, there is alternate change of response. So, see, this is the dorsiflexion. Earlier it was plantar flexion. With a slight movement of the needle. That indicates the ideal position of the needle tip. The next video is of the posterior approach. That was the intertendinous approach. That is the inversion response, which is the most ideal to get a complete block, rather than only one nerve getting blocked. This is the lateral approach video. First local is given. The local needle is touching the bone and I am coming back. I am redirecting the local anesthesia needle for the second pass. Generally, in the lateral approach, the first response you get is the eversion and dorsiflexion. That means you are touching the common peroneal nerve. One has to just advance a little bit to get a tibial response. And the common response, that is stimulation of tibialis anterior plus tibialis posterior, results into inversion. That is the ideal response. This is the distribution as well. Thank you. Any questions, or we'll discuss
We'll
later?
take questions at the end of the session, sir.
Okay, no problem.
Thank you so much for the presentation. Now I would like to invite Hetal sir, who will be speaking on ultrasound, why I do not need an evoked motor response. So it's literally USG versus PNS.
Thank you for kind introduction. Before I start presentation, I will like to ask all of you whether you have observed that you are giving the block with popliteal block with PNS technique. You are trying hard, but you are not getting response. And many a times happens that you are using both technique, ultrasound with PNS. You have inserted the needle. You feel that you are in the right plane, and you are not getting evoked motor potential. So I hope many of us has observed it. How many of you have observed it? Can you please raise your hand? Yes. So this was to awaken you. So can you load my presentation? Yeah, thank you. So I will, after wonderful presentation by Satish sir on PNS guided block, I will going to speak why I do not need EMR, or evoke motor response is not always possible, why it is so. So PNS guided popliteal cytic block is age-old technique. Popliteal block is associated with higher incidence of nerve injury at the same time. So we need to be careful that we don't injure the popliteal nerve. Ultrasound guided technique has made us understand needle to nerve proximity, but still there are chances of nerve injury. So this was an article by Dr. Edmir Edzik, Dr. Christopher and team. They studied that intraneural injection with low current stimulation during popliteal cytic nerve block. What they did is they took PNS machine, they took ultrasound, and they monitored injection pressure, injection pressure also. What was the end response? When they found motor response at 0.2 to 0.5, that was end response, or with ultrasound guided technique, when needle was in the paraneural sheath, that was the end point. And what they found was, in 20 patients out of 24, needle was intraneural and there was evoked motor response. But out of 24, 4 patients had no response in spite of increasing current up to 1.5 milliamps. So needle was intraneural or in the paraneural sheath, but there was no motor response. So they concluded that the absence of motor response to nerve stimulation during popliteal cytic nerve block does not exclude intraneural needle placement. So when you are giving with PNS, your needle might be intraneural, but there are chances that you are not getting the motor response. So PNS has got very good specificity, but if you look at the negative predictive value sensitivity, it is comparatively lower. Similar study was done by Tony Sai and the team. They concluded that specific response to nerve stimulation with currents less than 0.0 milliamps occurred only when the needle tip was positioned intraneurally. So when needle was intraneural, there was response below 0.2 milliamps. So there was good specificity. But motor response could be absent with intraneural needle placement at a current intensity of 1.7 milliamps. So even with 1.7 milliamps, there was no response. So what was the reason? One of the hypotheses is peripheral nerve can be hyperpolarized during nerve stimulation. When you are inserting the needle, when you are closing towards the nerve get hyperpolarized. And when you are close to the nerve, you will not get any response. So even if you are closer to the nerve or in the paraneural sheath, you might miss the motor evoke response. So what should be done? If you look at the anatomy of the nerve, These are the neurons and the endometrium. Surrounding the many neurons make fascicle, and surrounding the fascicle there is a sheath that is perineurium, and all of them are surrounded by epineurium. So if you go inside epineurium, there are chances of nerve injury. But there is one more layer, that is peraneural sheath, that surrounds popliteal nerve and both the components, tibial nerve and common peroneal nerve. So when you inject below the peraneural sheath, drug will spread nicely to both the tibial and common peroneal component. It is like a trouser. When you inject at the upper level, it will spread in the both sleeves of the trouser also. So Manoj Karmakar and team did a study, and they injected a drug at the division of the popliteal sciatic nerve where it gets divided. And what they found is onset was faster when you inject in the peraneural sheath, duration is the longer, and success rate is quite higher as compared to other techniques. Similar finding was seen by another study by Anahi Parlas and the team. They also found that when you inject in the peraneural sheath at the junction, at the point where nerve divides, onset is faster and duration is prolonged. So if you look at the anatomy, here you can see this is the peraneural sheath and this is the epineurium. So our target area is this point. So if you inject the drug after piercing the peraneural sheath and above the epineurium, then the patient will have no nerve injury and faster onset and longer duration of the action. This is the diagram to show this is the subperaneural compartment, this is the peraneural sheath, and this is the division of the popliteal nerve in the tibial nerve and common peroneal nerve, and this is Coco's septum. So if you deposit the drug here, drug will spread surrounding both the nerves. So how to give ultrasound guided block? It can be given in supine, lateral, as well as in the prone position. It depends on how you practice. We have to start scanning from a popliteal crease with linear probe, identify popliteal artery, vein, and tibial and common peroneal nerve, then slide transducer proximally to identify the junction of both these nerves where they merge, go little distally, and this is the place where you can inject the drug. You can go either with in-plane technique or out-of-plane technique, and you can inject 20 ml of LA there. So here is the video where you can see this is the perimysium. This is the muscle and this is the perimysial tissue. So if you start injecting the drug here, you can see drug is spreading inside the muscle. But once you advance the needle in the peraneural sheath, you can see a drug will spread surrounding the nerve. This is the nerve and drug is spreading surrounding the nerve. And somewhere here you can see this is the peraneural sheath. So drug is spreading inside the peraneural sheath. And here you can see vessels also. So this is how you can give the ultrasound guided block. This is another video where you can see nice spread of the drug surrounding both the components. Here you can see this is the peraneural sheath, this is the nerve. And when we scan distally, we can see the division of the nerve and drug is surrounded the both component, that is tibial component and common peroneal component. So after giving injection, you can see drug is surrounding, drug is made donut around the nerve. Now I am scanning proximally, and now you will see that the drug will divide into two parts, that is common peroneal and tibial nerve. Here you can see common peroneal is getting separated, and you can see drug surrounding both the division of nerve. So this is the sweet spot where you should inject the drug, and you have good, faster onset and longer duration. So to prevent the nerve injury, we should understand the needle to nerve proximity with ultrasound guided regional anesthesia. And for that, we have to accurately, machine should be good enough to accurately identify the nerve as well as the needle, and operator must be trained enough to identify the nerve and the needle. These are some tips and tricks how to identify needle tip. There are various tips. You can go through the literature, and this is how nerve presentation and nerve interpretation can be done with machine as well as with the operator. So if you know how to perform a block, if your operator is a good, then you can deposit at desired drug at the desired target. So to conclude my talk, PNS guided technique with high specificity but low sensitivity. So even if you are not getting motor response, you might end up giving drug inside the inside the nerve, and you can injure the nerve. Absence of motor response doesn't rule out intranural needle placement. Ultrasound has also got some limitations, like if you are not trained enough, you can injure the nerve, and it has got its learning curve. But if you combine both the modalities, PNS and ultrasound, along with injection pressure monitor, then there are less chances of nerve injury. Thank you very much.
Thank you, sir. It's a good, extensive, excellent talk, sir. Covered almost all the points. Now I would like to call upon Dr. Javed Khan, sir. Here, he will be speaking on, I can locate easily with the landmark, finding 5 nerves around the ankle on landmark and on the versus ultrasound.
Good evening, ladies and gentlemen. Greeting from the cleanest city of India. I'm Dr. Javed from Indore. Time is limited, so I have to be a little fast. Considering the innervation of the ankle at the plantar cutaneous innervation and the dorsal, it is evident that the ankle is supplied with the 5 nerves. Out of these 5, 3 are superficial and 2 are deep nerves. We see the anatomy of this each and individual nerve. The tibial nerve lies posterior to the posterior tibial artery at the ankle joint in between medial malleolus and the tendo-Achilles. Deep peroneal nerve lies anterior to the in the ankle joint and in between the tendons at the level just lateral to the pulsation of the dorsalis pedis and in between the tendons of the tibialis anterior and external hallucis longus. Superficial peroneal nerves lies lateral to the fibula and coming to the ankle joint becomes anterior and becomes superficial in the subcutaneous plane. Sural nerves lies on the lateral side just between the tendo-Achilles and the lateral malleolus. Saphenous nerves lies medial to the saphenous vein. Looking to the surface landmarks, with the PNS, this tibial nerve or posterior tibial nerve can be blocked 3 to 4 centimeters proximal to the medial malleolus, just beneath the pulsation of the peroneal artery, the posterior tibial artery. And with the landmark technique, it can be blocked at the ankle, just above the tendo-Achilles. A deep peroneal nerve with PNS can be blocked 3 to 4 centimeters proximal, and at the ankle joint, it can be blocked with the in between the tendons of the external hallucis longus and external distal longus, just medial or lateral to the pulsation of the artery. Superficial peroneal nerve can also be blocked with the PNS at the junction of the proximal 2/3 and lower 1/3 joining the line between tibial condyle and the lateral malleolus. With landmark guided also, it can be done with subcutaneous infiltration from the lateral malleolus to the anterior surface or vice versa. Saphenous nerve is usually a superficial sensory nerve, can be blocked from the anterior surface to the medial malleolus or vice versa. It is just 5 ml of local infiltration. Sural nerve again can be blocked just lateral to the lateral malleolus and between the tendo-Achilles and lateral malleolus. I will see the procedure. Position of the patient has to be in supine position, leg extended and kept on the a pillow or a bolster. In neutral position favors, you can block from both the side, medial and the lateral side. This landmark guided tibial nerve, just beneath the pulsation of the posterior tibial artery, slightly deep to the subcutaneous plane, can inject 5 ml of local anesthetic. A diluted local anesthetic will suffice the job. Now, deep peroneal nerve, again, 3 to 4 centimeter proximal, in between the 2 tendons, can be blocked. It also requires a 5 ml of local anesthetic solution. not more than that. Superficial peroneal nerve, just subcutaneous infiltration of local anesthetic from the lateral malleolus to the anterior, or you can do a vice versa. Sural nerve, again, subcutaneous infiltration or slightly deep from the tendon Achilles towards the lateral malleolus. Saphenous nerves can be blocked coming from the anterior surface to the middle malleolus, subcutaneous infiltration of 5 ml of local anesthetic. Now, one more example of this landmark guided technique. So this is the posterior tibial artery, just in between the middle malleolus and the tendon Achilles. Coming to the deep peroneal nerve, just over the ankle joint, slightly medial and lateral fan shape in the fan shape manner, subcutaneous infiltration will be just sufficient. Now, it is the saphenous. Again, one of the alternative technique is you just block the deep peroneal nerve, and from that point goes medially in the subcutaneous vein to block the saphenous vein, and then from there, that point goes laterally to block the superficial peroneal nerve. Now, PNS guided. Out of these 5 nerves, 3 nerves can be blocked by using a peripheral nerve stimulation. Tibial nerve, you calculate 3 to 4 centimeter proximal, take the pulsations of the posterior tibial artery, just go beneath that perpendicular, crossing the subcutaneous vein, you will get the motor response. What will be it? It's a flexion, plantar flexion of greater toe and rest of the foot. This is the motor response. Many often these patients are heavily diabetic, old diabetics, so they require a high voltage of high current. See, you can see the plantar flexion of foot. Deep peroneal nerve, again 3 to 4 centimeters proximal to the ankle joint, in between the 2 tendons. Just palpate and go perpendicular. It has to be a dorsiflexion of the toes. Can you witness the motor response there? Superficial peroneal nerve. Yeah, taking from the 2/3, 1/3, cephalic 2/3, caudal 1/3 at junction. Putting a stimulating needle, 5 centimeter stimulating needle, perpendicular, and you will get the eversion of toes and foot. Clinical pulse is that this block requires a lot of pinpricks, so slight sedation, analgesia is must. Posterior tibial nerve supplies the intrinsic muscles of the foot, so blocking the posterior tibial nerve is also a must. No adrenaline should be used. It causes vasoconstriction and gangrene. And repeated respiration, as we have saphenous nerve is just close to the saphenous vein, and the posterior tibial is so close to the posterior tibial artery, tibial nerve. That should be taken care of. Thank you so much for the patient listening.
Thank you, Dr. Javed. Moving on to the next topic, we have Dr. Nita D'Souza, and she'll be speaking, is ultrasound easier for the ankle block?
Good evening, everyone. I'm sure all of us have done ankle block at some point of time. And being a resident and during the previous years when we do a successful ankle block, we feel good about it. And then the surgeon tells us, "Arey, usko already paresthesia hai, kuch sensation hai nahi." So that's quite disappointing. But now listening to Javed sir's talk, wherein it seemed quite tedious using a PNS with including landmarks with distorted anatomy. So let's see if ultrasound guided blocks are actually easier or not. I won't go through the anatomy in detail, but the beauty of using ultrasound for the ankle is that 4 of the nerves are accompanied with either an artery or a vein. And only one of them needs to be scanned a little bit, which does not require much of a learning curve. So the posterior tibial artery travels, the posterior tibial nerve or the tibial nerve travels with the posterior tibial artery. The great saphenous vein, the saphenous nerve is very close to that. In case it's not seen, the distension of the vein by proximal pressure does do the trick. Dorsalis pedis artery, the deep peroneal nerve, travels lateral to it proximally and then medial to it further in the foot. The superficial peroneal nerve, which is the one which needs a little bit of scanning, there's no accompanying assistant with it. The sural nerve again with the short saphenous. So I won't go through the indications and contraindications much, but we know that we use it for diabetic foot most often, and they are successful stories. But there can be intense surgeries like ankle arthroscopies, forefoot surgeries or reconstruction, complex crush injuries of the ankle or the foot, which may need definitive surgical anesthesia as well. The anatomical landmarks which the factors influencing the anatomical landmark-guided block are mainly the technique factors. Many people would say that they will rely on certain tendons, and those tendons, we need to make the patient elicit the response or to move those toes, which may not be possible in all patients. Patient demographics, as well as the type and the amount of the local anesthetic which is used. Now, ultrasound-guided blocks, we have accurate identification of the nerves as well as the branching, so there may be less sparing, easy monitoring of the anesthetic flow during the injection, as well as speeding up of the onset time of the block, better success rates due to constant blockade, and less amount of local anesthetic can be used. Shortcomings of the landmark technique, I would say, is there can be a distortion, edema, trauma, mixed effectiveness associated with the techniques I have mentioned, demographic variations, the type and the amount of local anesthetics used. It is difficult, unreliable, despite a success rate of 89 to 100%. And many studies said that many patients required a higher dose of rescue morphine, and the technique was not perceived as a very successful technique. For an ultrasound block, more or less, the preparation, the ultrasound machine is shown as shown in the figure. It's kept on the opposite side. A linear probe is used. A smaller footprint would help, because in very skinny patients, the bony landmarks may not help keeping the linear probe very steady. The drug used could be lignocaine, a combination of lignocaine as well as ropivacaine or bupivacaine for giving a faster onset. And needles such as 25 to 27 gauge hypodermic needles would be sufficient. This can be given under general anesthesia as well as spinal anesthesia. Now, coming to this slide in detail, I'll try and show you the video of each one. Now, why the saphenous nerve is not included over here is that many people said that a local infiltration distally on the medial aspect near the medial malleolus is often sufficient for the saphenous nerve. As I said, each one is accompanied, especially the tibial nerve and the dorsal and the deep peroneal nerve, with 2 arteries, that is the posterior tibial artery as well as the anterior tibial artery, which further continues as the dorsalis pedis. And superficial peroneal nerve, I'll show you the video. Now, coming to the tibial nerve, it's very simple to just scan at the medial malleolus, and you can see over here, there's an artery, and just posterior to it. In fact, the facial planes are also quite predictable in this case. So even in patients with ankle edema, the pulsations of the artery can definitely be elicited. So if you can see over here, so the posterior tibial nerve is often posterior, but of course there are anatomical variations where it may go a little superior to the artery as well, and the proposition as shown in the figure. One can scan proximally as well to trace the nerve. The saphenous, very superficial. This can be distended on the, usually anesthetists who don't have access look for the vein on the medial aspect of the foot. So the nerve is pretty much close here, okay? So it can be scanned, compressibility of, you can see it in the video. So the saphenous also can branch into smaller branches, so an infiltration just next to the vein would be sufficient enough. Coming to the deep peroneal, the ultrasound probe as shown is on the anterior part of the ankle. Look for the tibial surface and the deep peroneal artery pulsating on the tibial surface. The nerve may not be very evident, but you can even deposit drug on the bony surface over here. And in fact, the nerve does float with it often. So you can see the nerve is here, it's crossed to the medial aspect. Now this purposefully I've kept the videos like this because bony landmarks may distort the contact, but still it is possible because of the positioning of the arteries and the veins. Now coming to the peroneal nerve, the superficial peroneal nerve, that's pretty much on the anterolateral aspect of the leg. One needs to look for the fibula. There's a jutting projection over here. And the lateral aspect of the fibula, there is the peroneus group of muscles, the peroneus brevis. Over on the medial aspect, we will see the extensor muscles, the hallucis and the digitorum longus. One needs to see a separation in these two group, anterior and the lateral compartment, and the nerve can be visualized right here. So if you can see in this video, it's not very difficult and you can trace it down. It's better to deposit the drug superficial to this fascia just to avoid compartment syndrome by large volumes of local anesthetic being injected. And coming to the sural nerve, again next to the short saphenous vein, you can see it in this video, you can see the compressibility as well, and deposit it in close proximation. Now there is a lot of literature to say that the ankle block is very effective, but just to highlight, this is a review article of 2022. USG-guided tibial and deep peroneal nerve blockade improved the success rate of the ankle block in comparison to landmark studies. Ultrasound also improved the success rate of the sural nerve block. So individual nerves, the success rate with an ultrasound definitely is better than with the landmark technique. This is another article by K. Chin. They did a 6-year retrospective review study, and they too mentioned that the ultrasound improved the clinical efficacy of the block as compared to the landmark technique, even in the hands of less experienced practitioners. So this is important. One should not think you need so much of experience. I think 10 scans would definitely give you more clarity. Now, the same study in continuity said that the logistic regression analysis showed only 2 variables to be predictable about the success of the block. One was the technique, which is USG guided, and the other one was the total volume of the local anesthetic administered. So as you can see, what they studied and noticed was the amount, the gray bars, the amount of ankle blocks progressively has increased since 2004. This is one study which I'll come back. They said that ultrasound did not improve deep peroneal ankle block. But if you see, the conclusion said the use does seem to improve the onset, but not the quality. But there are a lot of limitations of this study, which if there's time, I will come back. Ultrasound-guided ankle block for the foot. Again, the sensory distribution of the saphenous nerve was noted to be, one could use a mild infiltration and one could not use ultrasound only for the saphenous and just give a medial infiltration subcutaneously. But otherwise, an ultrasound was definitely much better. Similarly, so there are multiple studies to say individual nerve blocks definitely help. Now, why I choose ultrasound? They're very specific nerves which I can block. It's targeted. Proximal blocks are possible. I can look for anatomical variations. I can look for the branching of the nerves. In cases of vasculopathies, I can still rely on bony landmarks. So a lot of advantages of ultrasound-guided nerves as nerve blocks can be mentioned, along with the faster onset time as well, including a shorter hospital stay. So these are few tips saying that tibial nerve definitely should be blocked because it's a major supply of the foot. Try to catch it as proximal. Out-of-plane approach is perfectly all right. There's no need to give one local and another injection. So use 25-gauge hypodermic needles or 26-gauge hypodermic needles, which can be visualized very well under ultrasound. and they will give you good success. And infiltrations can be used for the subcutaneous, for the cutaneous nerves like the saphenous, the superficial peroneal, as well as the sural. So I rest my case in saying it's definitely easier, it's 100% success rate with minimal complications. So we must go ahead with more of ultrasound-guided blocks rather than relying on landmark-guided technique. Thank you.
Thank you, Dr. Neeta. The session comes to an end and the house is open for discussion.
I have a few questions. Ganesh, how many times it's difficult to identify the there are some times when it's very difficult to identify the sciatic nerve with ultrasound also, especially in very old patients or very obese patients. So any tricks to identify these nerves?
Yes, actually it is quite difficult in anterior approach because it is very difficult to differentiate from the fibrous muscle. So what I mentioned in my video, you first scan the nerve in transverse scan, then slide the probe medially and try to see the nerve in the longitudinal axis. This we practice commonly. And nerve can be visualized more distally, very well visualized distally than proximal level.
It was earlier said that if you decrease the contrast, only the nerve remains bright and rest everything in the sciatic nerve.
Yes, this is true in younger patients, but in older patients, the whole thing you can see is a hyperechoic.
Have you tried anterior approach under CM or IR? Is it easier to do it under that or ultrasound?
No,
Javed.
So many times. So many times. It is much easier than maybe ultrasound. I tried so many times and 100% success. Just you have to look at the lesser trochanter and just proximally from the lesser trochanter or just medial, you can get the sciatic nerve from the anterior approach.
Thank you for the ankle blocks. Might I increase the number? Make 6 out of it. Yeah, there's another one, which is the posterofemoral cutaneous. I know it's described in literature. This one regularly should stop somewhere around proximal third of the leg. It's running more distally. You will see more tomorrow. You will see the details. So just think about him, and he's also easily identifiable. Might be also reaching the thigh, the ankle region, and also the plantar. So that's why you have to think about him.
I'll continue. Satish, which will be your best approach? Because you showed all the 3 approaches. I found posterior approach to be easier than the lateral approach many times. What is your take on this?
Yeah, I agree. Posterior is always better because your direction is not from the side of one component. So it is easier to go in between the 2 components. That is the target region I would like to have. When you go from lateral side, naturally the first response you get is obviously eversion or dorsiflexion. And then it is said that you advance the needle further. So there is always fear in my mind whether it will go through the nerve or what. But being that the needle being the blunt, generally it doesn't pierce the nerve and it goes by the side, and it's easy to say in words that you advance and you will get the tibial response. So ideal would be, of course, posterior approach. But I have been using lateral approach for many diabetic foot and all those things where they are obese, they are old, and it's very difficult to make them prone. So most of my lateral approaches are for diabetic foot conditions.
Sandeep, my most favorable, the lateral approach.
Okay.
If you're operating at the ankle or the foot or greater toe, then why to go proximal? Below ankle, you can easily be done with the lateral approach. And it's very easy to turn. No need to turn the patient the lateral side or prone. And that is the most significant advantage.
Yeah, that's the positive point, that if the leg is fractured or something, you don't have to change the position.
Yeah, go for the femoral, and the same position, go for the lateral. It will be easily blocked. And regarding the, naturally, going from the lateral side, we'll give the peroneal component first. It doesn't matter. You deposit in a sheath. If you are intending to sheath, deposit certain amount of drug. It will take care by both the components, tibial and peroneal, right?
Hital, sorry. Anybody else? No. Said that the needle is near the nerve and there is no motor response. Yeah, are there any studies where they have placed the needle under and then stimulated and there was no response?
Yes, sir. That's what I was saying.
There are studies about this.
Yeah, I told same thing is sometimes what happens, you are intraneural, you pierce the paraneural sheath, you are close to the nerves and there is no response. It happens because of hyperpolarization of nerve.
What is the instance of this? I don't know if I encountered this any time, but what is the instance of this that the needle is there?
That's what they studied. Out of 24 patients, it happened in 4 patients. So it is quite high.
That's a big number.
Yeah, and I observed it.
Any of the other speakers have observed this? I have not seen this thing actually.
So I'm always using the dual technique with ultrasound, and so most of the time I used to get it. There's no problem for that.
Yeah, whatever Hetali said is new to me, not getting any response or something, but since he has read and he explained also, it has to be accepted.
Javed, you said no adrenaline for ankle block, but ankle block means the nerves are not the end organ nerves. So in my opinion, means most of the time we are using adrenaline in that one. So are there anything about adrenaline and ankle block?
It has been documented everywhere, so I'm not using it definitely.
Okay, it's only for the if you do a digital block or a penile block.
Yeah.
Yeah, you don't have to use
any places, Sandeep. Some places it is mentioned that you be using epinephrine. So I'm not using that simply.
Maybe the reason is most of the times patients are atherosclerotic and all those things. That may be the reason.
Usually adrenaline is added for increasing the volume. Usually for an ankle block, 25 ml to 30 ml is good enough, 5 to 6 ml per nerve. And so there's no harm in using, especially if it's ultrasound guided, you're watching where the drug is going, creating pockets. So definitely it can be used, but here volume is not a concern. And most of the nerves, even with plain ropivacaine or bupivacaine, the onset is 5 to 6 minutes. If that can be waited, the block is okay with plain without xylo-EDR as well.
I think, sir, PNS guided block, dual guidance block and no response was discussed in previous session also. With Dr. Sandeep Diwan and TVS sir discussed about lumbar plexus, where they were close to the lumbar plexus but not getting response. So it must be happening in many patients.
I think we'll end the session here. Time is up.
Thank you.
Thank you very much, all the speakers. We invite the moderators of the next session, Dr. Saurabh and Dr. Sunil Pandya, chair the sessions. Thank you very much.
Good evening, all. May I have the first speaker, Dr. Sachin George?
Very warm good afternoon to all. I'm happy to see a crowded, packed hall at the fag end of this session. And it is not a topic which you have been listening from morning. It is not about how to give block, it is how to give it safely. I'll be talking for the next 10 minutes about patient safety in regional anesthesia. This is something which we all know. We practice it diligently when we are giving a general anesthesia or a central neuraxial blockade. But when it comes to a regional block, we seem to be in a lot of hurry. We sometimes give the block and then forget it. there begins our problem. So I will give you 10 points, sort of 10 commandments that has to be borne in mind and that has to be diligently followed. So here starts my 10 commandments. The commandment number 1, consent. So as you know, informed consent is a cornerstone of medical practice, so clear documentation. Now, what we see most of the time is when you're giving a block, sometimes I've seen there is total lack of proper consent. AORA regional anesthesia consent form is available in the net. You can either download it and use it, or you can modify it the way you want to practice it in your local center. Prevention of wrong side block. I'm sure all of you must be following WHO safety checklist. Now, WHO safety checklist itself is not enough to prevent a wrong-sided block. So always there should be a stop before you block. Stop before you block is nothing but before you give a block, you stop and visualize the site marking. The side of the block has to be marked with an indelible ink in the shape of an arrow, most preferably. And the provider, care provider, should be visualizing this block before you give a block. And the consent has to be read. It has to be checked again with, if the patient is conscious, you ask the patient what side is your problem, which side is your fracture, and confirm it again. This is stop before you block. WHO surgical safety checklist, along with a stop before you block, is the most effective technique in preventing a wrong side block. Third commandment is infection prevention. Aseptic precaution in local or regional anesthesia is absolutely important. You cannot just go in and poke your needle without taking absolute aseptic precaution. Hand washing, skin preparation. There is chlorhexidine 0.5% and 0.2% available in the market. Studies have shown that there is no definitive advantage of 0.2% chlorhexidine in alcohol. 0.2% will be adding to more neurotoxicity when compared to 0.5% solution. And use an appropriate barrier to the transducer. You are not worried about contaminating your transducer. You are worried about transmitting deadly diseases from one patient to the other. Monitoring. You are all aware of ASA standard monitoring, 2 sets of monitoring standards. The standard one, an anesthetist or a trained person should be there, continuously physically present, monitoring the patient. You cannot just give a block and run away somewhere. And all these patients, saturation, ventilation, circulation, and should be monitored. So even if it is a local anesthesia procedure or a peripheral nerve block or a central neuraxial block, ASA standard monitoring should be there. And after the block, all these patients should be monitored for at least 45 minutes after the procedure. Now, patients with antithrombotic or thrombolytic therapy, there is a never-ending controversy. Always weigh the risk and benefits of providing regional anesthesia in a patient with antithrombotic or thrombolytic therapy. Various societies have placed guidelines, and these guidelines will be confusing, but then use your diligence. The best way forward is a multidisciplinary approach. What we do in our institution, if there is a confusion, we have a multidisciplinary team meeting, and the team meeting, it will be decided what is the best way forward. And be vigilant always. If you are giving a block in a patient who is receiving antithrombotic or thrombolytic therapy, where any other form of anesthesia would have been riskier, you are justified, provided you are vigilant in monitoring the patient post-procedure, looking for signs and symptoms of deterioration. Asleep versus awake. Again, this is one thing where there are no consensus. Most of our patients would want to sleep during the procedure. Doctor, can I sleep is what the pertinent question that will be asked to you. Now, there are for and against asleep versus awake blocks. Most of the literature supports patient to be awake during a block is given. But then pediatric anesthesiologists will not agree with that because 99% of pediatric blocks are given with the patient under sedation, and they don't encounter any increase in nerve injury because their patients are asleep. Now, last, there can be subtle sign of last. Last need not always present the way that is given in textbook. Any abnormality, last should be the first thought that comes to your mind. And intralipid should be there available in your facility. And I would suggest something, have a lipid rescue kit prepared with intralipid, a set of cannulas, IV sets, and any guidelines, any society guidelines treating last, that should be printed and kept in the lipid rescue set, because not everyone may not be aware of the correct dose of intralipid or correct mode or protocol that has to be followed. So a set like all the hospital, most of the hospital will have a code blue trolley or an arrest trolley that is kept ready in the theater. So I would suggest to keep a lipid rescue kit that has to be kept ready if your facility is doing regional anesthesia blocks. Worried about neurological injury? Always be aware that neurological injury can be due to surgery or other patient factors. We had a patient who had dense lower limb motor blockade, but ultimately that was because of the retraction. The poor anesthetist was blamed for the epidural for a prolonged motor blockade. There can be direct trauma, effects of tunicate. If you have an obese patient, there can be problems with positioning. All these has to be taken into account. But then from our side, make sure the injection pressures are not high. Always use a tangential approach when you are using the block needle. And whenever possible, combine it with a nerve stimulation technique. A dual technique is always safer. And make sure you use a short bevel needle when you are giving the block rather than do a cost cutting and use your spinal needle to poke into the nerve. Worried about compartment syndrome. We have surgeons who won't let us give blocks for an upper limb or lower limb surgeries, thinking that these patients will not complain of pain even if there is a compartment syndrome. So ultimately, there were instances where the patient has lost the limbs. But then that may be partly true, but then it is not always true, because the ischemic pain due to compartment syndrome is totally a different mechanism. And there are enough and more studies to show that it may not always be masked with our block. But then there again has to be a consensus, discuss with your surgeon and proceed cautiously, because these are factors that can lead ugly litigation if it happens. You are justified when this is the best possible way of anesthetizing the patient. Or focus on POCUS, because a lot of complications can be prevented if you focus on POCUS, like movement of diaphragm post-procedure. Most of these lung ultrasound is sensitive than chest X-ray. Hematomas can be picked up very early. And in summary, the 10 points, again, I'm stating as a summary. Remember consent, there is no shortcuts. There should be a proper sign-in with the WHO safety checklist and a stop before you block. Maintain sterility, proper monitoring according to ASA standards. Be aware of the thrombolytics and antithrombotics. Have a consensus. Decide on asleep or awake. Be aware of last. Be aware of neurological injury. Compartment syndrome, again, there should be consensus, and focus always on POCUS. And develop safety as a culture and document everything, whatever you have done. Thank you.
Thank you. Our next speaker is Dr. Sunil Pandya, the moderator of this session. He will be talking about how audits improve outcomes.
Good evening, all. Greetings from Hyderabad. At the outset, I would like to thank AORA team of Pune for giving me this privilege. So next 10 minutes, I shall be talking about how audit in our practice improves anesthesia outcome in the peri-operative period. Nil conflict of interest. The data I'm sharing is from my institute, and I have obtained permission. So if you look at the examples of clinical audit, why it is important? Because we know that clinical audit improves the clinical governance, and importantly, it is a continuous quality improvement program that we have established in our hospital since 1997. And the objective is to continuously improve your practice so that you can go up the rung and you can have the safest or safety culture in your hospital. It also helps us to demonstrate competency of the team as well as the individual in the team. It helps us in identifying the deficiencies in our staff and the training aspects and the skill aspects. It also helps us to suggest the areas of development where we need to focus, and also helps in capturing the near misses and critical incidents, which are very, very important in our practice. And overall, it improves the patient safety and outcome. A typical clinical audit cycle is nothing but data collection. It's very important. And once you collect the data, identify the deficiencies that you have in your practice, and then you put some recommendations or the standards from your literature which you have studied or from the global accepted standards, and re-audit. Once you set the standards, re-audit again, and basically reset the standards. And it's a continuous cycle so that you practice, identify the deficiencies, and then set up the standards, review the data again, and set up the standards further up so that you continue improvement into your practice. It is always better to have your own data audited periodically so that you know where you stand internationally and nationally, or even at the locally in your city, town, or your hospital. And it is always better that once you have your own audit, it is very easy for you to counsel the patient. Importantly, the complications are accepted by the patient very easily because this is what the data says, this is what our data is, this is what the international data is, and acceptance is quite easily. And I firmly believe that research and clinical audit and regular introspection, it helps us in enhancing the standards, and probably it also paves way of us training the trainers, and so that we can show the pathway to others. As a team, we initiated clinical audit in our practice right from the time we formed the team way back in 1997. And the first audit we did was in a retrospective audit from 1997 to 2001, where we analyzed almost about 5,000 labor epidurals that we administered in the pre-fentanyl era. Fentanyl was not available. And because one of the things that we had received complaint from our neonatology team that labor epidurals, since the time we have started labor epidurals, most of the neonates are requiring phototherapy, and there is a higher incidence of neonatal hyperbilirubinemia. Similarly, few of the mothers developed pyrexia, and they said your epidural is causing intrapartum fever. And they also said that the cesarean section rate is increased. Because this was the data that was there in the literature, and they started questioning us. And we did this audit and presented at FIGO in the US way back. And this is what the data is. And everything was, the critics were silenced, and that is what is important. And subsequently, since the time we had basically most of the practices that we do as a team is obstetric practice in Fernandez Hospital. And we introduced a continuous epidural infusion regime in our hospital. PCA pumps were still not available in 2000. And when we started using epidural infusion devices, we found that instrumental delivery rate was almost 40% in the infusion regime, vis-a-vis the spontaneous delivery rate was less. So we started infusion and we abandoned continuous epidural infusion in our practice. So that's how your introspection data has helped. And in 2003, again, we did a prospective audit of cesarean section rate with epidural, non-epidural. Since the time the fentanyl was available, and we started using low-dose mixture. And the cesarean section rate was same in both the group. And again, we could silence our critics so that they don't argue, they don't ask us questions. And 2 years after our study, this landmark article that got published in New England Journal of Medicine, where epidural per se does not increase cesarean section rate. We are lagging behind the publication, but this was what we had already inferred. So basically, the dynamic audit tool, we are doing hodgepodge audit, but in 2008 onwards, we strategized and standardized the way we audit, and we introduced a dashboard concept of clinical audit in our practice. And we captured 57 perioperative parameters, the clinical parameters, the administrative parameters as the department head, and also we look into the academics. And if you look at, we published our dashboard in IJA, and if you just Google search obstetric audit, it's one of those most researched articles in the Google. Well, this is one of the commonest things that we have in obstetric practice is the bloody taps. The incidence of bloody tap is almost about 5 to 7% in obstetric practice vis-a-vis orthopedic urologic practice. When you're giving epidural, you do hardly use any blood taps, but in obstetric it is very high because we know very well the reasons. And our audit and our inference led or paved the way of innovations in our practice. And one of the innovations that we introduced in our practice was continuous saline flush technique when you're threading the catheter into the epidural space, thus minimizing the blood tap to almost less than 0.1%. And we published this, and it was always also published in the textbook also. And ongoing audit every year we do. And if you see the incidence of, we compare our data with RCOA, Royal College of Anaesthetists, AAGBI standards, and if you see the incidence of bloody traps is 0.67% with injection of saline in the epidural space and CSF technique, especially in parturients who require thromboprophylaxis or who are on therapeutic anticoagulation. It is very important on us, our part, to minimize bloody taps. Another parameter that we, which is close to me, is the accidental dural puncture rate. And if you see our rate or data of ADPs in our practice is 0.31% vis-a-vis the accepted level of ADPs as per RCOA standard is less than 1%. And PDPH, we have standardized the moment you have ADP, we thread the catheter intrathecally. And if you look at the literature, the intrathecal placement of catheter may not reduce incidence of PDPH, may not reduce incidence of VP. But our data in our hospital, the incidence of blood patch is statistically significant, reduced. And so hence we thread the catheter intrathecally, and that's what our data is. Inadequate blockade following labor epidurals, again, this is the data with RCOA. So basically what I mean to say is everything that we have introduced as a part of audit, when we encounter a problem, we set a protocol, we introduce a protocol, we introduce algorithm, and that's what it helps us to improve our practice continuously. Similarly, conversion of LA to LSCS, the failure rate was initially high, then we introduced the algorithm and to minimize the failure rate. And similarly, if you look at the data this is the data in 2021, and we have compared the incidence of resetting conversion rate and accidental dural puncture. It's at par with or better than RCOA. This is the data of RCOA, Royal College of Anaesthetists, and where the Fernandez Hospital data is. So basically, what I want to emphasize is regular audit of all the parameters helps in enhancing your practice. And this is one of the good book. If you want to set up your practice today, you can refer this manual, compendium, where they have analyzed every specialty of anesthesia, neuro anesthesia, cardiac anesthesia, obstetric anesthesia, pediatric anesthesia, the standards that you need to maintain and the acceptable parameters that you can have in your practice. So clinical audit, how to make it easy. Create your own dashboard. Select few problem areas. It could be clinical admin related, academic related. Review your current standards and aim to raise the standard of care and collect the data, re-audit, and keep repeating the cycle. And subsequently, once we are successful in anesthesia, we ventured out and entered into the surgical ICU. And we introduced dashboard in SICU practice also, where we handle as a team both surgical ICU as well as obstetric ICU as well as OT anesthesia. And we analyze different, capture the data, the statistics, and the parameters. And we also look into the academics and admin part, like the amount of academic sessions that were cancelled or extension of personnel beyond regular duty hours, CPD points, and M&M discussion. And we put them under red category or amber category and green category. Green is acceptable, red is alerts, and that is what the global standard is, and orange is the best institute standards. And we want to stay or go green, and that's what we have established in our practice. So without wasting any time, I would say that each one of you should have your own audit system. Start today. It definitely helps you in improving your clinical practice. And currently, we are developing an app. It's almost costing me about 12 lakhs. So far, we have invested 3 lakhs from our pocket, but we'll be soon finding a donor, and we'll be getting an app of dashboard so that it can be helpful to our fraternity. Thank you very much. I invite you to this AOA 2023, and the next year, meet you at Hyderabad. Thank you so much.
Thank you, sir. We'll have the question answers later on. Our next speaker is Dr. Jitendra. He'll be talking on should anesthesiologists need to know POCUS. What do you, Jitendra?
Good evening, everyone. Towards the fag end of, just like what Sachin has told, towards the fag end of the
session. My topic would be, should anesthesiologists need to know POCUS? So we were not using ultrasound for a long time, but of late for the last few years, we've been regularly using ultrasound, and we have moved in from just being the anesthesiologists to perioperative physicians, where these type of modalities have come into diagnosis and management of our patients in the perioperative period. So the applications of ultrasound for anesthesiology are diverse and expanding rapidly, and numerous point-of-care ultrasound protocols now exist to guide the examination of nearly every organ system and area, including the cardiac, pulmonary, pleural, abdominal, genitourinary, ocular, and airway. And we as anesthesiologists are experts in the perioperative arena and are usually called upon routinely to evaluate and risk stratify patients based on, at times, incomplete historic information. Most of our surgeons just look into focused area where they're just going to look at surgery, and it's our responsibility to optimize the patient, risk stratify the patient, and go ahead and manage the patient. We rapidly develop and refine differential diagnosis and integrate evolving clinical data to resuscitate critically ill or unstable patients. There's a growing body of literature which suggests that POCUS can add value in all these contexts. Now, can POCUS actually impact the patient care delivered by anesthesiologists? Yes, it does. In the preoperative evaluation, as I said earlier, the anesthetist can aid in evaluating and risk stratifying patients preoperatively. And the focused cardiac ultrasound is particularly valuable in this setting because most of these patients sometimes come with hemodynamic instability, and you can't wait for the cardiologist to come and do an echo and evaluate the patient and risk stratify the patient. So most of the cases, since it's an emergency, you have to go ahead and do the focused cardiac ultrasound. It allows the practitioner to answer crucial goal-directed questions based on qualitative assessments gleaned from an accessible number of echocardiographic views. The anesthesiologist can also diagnose or rule out hypovolemia, gross ventricular dysfunction, significant valvular pathology, hemodynamically significant pericardial effusion in the course of preoperative evaluation. There was a patient who came from the ED with a hemorrhagic infarct, malignant hemorrhagic infarct, who had to undergo for an emergency craniotomy, decompressive craniectomy. Here, patient came with multiple inotropes, and when taken into a theater, she was on 2 or 3 inotropes, and the pressures were low. Had to go for an immediate, while the surgeon was preparing for surgery, we had gone for an emergency echo on the bedside, and it was found that patient had mild to moderate LV dysfunction, and we had to manage the patient accordingly. There is a single-centered retrospective study which reported that findings obtained in anesthesiologist administered preoperative focused cardiac ultrasound examination were sufficient to answer the clinical question that prompted consultations in vast majority of instances and changed planned patient management in most of the cases. There was another retrospective study which they did in 64 patients who had undergone hip surgery, who had an increased risk of cardiac problems. And what they found is anesthesiology-acquired focused cardiac examination changed patient cardiac diagnosis in 78% of the times and altered patient management in 52% of time, importantly without resulting delay of surgery. And what they found is like 12-month mortality was significantly lower than the control group, that is 17.1% was 33%, suggesting that management adjustments based on preoperative bedside echocardiography could improve outcomes, either directly or indirectly. Now, beyond imaging of the heart, there are actually multiple very valuable applications of lung ultrasound in the preoperative arena. For patients found to have an abnormal chest examination or hypoxemia, lung ultrasound can offer immediate information, potentially allowing the practitioner to distinguish between reactive and consolidative mechanisms. And there's evidence that lung ultrasound is more sensitive than the preoperative chest X-ray for detection of various lung pathologies, including pleural effusion, lung consolidation, pneumothorax, or increased extravascular lung water. What you see here is a lung sliding sign. This is a normal ultrasound of the lung. And you may have patients who are hemodynamically unstable to be shipped for CT thorax or whatever it is. And so a bedside ultrasound can actually help in diagnosis. And this is another patient who had an absence of lung sliding sign, which is the patient has got a pneumothorax. This was immediate post-operative period where the patient had an internal jugular vein cannulation without an ultrasound in the OT. These are another 2 group of patients who had undergone emergency ultrasound in the intensive care unit who had come with hemodynamic instability. One of them on the left side was just a pleural effusion who had come with medical issues. On the right side, it was a polytrauma patient who had come with hemodynamic instability, hypoxemia, and what we found on the bedside ultrasound was hemothorax, for which he underwent immediate ICD placement. These are pictures of consolidation of the lung, which can, again, you may have patients coming with hypoxemia, collapse, or collapse of the lung, collapse consolidation, which can be again diagnosed with an ultrasound. This is with a high frequency linear transducer.
What you find there is a consolidation, lung consolidation with air bronchogram with the hyperechoic specs. What you see is air bronchograms. Again, you can find A lines or B lines in the lung ultrasound. A lines is normal, whereas the B lines suggests that the patient was in pulmonary edema. More than three to five B lines is supposed to be pathological. Now again, use of gastric ultrasound in the perioperative period, again, it has also demonstrated utility for reliable assessment of gastric contents, potentially adding valuable information to anesthesiologists in the preoperative assessment of patients' aspiration risk. So here what you find is with a curvilinear probe, you find the left lobe of liver, there's a rectus muscle, there's a pyloric gastric antrum, the superior mesenteric artery and the aorta. The same picture over here. The gastric, why do you see the gastric antrum? It's basically because it's typically superficial and amenable to ultrasound imaging, allowing not only the detection of stomach contents, but also the characterization of type of contents, solids, liquids, or air, and an estimate of total gastric volume. The same thing, using a curvilinear probe in the patient, the right lateral position, the probe is kept in the parasagittal view at the midline, just to the right side, where you see the pyloric antrum over there with the food residue. And any food residue in the pyloric antrum is considered as full stomach, where the risk of aspiration is very high. This is just to calculate this circumferential area, this area, along with the age. You have a table which correlates the gastric volume, which can be identified, and the patient can be categorized as risk of aspiration. Though the findings on gastric focus should never be used as justification to override appropriate NPO guidelines, they may actually allow risk stratification among patients suspected of impaired gastric motility or in whom a reliable NPO history cannot be obtained. Now, role of focus in airway. Again, the role of ultrasound practice of anesthesia is continuously expanding, and applications of ultrasonic assessment of airway to assist in evaluation and recognition of patients at risk for difficult intubations are emerging as an attractive tool. And focus of head and neck, especially assessing tissue thickness over the hyoid bone and other airway structures, may offer increased sensitivity over airway examination alone for identification of difficult airway. These are some of clinical applications of focused upper airway ultrasound, where you can actually use it for airway size and prediction of endotracheal tube size, prediction of difficult laryngoscopy, airway device placement and depth, procedures like percutaneous cricothyroidotomy or percutaneous dilatation tracheostomy, identifying pathological airway structures like epiglottitis, vocal cord assessment, and predicting post-extubation stridor. Now, in the intraoperative management, the use of focus is, like what I've told you earlier, patients with hemodynamic instability, focus brings tremendous value to practice as a tool for bedside evaluation, and the focus provides an alternative to TE, transesophageal echo, the transesophageal echo, as a means of rapidly assessing for cardiac contributors to hemodynamic instability that confers many of the diagnostic benefits of TE with a less invasive modality. TE is not possible in patients with head and neck procedures, and then this is a non-invasive technique. Value of focus in cardiac arrest and resuscitation. Again, literature has demonstrated that expediting time to diagnosis is crucial in decreasing morbidity and mortality in situations with critically ill patients. The focus has shown utility in the setting of out-of-hour shock or cardiac arrest, and the American Society of Echocardiography recommends that initial evaluation of patients with hemodynamic instability should include focus. Now, what is the role of focus in the post-anesthesia care? Again, abdominal ultrasonography can provide critical information in the recovery room as well. A focused assessment with sonography in trauma examination, which identifies the presence of intra-abdominal fluid collections, may alert the surgical team of bleeding complications and prompt return to operating room. Ultrasound imaging of the bladder can also be assessed for urinary retention and assist in differential diagnosis of abdominal pain in PACU. Now, this was a patient who had come to the intensive care unit after polytrauma. Initially, the patient was stable. Later on, patient started developing hypotension. We did an emergency ultrasound which showed a subhepatic collection. There was hemoperitoneum. He was further assessed and later was taken in for emergency laparotomy. Again, the use of ultrasound is for detecting the optic nerve sheath diameter, which is again in non-invasive technique to identify the raised intracranial pressure, where the high-frequency linear probe is kept over the eyeball with the eyelids closed, and you look what you see at the posterior side of the eye globe. The globe is the optic nerve. You measure 3 millimeter behind the posterior part of the globe, and then take the measurement over there. Something above 5.8 millimeter, the optic nerve sheath diameter is suggested to be having the patient having an raised intracranial pressure. Now, to conclude, The focus has demonstrated value in multiple clinical settings in all phases of perioperative care, including preoperative assessment, intraoperative management of hypotension, and postoperative evaluation of complications in PACU. Anesthesiologists can now use bedside ultrasound to acquire rapid, high-quality diagnostic information about multiple organ systems and target discrete clinical questions. Incorporation of focus into daily practice is now more feasible than ever before, and expert consensus has come down in favor of its routine use. As national competency standards now call for graduating anesthesiologists to achieve mastery of various aspects of surface ultrasound, knowledge of focus will become expected of all practicing anesthesiologists. And to conclude, as champions for safe, efficient, and cost-effective patient care, all anesthesiologists must rise to the occasion and add this valuable skill to the clinical repertoire. Thank you.
We have 3 more sessions before question and answers. I request the next session's chairperson, moderators, Dr. Vandana Mangal and Dr. Kane to come on the podium, please.
Good evening, everyone. So to start the next session on how do I manage these scenarios, first I would like to invite Dr. Azam Danish on inadvertent intravascular injections. Dr. Danish.
Thank you. Good evening, everyone, respected chairs. Let us see how interesting we can make this session. So I think Dr. Sachin was mentioning about the last. So we'll just go a little bit deeper in last and see what best we can do. Now, why are we discussing this topic? Simple that 1.8 per 1,000 nerve blocks, that is the data in 2021, and 1 to 2 cases per 1,000 nerve blocks is what is the incidence that has been told. And what is the mortality? 2 patients die of anoxic brain injury. This is the problem with nerve blocks. And 1 patient died of cardiac arrest 2 hours after liposuction when lignocaine was used for the Timson's anesthesia. So with this, I thank the organizing committee for giving me an opportunity to share knowledge. As I say, sharing, it should be mutual. We learn from you and you learn from us. With this, let me get started. I have been given 10 minutes, so now it is 9 minutes and 22 seconds. Right, so let us see the epidemiology. Now, if you see this chart here, table, the most common age group that can have this is about 5 to 65 years, about 64%. Right? And in hospital cases, obviously, because local anesthetics are given in hospital patients, and it is also obvious that 68% will happen in the operating room. But very surprisingly, outside operating room is about 32%. So same way, surgeons also do give local anesthesia, but anesthesia is like, we are 50% responsible for this. And surprisingly, lignocaine, because we know that lignocaine toxicity can be treated, and about 44% is lignocaine, and lignocaine with other drugs is about 22%. And which surgery do causes? Again, 17%. We think that when we are anesthetizing the upper airway, we don't have LAS, but unfortunately, this is what the data says, which is about 17%, and 19% is for your upper limb blocks. So, do you see sign and symptoms? Yes, within 10 minutes, about 53%, and which is the most common system involved? It is, CVS and CNS systems are about 35%, isolated CNS is about 32%. 64 times the lipid emulsion was used. So I'll just quickly run through this because these are all the symptoms. What I say is the time of onset is variable, like it could be immediate or delayed, but as anesthesiologist, we should not wait till the patient collapses, because we are here if we can preempt a cardiac arrest and try and, if we can use our judgmental skills to find out the last is happening or on the process, we need to act much before and try and save this, because there's no point in doing CPR after the cardiac arrest, right? So these are the few symptoms which we'll all know about this. And the other symptoms that is really worried about is the arrhythmias, hypotension, conduction abnormalities, and if you don't treat, they go in for asystole. Again, CNS symptoms are definitely there. Suddenly, patient will stop interacting with you. That is a time it should ring a bell that this patient is getting into trouble, and you act at that point of time before they get into respiratory acidosis and coma. And as I say, the saying goes that prevention is better than the cure for the last. So use of incremental injections with intermittent aspiration is mandatory. Use of test dose, there is no doubt about that. And injecting the total local anesthetic dose over a long period of time reduces the peak serum concentration and reduces the risk of last. And basically use the doses according to the body weight and don't exceed the total maximum doses. So how do we manage? There are different ways of managing. One is stop injecting the local anesthetic if at all. This is basically seen when you're doing the interscalene block. When you're doing an interscalene block, the vertebral artery is very close and not necessarily the, even the drug touches the vertebral artery. It is so highly, rich blood supply that it can get absorbed and get into the brain concentration. The patient can throw a seizure instantaneously. So stop injecting, call for help. Definitely oxygenate and ventilate the patient. If there is no IV, please secure an IV. Never do a case without an IV line. Seizures control. It is much easier in operating theatre. If a patient has a cardiac arrest, kick off circulation, airway and breathing. And definitely intralipid should be available in the operating theatre. In case if the patient is seizuring as drowsy, not arousable, better to start airway, breathing and circulation rather than CAB, right? So this is the management. Now, the other thing that we need to keep in mind is these patients can throw arrhythmias. So you keep an amiodarone. If there is no pulseless VT, we know that the treatment of choice is defib them. If there is pulseless VT who is not responding to defib, yes, you can give amiodarone. Again, you need to keep in mind that it can cause cardiac arrest, hypotension. So avoid beta blockers, avoid calcium channel blockers, start chest compression, limit your adrenaline of less than 1 mic per kg, though it is very important. Right, then adrenaline. The most important drug here in a cardiac arrest is adrenaline. The reasons is because the adrenaline has two effects. One is alpha and one is beta. The alpha effect is what is more important because it causes vasoconstriction. It can cause the forward flow of blood, and definitely the lipid emulsion. Now, lipid emulsion, again, intralipid comes as 20%. Sterile non-pyrogenic fat emulsion, it is made up of 20% soybean oil, 1.2% of egg yolk, and phospholipid about 2.25% glycerin. The pH is ranging anywhere between 6 to 8.9. Now, this is the theory that we were thinking all this while. Historically, you must have read about the lipid sink. What it used to do is it used to take the local anesthetic, get into a lipid sink, creates a lipid sink, and it tries to remove from the targeted tissue. Now there is a theory that is emerging that is called a shuttle. That is the shuttle. What it does is the lipid emulsion carries or a shuttle the local anesthetic from the heart, brain, and tries to send it to the detoxifying organ to get rid of it. So that is what the new theory that it says that it acts by shuttling. Now, mechanism of action of intralipid is again direct inotropic effect, reduction in the ischemic perfusion injury, may also have a direct role in reversing mitochondrial dysfunction, sodium channel blockade, and nitric oxide and mediated vasodilatation. So what does ASRA and Pain Medicine 2017 says is lipid emulsion to be used if you're anticipating, if you have a last. Adults more than 70 kgs, bolus of 100 ml IV over 2 to 3 minutes, followed by infusion of 200 to 250 ml over 15 to 20 minutes. The pediatric dose is about 1.5 to 2 mils per kg. That is what you need to keep in mind. The maximum can be given is 12 ml per kg. There was a question asking, can we use propofol? Definitely the answer is no. There is no role of propofol in LAST, so better not use this. Now, we also have come up with our own guidelines from AORA. It's much easier to follow. Please take a printout of this and put it up on the operating theater, because it's a little difficult to go by step approaches. So this is what it is. And the LAST, if the LAST happens, it's going to create a disaster. So I would always suggest, and a take-home message is, try and anticipate a LAST before a patient gets into cardiac arrest. There is no big deal in doing CPR in a cardiac arrest patient, that anybody can do. But we as anesthesiologists have to develop a skill that we can preempt a cardiac arrest and stop that happening. So with this, I thank you for all your kind attention, and over to Murli.
Hello, thank you. We'll go on to the next talk by Dr. Murli, and the topic is post-brachial plexus wrist drop.
Thank you, ma'am. Just waiting for the slides to come up. So I think Azam finished well within time, so I think the slides are yet to come. So what we'll be doing in the next 10 minutes, and the other announcement that I have to make is Dr. Harshal was unable to make it for his talk. So we will cover the same topic. We will have a discussion amongst myself, Dr. Azam, and Vandana ma'am, and the other chairpersons. And then we will conclude with remarks and comments from the audience. So coming to what I'm going to be speaking about is wrist drop post-brachial plexus block. Now, how many of you here have experienced this? Any patients where you had wrist drop post-block or any kind of upper limb surgery? No. Okay. Now, I'm going to take you through two scenarios. One is what we faced in our practice, and the other one from the literature. So the scenario one here is, it was a 64-year-old lady who came in for a left shoulder rotator cuff repair. Otherwise, I think she had diabetes. Apart from that, no other issues. A superior trunk block was given with 8 ml of 0.5 levobupivacaine, ultrasound guided, with IV Dexona, that is dexamethasone. No paresthesia or pain was noted during the injection, ultrasound guided, clearly seen. No pain for 24 hours, patient was very comfortable. The wrist drop was noticed just before discharge. On the same side, that is around close to 36 hours after the block. Now the surgeon, the patient are anxious, and if something goes wrong, it always means somebody has done something wrong. So who is that somebody? It generally is the anesthetist, right? So we got a call, and then we had to kind of answer, because the block was blamed for the wrist drop. The second scenario, which I'm going to kind of highlight here, is a 34-year-old male for both bones fracture, open reduction and internal fixation. A subclavian perivascular approach was used, supraclavicular that is, which was landmark technique. Paresthesia was noted during insertion, because that's what we tend to do when we do landmark. We tend to see paresthesia. Surgery went on uneventful, just under the block. Wrist drop was noticed post-operatively. Again, the surgeon blames whom? They blame the anesthetist and the block. Now, with this kind of couple of scenarios, we will see how and why this can happen and how we are going to deal with it. So the wrist drop is when there is no movement of the extensors at the forearm, and the patient is unable to extend his hand at the wrist. Now, if you look back to why this happens, it is the radial nerve, which is innervating most of the extensors of the upper limb. As you can see here, it comes down from the level of the axilla, goes in the spiral groove, and then again innervates. So the dark brown is all the muscular branches it is giving. The yellow is the cutaneous. So it innervates most of the extensors of the upper limb. Now, where does it come from? It originates from the posterior cord, and it gets its root values from all the brachial plexus ventral roots. Now, coming to the symptoms of radial nerve injury, it depends on where the radial nerve injury is and the muscles that are affected and the cutaneous distribution. So, if the injury is at the axilla level, you'll have weakness of the entire upper limb, and then the tingling and numbness will be from the back of the arm to the hand. Whereas if it's in the spiral glue, as we note during humeral fractures, there is weakening of the brachioradialis and the muscles of the forearm, and it interferes with the person's ability to bend the wrist back, that is, wrist drop. And if it is a little distal, it mainly causes weakness of the muscles in the forearm and inability to extend one's finger. Now, what happens when there is a nerve injury? Now, this is an excellent flow chart again from the American groups. This is the American guidelines, where we talk about what to do. So, we will take up with neuraxial. Of course, we are not going with neuraxial. But when we go into a peripheral nerve injury, they say that if there is a mild or sensory symptoms, then we just observe, right? And then only if it is severe, then we go on to neurology consultation and further ahead. And also there is mention about EMG and NCS. Now, when we look at neurological injuries or nerve injuries following peripheral nerve blockade, we see that the incidence ranges from anything from, as you can see here in cardiac, of 0.077% to up to 4.3%, especially in shoulder arthroplasty cases. And there is something called persistent neurological symptoms, which again tends to decrease in incidence as the time progresses. So this postoperative neurological symptom, also called PONS, is given an importance that these can occur up to 15% in cases where blocks are given or surgeries take place under blocks, and they are self-resolving. Right? So if it is something which is just persistent paresthesia, we can wait it out. But the mechanisms that go behind what can happen when we give a block is it can be due to needle trauma at the injection site, and also physical stress and ischemia, which can be again related to the surgery, and the role of additives. I'm not going to the details of this because I think that has been dealt in a different lecture. So what do we do now? We have these two scenarios. So how do we go about handling the surgeon, the patient, and finally ourselves? Now, the problem here is the deficit has outlasted the block, right? Both the blocks, deficit has outlasted. In fact, in the first one, we didn't even expect that there will be a radial nerve involvement, but we have a radial nerve involvement. The first thing here to do is communication. Now, the communication here should give importance to the support that you're going to reassure the patient, and also you've got to have a frank chat with the patient and inform the patient as to what's happening, because the patient is quite apprehensive at this point. If there is a pathology that can be corrected, it could be a tight bandage or it could be something like a compartment syndrome which is developing, that should be corrected. The symptoms should be alleviated. Now, the main concern here is that there is a wrist drop, so you have to look at what can be done to alleviate the symptoms. So, if required, we take the support of pharmacological methods, physiotherapy, or even things like splints. And finally, I'm sure all of you will agree that from the medico-legal perspective, documentation should be absolutely firm. So, consenting, the documentation of the block, and also the documentation of the consultations after we know that there is a persistent deficit. Now, how do we go about dealing with this? So now, as I said, we speak to the patient. Now, if there is an ongoing emergent process, that is something which can be corrected, we evaluate it and remove, example, a restrictive cast, or if there's a compartment syndrome. If there's a surgical cause to what is happening as a deficit, then we go about evaluating and dealing with it. And if the deficit is severe, such as what we see in our patients, we seek immediate neurological or neurosurgical consultation. If we saw that it was not severe, then we can probably consider reassuring the patient that it will sort itself out. Now, this is again a very similar approach which has been recommended by the Regional Anaesthesia of the UK Society, and it again goes through the same flow chart. Now, where does an NCS and EMG come? Now, many of you would have heard, okay, let's get a nerve conduction study done. You know, the patient has got a wrist drop. Now, nerve conduction study is done for functional assessment of motor and sensory nerves. whereas an EMG is done to distinguish radiculopathy, plexopathy, and neuropathy, and also to differentiate whether the muscle weakness is either neurogenic or myogenic. So it's very clear. NCS is for nerves and EMG is for differentiating neurogenic or myogenic. Now, the important thing to note here is, in any kind of nerve injury, the sensory neurons are excitable up to 11 days after injury. There is still degeneration has not taken place properly, and motor neurons are excitable up to 7 days. So if you immediately do a nerve conduction study, it will come back as normal. So we have to wait for at least a couple of weeks before we even do an NCS to ascertain whether there is something wrong. So don't jump and kind of do an NCS early, because it will come back as normal. So let's come back to our scenarios. So the first scenario, we had a wrist drop which persisted for 4 weeks. The patient herself was a doctor here, and she refused an NCS or a neurological consult. Now the wrist drop improved and the patient got better, but it always puzzled us. We have done an interscalene block, which is just the C5, C6, just the upper trunk. How did the radial nerve get involved? So we went through a lot of discussions to see how this could have happened, and guess what? It was actually an arm pouch which was very loose, and the patient's arm was resting on the side rails of the bed overnight, and because she did not feel anything, the radial nerve compression took place and the patient developed a wrist drop which resolved in itself. So it was a learning point for us to make sure that when we use arm pouch post-shoulder surgeries, we should be very careful. The second scenario was from this paper which was published in 2016, where they did an NCV and EMG which confirmed radial nerve palsy. They treated the patient with supportive pharmacological and physiotherapy and other splints, and following 3 months, I think the patient recovered completely. So this was about how to manage a wrist drop following brachial plexus block. Thank you.
Okay, thank you. Would you like to just give the scenario? Because I think there is, we are going to talk now about the post-epidural sciatic foot drop. So
Yes,
would you just, kind of...
you can leave it open and we can discuss it.
Yeah.
Okay. So Dr. Harshal is not here. I think he'll be joining us late this evening. Now, the scenario, I think we'll have an audience interaction and we'll discuss.
Bit of audience.
We'll discuss this case. So we have a 45-year-old lady who undergoes a hysterectomy, vaginal hysterectomy, and on the insistence of the surgeon, the anesthetist cites an epidural at L3-4 following a spinal anesthetic. The epidural is activated for post-op analgesia, and the following day, the epidural is working very well, the patient is very comfortable, but they notice that the right side foot, there is a foot drop. So the patient complains that I'm unable to move my right ankle. So this is the scenario. So I would require a couple of volunteers from the audience.
Yes, please, from the audience, to, kind of just, first let's just go and, what will you do first thing when you see this? Yes, sir.
Okay. Sunil Pandya sir has volunteered, and
yes.
I request one fellow or postgraduate to please come forward and join us in the discussion, please.
I recall 2 cases who had foot drop, or rather 3 cases in our practice. And one of the cases, yes, it was an uneventful combined spinal epidural for a myomectomy and postoperatively foot drop, and of course it was related to lithotomy position, and patient recovered spontaneously. It was a sensory and motor deficit, which recovered within 4 to 5 days. So lithotomy position, we know that extended, we need to take care of adequate cushioning of the superficial peroneal nerve, and you can minimize this thing. The second case was an interesting case where a patient had foot drop, and a patient and the surgeon both blamed anesthesiologist, and then we were also little concerned because it was a little multiple attempts were there, it was difficult back. And we got a MRI of the lumbosacral spine and interdorsal spine, everything was normal. And when we did a ENMG after a week or so, it was slightly, the sensory motor element, both were there, the amplitudes were less. And then we did a sciatic mapping from the origin till the knee level. And interestingly, we found that at the level of gluteal sciatic notch, there was inflammation. And when we did a root cause analysis, the intramuscular diclofenac given in the ward was responsible for the foot drop. So basically what I want to highlight is neuraxial techniques by and far are very, very safe provided you take care of precautions. But you need to have a holistic approach to do a root cause analysis, and you can linchpin the cause and do what is appropriate. But importantly, whenever there is a dislocated foot drop, do not allow the foot or the wrist to hang. Always give a splint so that you can minimize the stretch and minimize the nerve damage.
So was there a continuous epidural going for these patients?
Yes, it went on. And the third case, which I said, interestingly, this patient developed foot drop, uneventful combined spinal epidural for again a hysterectomy, abdominal hysterectomy. And interestingly, when we did a root cause analysis, it was the thigh length dead stocking, which was very tight, and it unrolled, and it was compression at the fibular head that was responsible. So after that, we abandoned thigh length stockings. We went for Villoni TED stockings for routinely as a part of anti-DVT prophylaxis. So there are multiple non-neuraxial causes of nerve palsies which you need to consider in your root cause analysis so that you can give the right treatment and the blame game can be minimized. Because patient has got a nerve damage, it could be surgical cause, it could be a patient cause, it could be anesthetic cause, but as a whole, the team has to respond appropriately and do the needful to the patient.
Thank you, sir. Just a note to the console. Can I have my slides back? So, sir, just a question. Now, if the patient has developed the foot drop due to the common peroneal nerve involvement, and if the patient has got an epidural hematoma, which is pressing on, say, the L5 root selectively, I'm not talking about a cauda equina kind of picture, how would you differentiate the common peroneal nerve involvement or the L5 radiculopathy?
Again, see, neuraxial hepatomas, epidural hematomas are not very common, even if the patient, unless the patient is on anticoagulants and other things. But yes, we need to do a mapping right from the thing, and then once you do a mapping, suppose if the patient has sensory motor deficits right from the origin till this thing, then yes, it could be the central cause. Otherwise, suppose if it is just peroneal this thing, usually the thigh part is you don't see any abnormal ENMGs.
Yes,
I think, other thing is, how do we differentiate between a common peroneal nerve and epidural hematoma is very simple. One thing is the loss of anal sphincter tone. If you do a PR, if there is a loss of anal sphincter tone, most of the times, yes.
Or in the bladder involvement.
Yeah. It could be a epidural hematoma. Yes.
And I think Ram, from the chronic pain perspective, Ram might have to say, because we do see patients.
I think at that time, EMG of paraspinal muscles will help, because in a common peroneal nerve involvement, it's most distal. So the EMG of paraspinal muscles will be normal. Whereas in an epidural hematoma, the electromyography of paraspinal will be affected.
And the other important thing here, I would like you to kind of look at this flowchart. Now, if a neuraxial anesthetic has been given and the deficit is limited to unilateral common site of compression, whether it is an ulnar or peroneal, which is what happens, these are the superficial nerves which can get kind of affected. The main thing is to observe for a few days and see if it resolves. If this is not uncertain, that you're uncertain that anything else is involved apart from just these two nerves, then we have to immediately go for emergent spine imaging to rule out an epidural hematoma or anything which needs to be decompressed. And another important thing to note is, if there is just a common peroneal nerve involvement, the foot eversion, I think is, I get confused with this always. If the L5 radiculopathy is involved, the foot inversion is affected. Whereas if it is just a common peroneal nerve, the foot inversion will be intact, because the L5 root is still intact and it is just the nerve which is getting affected. So that's one of the differentiating factors when it comes to... Now, Dr. Amit or Sachin, have you got any other points to add here? Any other comments from the audience? We'd like to just make this more interactive.
Yeah, today afternoon I was just sharing this one case we had. Patient was a elderly gentleman, 80-year-old, and patient had EF of around 20-25%, and he was on clopilate, and 5 days are already gone, and anesthetist thought that probably instead of giving spinal, we'll do it solely on epidural. And it was an uneventful epidural. And then surgery went off well. And later we found that there was decrease, sort of a paraparesis, which was picked up next day. Patient was sort of bedridden with multiple comorbidities. And then we looked at and followed it up, and it's a really very hard task for everyone, because neurosurgeon has a different opinion, neurophysician has different opinion. We did MRI, which showed around 4 to 5 ml in the epidural space, and the neurosurgeon said that this is not going to help. We will not proceed with laminectomy in such an elderly gentleman. And even the neurophysician has a different opinion. And on the top of it, neurosurgeon also has some say. So in that case, you have to have some, you will have to lead, you will have to look at the literature. And we did it. On introspection, we thought probably what we read all those guidelines, we must calculate the GFR with Cockcroft and Gault formula. Most often in elderly gentlemen, octant, nanogeriatric, when they have, say, creatinine of 1, 1.2, 1.5, if you really calculate their GFR, it may be less than 30. So when it is less than 30, we really have to wait longer. So maybe that 5 days interval was not good enough time. We have done spinal, and this foot drop issue, as already Dr. Sunil Pandya has already mentioned, other causes like tight breasts and all that. Another thing which I wish to highlight is whenever there is foot drop and we get a call, we must be very sure that there was no weakness with the common peroneal component pre-op. And that is how it is very important when we have a hip fracture, we must assess the sciatic component, because many a times, and we should know the surgical steps as how the bipolar is fixed, which nerve is getting stretched, and we should have a good pre-op evaluation. If you look into Bruden-Fenuken, the complications of regional anesthesia, then we talk about all those blood conditions, thrombocytosis and sickle cell, and there are many other conditions also, protein CNS deficiency and other things, which we do not elicit that sort of a history, and we need to know very good about. Some patients may also be taking some medications like Chinese herbal medications, or some medications which will have coagulation impact. And then when they are on multiple medications, then again that's an issue. So we need to have a good clinical examination before doing any block, and we should document it. And if possible, if there is any issue with our traumatic multiple attempts, or if we have done a block, if there is swelling of nerve, we should store those images, and we all should do that. So I think what we have learned is we need to look at Cockcroft-Gault formula to look at the GFR. It should not be less than 30. Secondly, pre-op good assessment, talking to the patient. And then how to manage epidural hematoma and clinical, it's a big challenge in itself, and it's a different topic for pro-con. Thank you.
Thanks a lot, Amit. Thank you.
Can I say something, Murli?
Yes, ma'am.
So I was wondering if the patient is on CSE, so how early are we going to diagnose that foot drop? Because generally when we do CSEs, the epidural infusions are sensory blocking, the motor power has returned. That is what we generally see. But is that going to happen in these cases also?
No, ideally, I'm sure Dr. Pandya sir will agree. If there is any kind of epidural infusion running, there should be some kind of monitoring, documentation which should be ongoing. And at any point, if we feel that the deficit is more than what we would expect, say example, one limb they're unable to move, the epidural infusion should be stopped. The patient should be assessed after 4 to 5 hours. And if it has not come back, then it should be taken as a sign of some kind of space occupying lesion. And another thing regarding Amit's thing is spinal stenosis in elderly patients. Now they don't have enough space there. So an epidural catheter, even if there is 5 ml of blood or even 3 ml of blood, can be significant enough for that patient to cause a cauda equina. So I think in elderly patients, that is one catch, especially when it comes to the volume of blood which can cause a deficit.
But in elderly patients, another challenge which we very frequently face is that they are not very mobile. So they will not be manifesting any symptoms of stenosis, because when you ask them, try to calculate their meds, the only answer is they just sit around, they do their routine work and they spread it over the day. So it's very difficult to assess if they are having some element of stenosis.
No, in fact, to answer your question, ma'am, if I do a epidural or a spinal, I find a difficulty in doing a spinal or epidural. Patients on anticoagulants, I tell my resident that we need to keep a watch on this because I have given a multiple pricks. Automatically, I will stop my epidurals. I will not kickstart my epidurals at any given point of time, and neurological assessment will be done no matter what. Yes, sir.
I would like to share three more cases, one from our own experience and two from the literature. One was a gastrectomy case where we had given a thoracic epidural, uneventful single pass, and patient develops paraplegia post-operatively. And as usual, our surgeon writes review anesthesiologist urgently. We saw the patient, definitely yes, there was a paraplegia, but there was a cutoff sensation at the level of L1, L2. And then subsequently, we asked for urgent neurosurgical consult, and there was a metastatic lesion in the L2 vertebra, which led to compression of spinal cord. And thoracic was fortunately at D8, D9, nothing was there. That area was impeccable. So what I mean to say is always assess the patient properly. Be the bedside neurophysician. You need to know the bedside neurological assessment whenever the patient develops any neurological deficit. Two more interesting cases from the literature. One was again a massive retroperitoneal sarcoma with a zip incision, combined general epidural was given. And post-operatively, patient was in epidural infusion for 3 days because of a big incision. And there was a bromage 4 and 5 on 6. And that was acceptable because patient was a low-dose mixture of bupivacaine with fentanyl. And they removed the catheter at the end of 72 hours. But the persistence of deficit, neurological deficit was seen. The paresthesia and numbness was still persisting even after 12 hours. That's when the alerts were elevated, raised, and then they screened the spine. There was no neuraxial hematoma, but they found altered sensitivity of the spinal cord. Ischemia was seen on the MRI. The T2 signals were reduced. And subsequently, again, RCA was done by the team, and they found out that when the vascular retroperitoneal sarcoma was dissected, the surgeon had accidentally ligated arteria magna, which we know that it supplies the spinal cord, and that was a culprit for spinal cord ischemia, and epidural was a silent, benign bystander. So basically, again, a holistic approach, and you need to be well versed with the literature also and the case report so that you can defend yourself, otherwise it may be an issue. There's one more case, a pregnant lady who developed paraplegia again after, in fact, there was no neurological, anesthetic intervention done, but because of the high epidural take rate in that institute, this was in the US, as usual, the referral was given because the patient could not move the legs. And when the anesthetist went and saw the patient, there were no anesthesia notes, there was no labor epidural given to that patient, and they thought probably the anesthetist must not have written or documented. But subsequently, they realized that anesthetic was not given to this patient, but the patient was having paraplegia. She was having a preeclampsia with severe features, and subsequently, when RCA was done, it was the Pritchard regime of Maxself that was followed, and intragluteal Maxself was given. It went intra-arterially, and that caused ischemia of the spinal cord, because in this patient, the arteria magna was arising from the superior gluteal artery. Because we know that arteria magna can arise from anywhere between D12 to L2. So these are all the aberrant anatomy that can happen, and you need to be well versed with the literature. The neurological complications can happen because of regional anesthesia also, but invariably, it is most of the time the surgical causes or non-anesthetic causes that are responsible for neurological complications.
So just one question. Yeah. How does the anesthetist manage the increase in heart rate and blood pressure overnight when they hear this news at 10:30?
It is stressful.
With your experience.
In fact, I can go on and on from our, the vast number of cases. One of the cases was a young patient, ophthalmologist, husband was a general surgeon. The patient could not walk after labor epidural, uneventful delivery. And the patient's husband was a surgeon. He called his friend, who was an orthopedic surgeon. He came, he saw without our advice, he came and wrote in the case sheet Koda-Ikwana syndrome. We could not see, this was one day before our national conference in Hyderabad. And at one day, we are busy with the conference preparation of the World Congress, and this patient was sitting on our head. Ultimately, when we did a proper examination, it was the pelvic diastasis. Patient could not move because of the diastasis of pelvis, and shoulder dystocia was there, and so it was a suppression of pubic rami. It was the nerves were intact. What I mean to say is, all specialist consultation also, it's biased. So you need to have a thorough knowledge about what you do, the neuraxial anatomy and the anatomy of the nerves and musculoskeletal system, so that you can linchpin the diagnosis rightly. Yes, adrenaline surge can be minimized by spirituality and by meditation.
In fact, it's too stressful. On the same note, I think, Murli, there are two cases. One was what Murli said was wrist drop. I had a patient whose husband was a lawyer, quite a big lawyer in Bangalore, and came for a both bone fracture. I said, okay, fine. When I got to know the history, everything, somehow my conscience said, let's give GA, let's not get into block. Yes. I said, okay, fine. Then we gave general anesthesia. Everything went on well. Surgeon comes in, operates, goes off. Post-operative, she develops weakness on the left hand, because left hand is the surgery. Post-surgery, after a day, develops weakness. Surgeon tells, don't worry, it is because the anesthetist has given a block, that is the reason. I knew, with due respect, you should know who you're operating with, right? That's more important. And I said, sorry, sir. Then they suddenly, usually, as Murli says, tachycardia, everything happens to us, but it was happening to him. This was one case. The second case, I don't think TVS sir is here. Anyways, 2007 was the first ultrasound-guided workshop in Hyderabad. So I was there because we were doing a lot of vascular surgeries then with low ejection fraction. So I wanted to learn popliteal sciatic nerve block where I can do transmetatarsal amputations, all this. I said, okay, fine. Went, learned, and we had a vascular GE machine. I said, yes, now I know how to do popliteal sciatic. I went to that conference only to learn popliteal sciatic nerve block. I said, I'm not going to get into any of this. All 5 rounds, I was with the popliteal sciatic nerve block. So I learned that, came home, came to my hospital, gave a popliteal sciatic nerve block. It worked beautifully. Patient diabetic, hypertension, ISD, fantastic, and I felt, wow, now this is the way out. I'm not going to leave my ultrasound-guided nerve block. I don't know what, it was GE machine. I'm doing it for the first time in my life. After 3 days, the vascular surgeon calls me and says, Azam, just see, he has developed a foot drop. I said, oh, that is a time. I think Dr. Sudhakar Koppad was my, head now. So we had a discussion saying, patient developed foot drop, sir. I gave a block. I don't know. I told myself that, okay, definitely I've injured something because it was my first time. Later, I get to understand, after reading a lot of literatures and things like that, I had used adrenaline, lignocaine with adrenaline. And that took, because sciatic nerve also has intraneural arterioles which had gone into spasm, and that took longer duration to come out. When I visit the ward, the lady is sitting near the leg of the patient and she's crying. I said, what did you do? I came for some other problem, now he's not even able to go to the bathroom. Then everybody pounding and seeing at me and saying, what happened, what have this fellow done? So came boldly and said, don't worry, nothing is going to happen. 3 days is done now, another 2 days we'll wait and it will become all right. Thank God he recovered, that's a different issue, but these are the take-home messages that you need to be careful when you're having diabetic patients when you're...
Ma'am, thanks a lot. I think we have...
Thank you very much. Yeah, that was a great
discussion.
And Dr. Mutha, you want to add anything?
In fact, the previous session is also open to discussion if anyone wants to ask anything. The one where we were talking about patient safety, audits, and should we need to know POCUS? Yeah, all 3 of them.
Anybody else doing these audits in their hospital?
Yeah, we are doing. Yeah, ma'am.
But means anesthesia related, everything. Because NABH is doing some audits, but they don't get, any preference for departments. They just do quality indicators and stuff like that.
In fact, I'm sure Sunil sir will agree. I think if proactively every person here starts doing audit, not only will your practice improve, but also the management will be very happy, because when the NABH people come, you already have 4 or 5 audits ready. So that is something
Let's not contribute to Dr. Pandya's app.
Yeah, that's a great idea, actually, yes.
Ma'am, anything from your side with regards to medico-legal with what we have discussed so far? A couple of points.
I'm going to do that tomorrow.
Tomorrow, okay.
You have to come for my lecture.
Thank you so much, ma'am, for giving us an opportunity. Thank you so much.
Thank you, thank you.
It was a very good session. I think so everybody learned a lot. I would request everybody to stand up for the national anthem.
Just an announcement. The dinner will be served at the same place as the lunch for all the delegates. After 7:30.
Please do join us for the plenary tomorrow morning at 8 a.m. in the same hall. Yes, please do come.